Well, first of all, I'd like to say good morning to everybody, and thank you so much for coming out and joining us today. This is our 2025 ANIA Fall Conference, Informatics Powering Quality Across the Continuum of Care. Raise your hand if this is your first ANIA conference. I know I see a lot of familiar faces, but I see some new ones. Oh, awesome. Well, welcome. Okay, keep your hands up. Keep your hands up. Oh, here we go. Dan's coming around with some stuff.
You get some swag.
Here's Oprah coming around. Awesome. Well, you are in for a special treat today. I'm so very excited. This is my favorite time of year, the ANIA conference. So it is an honor to be here with all of my colleagues, friends, and of course, all of our leaders in nursing here today. First, I want to extend a heartfelt thank you to our planning committee and our tech committee who worked so hard to bring this event together. Your efforts really behind the scenes today is what makes everything possible. Next, I would like to extend a thank you to the Jefferson School of Nursing for their partnership and support in hosting us. This is a beautiful facility. College of Nursing. This is such a beautiful campus, and thank you so much for allowing us in your space today. So with that being said, I look forward to, of course, an inspiring day of learning and networking and getting to know each and every one of you. If you have any questions at all, please feel free to ask myself, anyone. Most of the people at the front table here are helping on the planning committee, the tech committee. So we're all very happy to help you with anything you may need today. Enjoy, the food across the hall here, where the restrooms are. If you have any questions, like I said, let us know. Otherwise, thank you so much again for being here today. And I'm going to hand it over quickly to Lori to read our CE statement.
Nope, I just want to let you know when we're using that mic, just keep it far away because it's very loud. Yeah.
Sounds good. Thank you.
Yep. Yeah. Here.
How's that? Is that good?
That's actually perfect.
Okay, great. So I'm Lori. I am the president-elect for GDV ANIA this year. And I was in charge of getting the continuing education credits for this event today. So you'll be getting 6 credits, but I have to read the approval statement and the disclosure so that we can make those legal. So the approval statement is, this nursing continuing professional development activity was approved by the American Association of Critical Care Nurses, an accredited approver by the American Nurses Credentialing Center's Commission on Accreditation. Learner requirements to receive contact hours are: learners must attend the entire conference, including the question and answer portion at the end of each lecture. Learners must complete a post-test, which is your evaluation. And then learners must complete an evaluation form. So I have questions in the evaluation form that count as the post-test. And disclosure of financial relationship between planners, faculty, etc., with ineligible companies are: there are no relevant financial relationships identified for any individuals with the ability to control content of this activity. There you go.
Wonderful.
All right. And now we have.
Yep, we're going to pass it on to Dory, who's going to introduce our first speaker.
Oh.
Hi, Tiff.
Good morning, everyone.
Good morning.
Good morning. Do a wave. Let's do the wave. All right. I'm Dory Nation, and it's a pleasure to introduce our keynote speaker, Dr. Anna Schoenbaum. She is the Vice President and Chief Digital Applications Officer at Penn Medicine, University of Pennsylvania Health System. With more than 30 years of healthcare experience that began at the bedside as a pediatric intensive care nurse. She leads transformative and digital initiatives that reimagine, hold on to that word, reimagine the health ecosystem, advancing population health, enriching the patient experience, and supporting clinician well-being and driving research. A national thought leader, Dr. Schoenbaum co-chairs the HIMSS Innovation Advisory Nursing Group, shaping informatics strategies, guiding healthcare innovation efforts. She also serves on a nursing informatic advisory board and as an adjunct faculty at the School of Nursing, Maryland University, where she's mentoring the next generation of nurse leaders. A published author, recognized expert in health IT, she integrates research into her work to evaluate emerging technologies, assess AI adoption strategies, and examine the long-term impact of innovation on clinical practice and health equity. She received the 2023 HIMSS Caremaker in Nursing Informatics Award and was inducted into the American Nursing Academy in 2024. Please join me in welcoming to the stage our keynote speaker. Dr. Get this on a little bit here. Oh, I guess I'll hold it. I think it'll be easier. Good morning. We are standing at the inflection point of healthcare. The changes are never been any faster, and the pressure has never been any greater. Patients expect more, clinicians are stretched thin, and technology is changing every corner of our work. The question before us is not whether we adapt, but how do we meet this moment? Again, my name is Anna Schoenbaum, and I'm delighted to be here today to be invited as your keynote speaker. I know many colleagues here, so as well as I know that some of our colleagues are also joining via Zoom, so glad to be here. And I just wanted to call out the title of your conference. What a powerful title for your conference. Informatics, powering quality across the continuum. I think that's really important. So I want you to think about the title today, but as you take away from this conference. I'm tackling 2 slides here. Okay. So the objectives, it's pretty simple. I want to make sure that you take some nuggets away, not just for your informatics community, not for just your professional aspirations, but also you personally. So hopefully you take some nuggets for each sector. But we'll emphasize on leadership, on how you can influence leaders and how you are a leader. I'll present some strategies of how to implement and how you think about coordinated care, data-driven care, and then the use of some innovation for today and for tomorrow. Oh, I should say, Doreen asked me to do this presentation and it's long. It's about, I think she gave me 90 minutes. So I wanted to jazz this up. Like we got to jazz it up. Okay. Anybody talk about jazz hands? Okay. When you do jazz hands, you smile and it feels good. So if you see something that you really like, I want you to do some jazz hands throughout the okay. What about Penn Medicine? Jazz hands, right? Great, especially all my Penn Medicine colleagues. Penn Medicine, I am so honored to be a part of this organization. We're a hospital of many firsts, first in the country of hospitals, but also the first medical school. And so I represent Penn Medicine, and they're so innovative and first in many research. But also we've been trying to change our culture into innovation and being more at the early front. And we'll be talking about some of that as well. Understand the healthcare landscape. I want to talk about, just begin with my own journey. I started out as a pediatric nurse at Eccleston Hospital in Atlanta. And that picture I think they used for the School of Nursing there, even though, and I liked what the title said, Tradition of Caring, because really that's the foundation. This is a picture of me in a pediatric ICU at UNC Hospital. And we're doing a magic show for a patient that is on a dobutamine drip. But we were at the corner of the very back room, but we're doing a magic show for the staff. And it was a great day. It was a great day. But the thing that took away when I was a nurse in my younger years, two things I carried away. Is that I really love nursing and I love patient care. But it was not about just the patient, it was a family unit. And it's really across the spectrum. And so I take that as two things that I do in my job every day, is think about the patient and think about the spectrum. But I've added a third, and that is clinician wellness. That is really important because of all the technology, we're overburdened with so much technology. But that is how I really work in my current role, is to think about that as I make decisions. So I'm going to talk about one patient that really changed my life and one moment. This is Keely. She's at this picture, she's 12 years old. And I was at University of Maryland at CNO council meeting and got a text, and it said, from my friend, Keely's really sick, please come. I need you to come. Or can you come now? Can you come now? That's it. And so CNO meeting got done fairly quickly, and I'm just texting back. What is going on? You're like, where do you want me to come? You know, just let me know. Because I knew that the night before or the day before she was sick, because her mom and I were supposed to start our first training run for the Disney Marathon so we could take our senior boys to Disney while we ran the Disney World Marathon. And she decided she couldn't do it because Keely had a headache. So finally, after so much testing, a friend called on the phone and called me and said, hey, go to Hopkins and meet them there. So ran back to my office, which was, I had to get in the car, and my staff came out and brought me my coat and my laptop and everything, because I didn't take it to the meeting downtown. And I grabbed my laptop and my coat and met them at the hospital. She coded 3 times that day, and it was a severe infection, and she had a significant brain injury and had stroke. So Keely's now a quadriplegic, and she is vent dependent. But every day in my decision, and every just day, I think about Keely and the impact that healthcare has on her life and her family life. It's really saddened that the nurses don't show up sometimes, or she doesn't at home. And they just really struggle just navigating through healthcare. So I think about that. She shares with me a little bit, the mom and Keely, but she's driving, but she's independent and a quadriplegic. But I do think about them as we're designing rooms, as we're designing or thinking about pop health, value base. I do think about this one patient, one moment. So with Keely's story, it reminds me of just the current landscape that she and her family have to navigate. So what does that healthcare landscape look like? Well, we have an aging population. We have a workforce shortage. It's under strain. It might be getting better. I think the nursing recruitment and retention is getting better, but we're not out of the woods. I think they're still really high of first-year nursing turnover. People come in for 1 year and they're leaving the jobs. But we've got to keep those younger nurses We need them, patients need them. We have just, regarding medication or patients taking medications, coming back into the hospital readmission, the aging population, the labor costs, provider burnout, nurses burnout. It's just really challenging at this time. And even this week, there's a lot of uncertainty regarding reimbursement and financial pressure. So how do we navigate and how do we lessen the burden of our providers, but also make sure that our patients are taken care of? With that, we do have some relief. We do have some technology, and here's just a visual regarding how the technology has evolved. It's gone at a rapid pace, and it's been very steady. But today, technology is taking leaps into it's not linear anymore. It's really exponential and really making a difference. But we got to be smart and selecting the right technology. So how do we harness this rapid evolution, especially in the world of artificial intelligence, and to study the lives and how it impacts our clinicians? So let's just talk about the introductions of AI in healthcare. AI evolution in healthcare. We know, based on some early studies, and hopefully some of you have been involved in some of these studies, that it has made a change, and people have proven that there is a place for artificial intelligence on the patient side as well as the clinician. It is everywhere. It's at the conferences, it's at the boardrooms, and there's a lot of pressures from our healthcare leaders to get it in fast. I don't know if you feel the pressure, but there's a lot of pressures. There's a lot of urgency in the healthcare, and it's across the country. And I think it's across the world here too. But there are concerns from the patient regarding privacy, data access, and just sharing of information, and we can't take that lightly. There's also concerns from staff. We're doing ambient technology, and we said we wanted to start, listening to the recordings and saving it. And there's concerns even some from providers that are using it and say, oh, I don't know. Sometimes I talk about things that are more personal for the patient that's maybe not going into the record, or maybe I'm talking about my personal life to the patient, kind of sharing something. And are you guys going to hear that? So there's also concerns from staff. Financial implications, there are some cost savings, but there are costs, if you're not careful, there are, costs that may be, I guess, unintended consequences. So there are startups that are already going out of business. A couple of weeks ago, we had a imaging AI company, more of a middleware. They are de-invested, so we got to take it out. So that's no longer there. So there's a lot of startups that are flourishing, but there are some startups that are already pulling out of the market. And just really the importance of healthcare is just, where are the patients, where is the human, and keeping the human in the loop. So let's just begin with a little bit of foundation regarding artificial intelligence. And I'm just not going to spend too much time on it, but just sending the foundation regarding where is artificial intelligence. And it's the big umbrella that seeks to create intelligent machines that can replicate and exceed human intelligence. And it's getting stronger and better as we speak. But it's been here since the 1950s. Machine learning started about in the 1997. And it is where machines to learn from existing data and to improve upon data to make decisions and predictions. And I think Joy's going to be talking about some clinical decision support later today. Deep learning is a machine learning techniques in layers of neural networks and are used to process data and make decisions. So think about the year here, 2017. And then in 2021, right after the pandemic, you heard a lot about generative AI, and that is create new written and visual auditory content. Who uses ChatGPT these days? Who used it yesterday? Who uses it on the weekend? So Do you do it personally and professionally? So I do a lot, I do it for my emails and professionally. This weekend, I looked up what are the top wakeboarding boats? Because my husband's like looking for we were looking for a surfing boat. And I was like, I don't know about boats, but they're just too expensive. But I just wanted to make sure we invested in the right kind of boat. But I even use it for that. Or, if I go to a foreign country, I do look up, are there any road races that this weekend to see if I can jump into maybe a race or a walk or something like that. So a couple concepts, and I just wanted to show this is on here. I do have natural language processing, but this is just a visual, how everything kind of intersects or kind of from an umbrella standpoint, because really this is our world, because any kind of technology you invest today has a little bit of AI, but you do have to be careful because everybody says that they have AI. So look under the hood and ask about these AIs and how they're getting the AIs, and some will share how they're getting it, but a lot of it is intellectual property. So, but you do need to ask of what it is. So I just wanted to talk about a little bit between generative AI and agentic. And you'll see some of this terminology probably go and fade, such as prompt engineering. I think I listened to a Google talk the other day, and I laughed because I'd listened to some nerdy things when I go on a run. And so I was listening to the acquired Google Talk podcast, and they were talking about just terminology, and they said, prompt engineering is probably going to go, but agent AI or agentic AI is going to stay. So I thought we're doing a lot about agentic AI, because as we're getting the data from multiple sources, it's making goal-oriented decision-making in action. So who drives a Tesla, right? So nobody drives a Tesla. Who drives the Rivian, right? But who drives it? What do you call those? EVs. Is that right? It's what's called EVs. Yeah. So those are really prevalent. I haven't tried the auto drive on our new truck lately. I just didn't even know how to start the car until I got in it. I've driven it once, but which is absolutely funny. But it just really can take a mind and take decision after decision by taking in the road, taking in what's ahead, the directions, and sometimes what's even happening in the car. But it can make multiple agent kind of making decision, and it doesn't really need a lot of human oversight. So how is it proven, and how's the research on ChatGPT throughout the time? And I have the study on ChatGPT 4 and 5 in here. But here is a study from China, and they did a research from a whole bunch of different categories of learning. And you can just see the gradual upswing of how it's improved over time. And so it is improving. It's getting better. Even your ChatGPT, even for your emails or your, if you're using Copilot, it has improved with every upgrade. This is another one, but how is it you're just talking about from an emotional standpoint, and is it empathetic? And this is a study from Stanford, and pretty impressive. So in this study, out of 585 evaluations, evaluators preferred the chatbot response. Okay. And so, was it because it was longer? Physicians' response was shorter. The chatbot was a little longer. Now, in our ambient study, it was interesting for our providers that we published in JAMA, is that our notes were longer. And we said, well, God, does it mean that it's no blurred, or does it mean better quality? And we were studying that right now. But when we talked to practices at Lancaster, they said that the nurses are happier and the patients are calling less because they think that their instructions are a lot more thorough. So like it could be just full circle, but we were trying to study that because it's that better quality. But here it says for the chatbot, it did rate higher quality. And then it was also more empathetic is what they thought. So anyway, I thought that was a pretty profound study, and it was interesting. I pulled this from my colleague that presented the study, but he also did another one. And there was an algorithm that they studied regarding just how people make decisions, and they did a real life decisions regarding just palliative care and the life regarding a feeding tube discussion, or whether you chose the feeding tube path, or do you just let the patient, just go, travel, I guess, in the death a little bit differently road. And they said this at a HIMSS conference that right before I talked, and a week before we had to make the same decision for my father. And I was like, oh my gosh, every path and every decision that the artificial intelligence was that every decision milestone that was done with our provider. And we chose the other path. And he ended his life a lot sooner. The more please play. So here's the study on ChatGPT 5. And this is a study by Emory. Recent study, and this is great because people are publishing so quickly, and this is a Department of Radiology on the oncology space, and they looked at different categories from a medical reasoning. And look at this. Their reasoning increased from ChatGPT 4 to ChatGPT 5. It increasingly increased from reasoning to understanding. So people are studying, and it is making a difference in certain sectors of our care. So for us as informatics, it's to understand the landscape, understand what your clinicians are going through, as well as your patient. And with leadership, you got to leverage the right technology at the right time. And then innovation to understand trends and strategies of deployment and sustainment. And we're going to talk about that today. So meeting the moment requires leadership and inspires team to change. We need to guide the teams through digital transformation with clear vision and purpose. Use technology to support clinicians and to reduce workflow burden. That's what I think that's really important, is don't add those clicks, but do count those clicks and reduce them. And we want it to be data-driven decisions, and then to make sure they're accountable. Okay. So I want to ask this group, are you a leader in your organization in their transformation journey? Jesse? Yes. Great. So in that, where do you fit in the transformational journey? Who's a decision maker? Great. Who is an influencer? Everybody should be. So you can do that in the informatics community. You can do that within your organization. And you, as a consumer, can also do that, right? Who's an implementer here? Who's on the implementation side? Okay. Researcher? Do we have any data scientists here? Anybody research? Okay. Who participates in research? Who wants to participate in research? I hope everybody does. Think about that. Not as many hands raising in research. Really, literally, if you're part of the implementation, get those metrics, get a baseline, and get and work with the team to get metrics, because you really want to. If you're implementer, you should be measuring adoption. And write it up. There's a lot of people from the different health systems here. Maybe you could collaborate For every one of my ambient technology implementation, we have a research team that's tied to it. It makes our job easier because we have some experts that's leading that arm, but they're working closely with us. But when we have the data to say it's up or down, we're like, oh my gosh, we got to do more. So, think about that, but it doesn't mean that you have to have a research team. But if you have the data and just look at it, but you may want to get some guidance from a statistician or maybe partner with somebody at the school. Who is on the data analytics and report writer side? Great, a few people. Then we have, how about the application analyst side? Okay, great. And who uses the system? Who's on the bedside and use the system? Wonderful. Very important. And we all should be consumers. So who are more than two of these? Everybody should be two. Great. How about three? Okay. So just think about where you fit. And I just, from a personal and professional, it's just, where are you now? But where do you want to be in 5 years? So think about that, because maybe if you think about where you want to go, maybe it's that research piece that you want to tie it in, or you want to publish, or you want to speak. Just think about that as a possibility.
And there are people in the chat that are also doing class as well.
Absolutely.
So there are
Right. And so that's why I said jazz hands, because we can't, I don't know about thumbs up here, and so that's wonderful. So yeah. So the opportunity for technology in healthcare is really on this whole circle here. Think about, because nurses are the best here, is about advancing health equity. You guys are the best at leading those efforts. Enhancing patient experience. We are the best at advocating for our patients. Right? You're there beside them. You understand what patients are going through, what families are going through. So you'll know what technology might be able to enhance. Addressing worker burnout, different. You should talk to your first year nurses, as well as maybe some of your senior nurses that are thinking about, I might leave the bedside. I was walking out of a UGM session, and it was about cool stuff ahead. And I heard a nurse talking to somebody and said, it makes me want to go back to the bedside because all this cool stuff. Like, I thought that is the best thing. I do know that when we're doing implemented nurse triage, so we're doing a pilot, a development study with Microsoft in the ambulatory nursing space, first in the country, in the ambulatory space. And the nurse is like, oh, I'm not sure if I'm going to retire. This is really making my work better. Like, those are making a difference. That's changing our work, lowering the cognitive burden. Lower costs. You've done some of the studies. There's a lot there of how to reduce costs, and then just really improving pop health. There's a lot of different AI coming up with just reminders for health maintenance, or just pulling in payer data. Again, this is about the theme for here, across the continuum and the opportunities. So you got to think about, and this is what I think about, is the interoperability of data when I think about decisions. It's pre-visits, hospital visit, ambulatory visits, and home care visits. It's just, how is that data going across? How's that technology going across? I think that is really key, because you want to invest in the right things. Okay. So how are nurses feeling about this? Have y'all seen this study? This is a study that was done by McKinsey and ANA, and they polled 7,200 nurses. So how are nurses thinking about this? Well, they're cautiously optimistic, enthusiastic about AI. 20% of nurse shifts could be free, if they think, through technology. Think about that. And 64% wanting to see more AI incorporated into their workflow. And there were many around the table that were eager to participate in this AI development. But they also stress it's really important that they did not want to sacrifice high quality care. That's so important. Okay, that's where nurses need to be involved. So how do you begin? And this is the very first thing, whether it's AI or just regular technology or even changing workflow, and doesn't always have to involve technology. So you can apply this. And there's going to be several of these little tidbits here, and these are available on the HIMSS Nursing Innovation website. And this is one of the slides. Several of my slides are going to be that, and the resources. And some of the AI pieces that I talked about, we have a training deck for AI, and that is for you. And you can pull the slides for your colleagues and for you, and you can modify it. But we do have some AI PowerPoint, as well as this and several other tools there. But here is about the 5 rights of AI in healthcare, and it can be applied to really anything. It's just understanding the problem, right? Or the opportunities and how technology, and you think, gosh, everybody asks that. I don't know, sometimes you come back from a conference and Dr. So-and-so said, I really want this. And you're like, well, what problem are you trying to solve? And once you drill down, it's maybe a miscommunication, maybe it's training, and it really is maybe not the technology. Then just the right approach. Do you change workflow? Do you introduce new technology, or do you do both? But it's just what is the right approach. And then just the right competency regarding, does the project team have the right competency? Do you need to augment it? What's the competency also about leaders who are trying to understand AI? But it's just making sure that we pick the right solution that's not biased, that has been studied, and are going in the right direction that you want the organization. And then this is maybe the hardest part, is getting the right data. So if you work for a 54 hospital health system, is you define data the same way so that you can leverage the same tools across the board on an equal fashion. But, the harmonization and standardization, I think, do you have, I don't know, so many different rows or different ways you capture, pulse oximetry from different machines, and it's all going to the same, is it the same data that's being used? Or is it only some of them are being pulled? And then do you have the just the safeguards in place? People implement, and they may walk away, but do you monitor? How do you do your change control? What are you asking? Do you, is it fair? Is it accurate? Is it inclusive? But the last part is, how are you monitoring? Do you monitor daily? Do you monitor weekly? Do you monitor with every upgrade? And then just sustainability. If you're going to monitor, do you have a team to monitor? Whose responsibility is that?
Yeah.
Yes.
One of my favorite analogies is, in our world, we plant a lot of trees. We don't always go back and rake up the leaves or prune the trees.
Yes.
So I feel like that is a big piece that we do so much in preparation and planning,
Yes.
go live, immediate support, and then we are forged on to the next project. So we don't always go back and really do a good job of that, I think.
I would agree with that. Absolutely. That's a great statement. And really is you pile on, and you need to also get the best investment from, and by pruning those trees, and it will blossom. Here, just quickly, because I want to get to the other slides too. This is about industry trends. So if you're healthcare leaders or yourself wanted to think about what are the trends of other healthcare systems. This is from 2024. We do it on an annual basis, but this is what your peers are looking at from what technology are being implemented in some of the healthcare health sites. Might be a good thing. Here is a screenshot of just different technology in different categories, but it's doing the research and see what's out there in what area, because there are, I think, there were like 3 ambient listening vendors, and now there's like over 100. You're just figuring out and doing some research and making sure that everybody has the right information as you're doing system selection. Here's another one regarding, this one's from Gartner. And the very bottom is really what are the things that are being done now, but also along the way. So it goes from, I don't know if this works. Let's see. But at the very bottom is the 1 to 3 years. Then it goes to 3 to 6 years and 6 to 8 and then 8+. But it talks about how things are being implemented and what people are thinking about over the next several years here. So as we explore the landscape and examine leadership and understand the problem and reviewed industry trends, now it's time to talk about strategy, insights into action. So we can have adoption, we can implement, and we can have sustained impact. So it might be you have to change culture, and we're doing that at Penn Medicine. We're very been kind of conservative, but with AI and all that pressure and everybody wanting it, and from and some urgency, we're going from sequential to iterative thinking. Not for everything. When we were implementing over at Doletown, we're doing the same waterfall life cycle implementation, right? But here, for some of the AI, we're going a little faster. We're doing more agile methodology. We're doing from silos to more cross-functional. We got to bring everybody to the table at the same time to work on this. And because you just want to go faster and you want to have the right skill set. And we're also going from risk avoidance to controlled experimentation. It's to try it, to think about it. If it doesn't work, it goes on the shelf. But we just want to make sure, and I'll talk about our methodology. And then we go from project focus to product outcomes, understanding the problem. Constance went like that. So strategy consideration. Find those metrics up front, get a baseline for the initiatives. Make sure when you're collecting those are interoperability, that's your expectation, and it should be. Standardization, and that is a lot harder than we think. And maybe standardization is just really has a bad connotation. Maybe it's more harmonization or alignment. And then an implementation framework. It depends on what you implement, but really you got to teach. And if you're changing culture, is that methodology and that fast pace. Just a couple of things regarding if you want to measure, is to measure qualitative and quantitative outcomes. Do that at the beginning of the project. If you can get baseline, great. But you want to make sure that you're, how does success look like? You should ask. You should ask your CNO, what does success look like after you implement this? Provider, patients, but you should ask. So also is to make sure you involve the key stakeholders and central hub. And to have groups, but to have on the right side is a health IT group, and make sure everybody's in alignment so you can start at the right time and at the right speed here. But on the left side is to make sure you engage your operational stakeholders, and to make sure if they're participating in a development, is that, hey, you're participating in development. We need feedback. You're part of the feedback. You also have to say, this is not prime time. We are participating in this early phases as an early adopter. And you have to sometimes remind them because it's a privilege to be an early adopter, but it's not going to be perfect. And you're engaged in a vendor to provide that feedback. I always have to remind people. Here's our just from idea to implementation, how we're scoping our AI project. Again, understanding and look for the opportunities, promoting safe, reliable workflows, rapid execution, define the metrics, making sure that it's fair throughout, and then just looking at total cost of ownership and return on investment. And really what we want to do is just really elevate the role of the patient and clinician, and that's how we define success. So in order to run fast, we also need a hub of somebody that's orchestrating. So we did hire somebody in the middle to help coordinate because it's just coming fast and furious. And so it's their responsibility to just coordinate and communicate for the implementation. So just wanted to share, not everybody's in Epic Hospital here. I don't know, but this is what we engage in the Epic Launchpad. Found out on Thursday at the National Hymns, and we started on that Monday. So talking about fast pace, but we had to do this because we wanted to be part of the community that was launching this, the generative AI package that Epic had to offer, because we wanted to be with the community to learn from them, for them to learn from us, but also and then to have Epic at our side. And so we implemented. These are the starter kits, but then we added some additional ones. And then we jumped in March 10th, few days later, I mean, from a Thursday to a Monday. And we completed 8 out of the 9. And within the first week, at the 3rd week, we implemented 1. And within the 6th week, we had implemented 5. Okay, we changed culture. So this is our development cycle here. We have alpha, pre-alpha, and that's the unit testing within the team to make sure things work and with the vendor back and forth. Then we have an alpha set. And so this is where we really partner with our informatics team and a small group of just clinicians. Maybe, it could be 10, it could be a little bit more, but we just say, hey, is this worth it? Do a quick survey and say thumbs up, thumbs down. Then we open it up to, after the survey, if it looks like it has some promise, it goes to beta, which may open it up to a larger audience, not to the enterprise, but a larger audience. And then if it's really good, after the survey, it goes to general availability. Very much a product development cycle. So with that, we need to have an AI governance focus. And these are some slides that we shared at Epic UGM in our talk. And just regarding governance, don't over redesign your AI. Use what you have existing. Maybe there needs to be an AI governance that looks, but our AI governance is asynchronous. Unless they need to have a conversation, but they fill out a form. Just say, it's good to say, maybe get some more information, but it really is at the work stream. So the focus area that says this AI tool will be good for our ambulatory providers or to our ED physicians or ED nurses. And that's how we go about adding AI into our production environment. But we want to make sure that it's clinical and operation validation. We want to make sure that we're thinking about our product and our service rationalization. Intellectual property rights, we need to consider whether it's ours or a vendor. And then we just want to always make sure, and we look at this very closely, it's just data rights, privacy and security and compliance. We look at methods and technical review, and then we look to make sure that it's the fairness and the bias in our AI governance here. Here's just a little governance review process, and we're trying to just simplify. Most of our aspiration goal is anytime we make a change or a change request is to stop shop. And so sometimes it works, sometimes it needs to go through more, but that's our aspirational goal. But we look at it from a different risk category, whether it's a low risk or just high unknown, and just follow the process and just manage the risk. So there's some things that is acceptable and there's some things that is a no-go, right? If a vendor doesn't have certain aspects, it won't get done. And there's a little bit slightly different path, but we want the research to follow similar paths as our whole governance cycle here. What we've done is we just wanted to create a culture as well as a environment for experimentation. And so it's just to make sure that we have testing environments, integration, have the right data to do this. but it really doesn't necessarily work until it gets to real production data in most of the workflows for some of this. So if you're trying to do chart summarization, it's hard in a testing environment if you don't have real life data. So it's that one or two clinicians or maybe a handful of clinicians that really we turn it on just for them so that they can just use it, whether it's in parallel or is, they just use it. So I talked to a director of radiology this week, and she is testing our custom searchable AI tool. And she is using, I think, an Epic tool at the same time, just to see the difference. But you can't ask for better than that, is that somebody's engaged and trying to use the different tools to see what works when she's taking care of patients in real time. Systematic monitoring, and then just really our goal is to just simplify the process. Okay. So this is, with the team that I manage over the clinical application, and just this is how I think about how we do our work, is that got to look at the whole spectrum and got to look at all the pieces, whether it's all the systems that are utilized. It's not just the EHR that we need to be at the forefront. It's all the third-party solutions that might be feeding, but we need to understand what the clinicians are using. Found out this week, probably shouldn't be sharing this, that some of our rehab practices have 7 different standalone rehab systems. Little hard, right? So should we just have one? And should we have the same interfaces, right? That's system rationalization, but you got to understand the workflows. Key performance indicators, education training, revenue, how it impacts revenue, continuum of care, and I should say maybe financial health instead of revenue, clinical workflows all across the spectrum. But then all these other things are important. In the middle is cybersecurity, infrastructure, communication, just governance. All that is just continual, no matter what setting, and then the patient workflow. But this is really what I expect of the application team, is that they need to understand the whole unit. Thank you, Constance. Okay, let's talk about innovation. This is the fun part. And it's a critical moment that we're here as leaders to make decisions on the technology that will shape our future. And these implementations aren't necessarily inexpensive, even though there's a lot of startup companies that will talk to leaders about free development, free trials, but it takes resources from contracts, from cybersecurity, from application, from informatics, from data scientists. Even though it may be free, there is a cost to those low-cost AI startup companies. Just have to think about, is it meaningful for your organization to embark? But you just need to make sure that that AI works with those 5 whys. Does it align with your strategy and the problem you're trying to solve? And really, with that, how do we meet the moment for tomorrow? Patient care has really shifted. It's the Amazon, if I'm a patient, I kind of want that Amazon healthcare, and people are wanting it at the right time in the right place. So as you're looking at digital solutions regarding these technology, you just need to look at, they want easy access, they want seamless care experience, they want to navigate support easily and it just be intuitive, and then they also want it personalized. Again, we want to make sure that our technology goes across the spectrum. And then think about, how is adoption going to go here as you select the technology? So this is from Gartner here regarding just the innovation triggers. So when it's a great technology for the first month, it may be really spiking high. And then people get used to it, and sometimes they get disillusioned or they get too busy and they stop using it. And then it goes back up for a little bit more engagement, and then it plateaus. It's really important. If you want a new study, It's really important to see where people will end up. We're doing that with all our new technology right now, especially in the ambient space. And just to see regarding just how are people adopting and people are plateauing. I haven't looked at it, but our vendor tells us that we have 70% adoption for our ambient scribes in the provider space. I think that's pretty good because I think for other people it's like in the 30s. So just wanted to share a couple of slides here regarding this is, if you can see close enough, just where maybe if you're working on a certain technology, see where it lands in this the hype cycle here for digital technology. Somebody yell out something that they're doing. Let's see if it's on here. What is anybody working on virtual nursing? Anybody doing virtual nursing? So right here is at the top of this right now. Ambience for intelligence for health is right here. Down here is EHR for virtual care. But anyway, it just kind of sees just where is your innovation in the hype cycle as you're implementing. Here is the hype cycle for AI. All of it is right there up on top. So that's probably the urgency that we're feeling as leaders are saying, can you implement this? Can you implement that to get a faster impact? So the couple of potential use cases in this innovation space. Here, just I put some into categories regarding how AI may impact clinicians, where it may impact patients, and then administrative and operations. So let's talk about patient-centric care. I pulled out just a few. So what does it look like today? And you may not be there, but it may be on your roadmap. It's a reactive tool for some things that you may have in place. It's more reactive, following up on patients. Some may have virtual assistants and chatbot incorporated into the patient portal, or you may be working on it. And you may have 24/7 support for triage, appointment scheduling, and common health questions. You may be there. But what does this look like tomorrow? So it's more proactive. It's going to start incorporating, but it may incorporate what you do on Amazon and what you search for, as well as a virtual assistants and chatbot. And maybe if you want to be on, and maybe I need, maybe it's that if I want to train for a race, or maybe I'm on a diet, is that you could have a virtual assistant helping you along the way. Just reminder in appointments, medication adherence, nutrition intake, and coaching. Or you could have Joy to text you and say, I just ran 18 miles today. So today is for precision health. There's a lot of work here, and this is really, I think, the exciting place regarding where healthcare is going to go. Proactive data informed about unique characteristics of individuals. People who have genomic modules and taken variant data, they can start making some decisions in personalizing the healthcare treatment, taking in real-time physiologic monitoring, their social determinants of health, and personalized treatment. Tomorrow is exciting. It's going to be a deeper intelligence, and it's going to be in both daily life. Advanced genomics is going to be incorporated, and you'll be able to do a lot more individualized decision making, especially for somebody who has maybe a rare disease. You can look up to see what's the right treatment, but also regarding just with virtual assistant and more chatbots. Personalized education and immersive experience. We have right now just adaptive platforms for AI, health literacy, learning style comprehension, and it's incorporating on social determinants of health. It should. That social determinants of health is probably a key indicator on success of education seeping in into somebody's habits. Immersive technology, interactive, regarding just, virtual reality, and those are just coming aboard here. Tomorrow, what it looks like is just really deep integration of adaptive intelligence in our daily lives. And then also with genomics, it'll be able to incorporate that regarding pharmacokinetics and gene therapies. And also with that is maybe that also for family members, they can also join and see more engagement if they can't be at the hospital. So today, the ambient technology we're implementing is just the foundation, it's just scratching the surface. And it's going into all care settings. I'm excited. On Monday, we kick off the inpatient nursing for our flow sheet ambient on the inpatient side. Tomorrow, though, it's going to be in the room. It's going to be in the room. You just be able to speak. You know, maybe there might be intercoms or somewhere where you could just, it's just integrated when you walk into the room, or you say, hey, you know, hey Siri, or but I say, hey Franklin, and so I like, hey Franklin, Benjamin Franklin. That's what I'm aiming for now. Integration of biometric sensing, environmental data, and context aware. So this is really important. Is we have cameras in place now, but if you don't have cameras in place, think about that. Think about the continuum of care. Because if you do think about the continuum of care, can you use that same camera in the different settings so that's easier regarding a sustainment model? But if your camera is doing it, is think about not today, but in the future. Do you want that camera to do also some surveillance, which is the next slide, I think. Think about, do you want to do virtual nursing? Do you want to do virtual consults? Do you want to do to an EICU? Can it be one neutral camera rather than having multiple cameras? So think about that meaningful investment. That's really important. And that's where you step in and say, hey, time out. You know, eventually we want to do this with this camera. And this is where your voice is really important. Is that, have you thought about this or that? But, you know, you don't want a patient room to have multiple adapters in the room, because really they're there for healing. And having, I don't know about you, but if you have a lot of cameras, I would feel a little self-conscious. So today we have some surveillance. People are incorporating. I know that some hospitals are way in front, but they synthesize real-time data into the score. And then also, you know, in the future, whether it's you're wearing an Apple Watch, is that you're going to get some alerts regarding high risk. It may go to a provider, it may go from a hospital home situation, but there's a continuous monitoring and a ping to maybe somebody at the central hub that's caring for patients. And then we'll be able to integrate any kind of self-reported outcomes. Also, you may also, if there's a change in behavior in the patient's room regarding, say, you know, or behavior, there may be some alerts. One of our researchers at Penn Medicine is doing a research study, and he is watching the gait of patients from visit to visit. I think that's fascinating, because, and then you just start thinking, oh my gosh, my gait, I've been thinking about what's my gait. So my gait has really changed, but I had never thought about that until he told me about a study. So if you can think about your parents' gait changing, and is anything happening during that, he's thinking, hey, maybe that would trigger something from a high risk. So, but that is going to start happening. Smart room technology, this is fun. Just again, making sure what you have today is just real-time updates, virtual encounters, but in the future, you know, you want to make sure it's fully adaptive throughout and make sure that everything flows. But it's going to be from falls, wound injuries, pressure ulcers, maybe even mental, if somebody is having delirium, but there may be sensors in the room or sensors on the bed that's going to be able to alert us. Couple of things regarding digital twin. I think this is powerful. Some people are doing this now, but it's just really, especially in the field of oncology, it says, you know, where do I do if I take this road for this therapy? Or what did these patients with the same characteristics and the same disease, what was their care journey based on their treatment. So you'll be able to see that. And so for your individual patients, you could try what would it do if this characteristics of data elements and you treat it with this medication or this treatment, and you can see, predict their outcome. And you can also give patients choices as well. And then just in pop health, for those clinicians that are in the public health agency sector, it's just, AI will be able to help us more in real time predict any kind of environment or community alerts. Okay, just, whatever we do with leadership, strategy, and innovation, it really is about quality and safety. And so we just need to consider any kind of technology we do to improve it across where we take care of our patients. We must understand the landscape, organizational culture, the dynamics of our teams, and the strategy and the innovation priorities. By aligning these factors, and using the right technology, we will ensure that we have a truly good patient outcome and support for high quality care in all settings. Don't forget the principles of the generative AI, guidelines for AI, and make sure you ask those questions. Or you think about this when you're part of a vendor selection. But whatever we do, there's a lot of technology out there. We want to make sure we have meaningful investment and that it equals quality and safety. I just started joining the quality and safety at the enterprise level, and it's great. It's just incorporating people that are making decisions, but I did not know that there might be barcode regulations in the ambulatory space. So we need to think about that because there's a cost implications, but we got to plan that into our roadmap. So I always pick up things when I join different committees. So I'm going to just leave you with a couple more, this isn't the last slide, but just regarding where Keely is today. Okay, let's see. I think I have to do this.
With technology, we're pretty scarce because anything to do with the computer or the internet, I had to have another person help me now do things on the computer whenever I want. Not having to rely on others, it really has become a game changer. Independence is really big to me. Morning.
Keely.
My name's Keely Horsch. I'm 19 and I live in Kaysville, Maryland. Awesome yogurt.
We have raspberries, blueberries.
Hey, I'll take blueberries. Growing up, I love playing soccer, baking, swimming, definitely big into sports.
Keely was a ball of energy. She had a mind of her own, was always very independent. And I assumed she was going to probably be president of the United States at some point. Keely enjoyed memorizing the pi digits. Keely was also very competitive as far as sports and enjoyed school a lot.
When I was 12, I got sick.
She called me and said, I have the worst headache of my life. As soon as we got into the doctor's office, the doctor said, I'm going to have to call an ambulance and you're going to have to go to the hospital. So an ambulance came, we went to the hospital, and she had a stroke. A doctor came in and said she probably would never be able to walk or move again for the rest of her life, and she would need 24-hour care.
It was hard relearning how to breathe, and then also I had to relearn how to eat.
Keely is a quadriplegic, and because of that, she has no ability to move her hands, her arms, anything. So for her to be able to do work with the computer is a lot more difficult with a lot more challenges.
I think that I didn't really think of accessing technology as something that I wanted or needed, just because all my interactions with technology were frustrating and not a pleasant experience, like learning to move around just by moving my chin. I asked a friend, he let me know that there was a company testing out a product for people to use their mouth to control a computer. And he put me in touch with the people from Augmental.
Hello. How are you doing, Tracy?
See you.
You too.
Hello, Tracy. How are you doing?
See ya.
Same.
Hey, Huey.
Hi, guys.
How's it going?
Pretty good.
Yeah. Is it working well for you?
Yeah, I've been using it a lot.
I met Lily 1 year ago, and she's been using her device since. It's been a pleasure working with her. When I was 5 years old, I started stuttering, so I became obsessed with the concept of human augmentation, of using technology to overcome our limitations. Human-computer interaction really has been focused on the hand, and that's just not inclusive. So I went back to MIT, where I was doing grad school, and with the goal of making an interface everybody can use. Our tongue is, I would claim, as expressive as a finger, and it's composed of muscles that don't really fatigue as much as other areas of the body. So I thought, why don't we control a computer with our tongue? So I called Corten, who I met at Berkeley. I told him, hey man, I think that this is the right interface. The mouse pad is a trackpad for your tongue. It's a mouse in your mouth. The user uses their tongue on the trackpad, on the palette, to move it around and control cursor. The user clicks by pressing on the palette, right clicks by sucking or sipping, like you can also do click and drag. The mousepad connects to laptops, phones, computers, tablets, like any Bluetooth input system, like a mouse. Would love to see what kind of projects you're looking into now.
Yeah, I'll post them up.
Can you show me how you copy a variable? Cool. As easy as that.
I'm a freshman at University of Maryland, Baltimore County, and I'm studying math and computer engineering. My favorite thing is probably meeting others that want to do engineering. I can bounce ideas off them and make friends in a new way. Before college, I really would just do the assignments that were necessary. Now in college, there's a lot more work, and so being able to get all of it done is only possible with the mousepad. It allows me the opportunity to engage with the content during the lectures. I'm able to take notes and also participate in class.
This allows her to grow. It's allowing her to become more independent and become stronger. Her determination and her grit has gotten her through a lot. And because of that, she is one super duper powerful female right now. So the world should watch out.
I'm excited about the future because of the independence I have now from the mousepad. Being able to stay up late to do homework or play games gives me a sense of normalcy. It's given me the motivation to want to take control of my life. There's the ability to live independently. It's given me a spark.
So she needs us. Keely needs us, but all patients need us. So this is Keely at 12, the day before her injury. This is her now with the founders of Augmentum. And this is a slide that she and I did together to develop the Mother's Day card 2 years ago when I learned how to use ChatGPT. And I asked her, what do you want the card to be? What image? She said, well, I want to do it when we used to pick cherries in the backyard with my brothers. And her brother is my son's best friend. And their dog. So this challenge, how will you meet the moment, right? How will you meet it? So, call to action, meeting the moment, whether it's professional, personal, or as an informatics committee. Lead with change and courage. Build partnerships across the discipline. Keep equity, safety, and patience at the center. Turn innovation into lasting improvements in quality and safety. I thank you for the time today.
So we're going to take some questions. Yeah. If you just put your hands up if you have any questions, we can come around with the microphone. Or if there's any questions online.
I just asked them again,
Great.
but they are all clapping. So,
Yes.
We have a question over here.
All right, thank you. A great presentation. I enjoyed it. But as somebody who loves technology, anybody who knows me knows that I love technology. I'm all about it. I've seen the trend of clinicians treating technology instead of the patient. So, like for example, the overuse of BPAs that weaken the development of critical thinking skills and whatnot, especially with new nurses who haven't developed those skills yet. So understanding that AI is definitely here to stay, what are we doing to prevent those clinicians from becoming over reliant on AI to give us all the answers?
I think that's a great question. Have we overdone it? Right? Have we overdone it? So what is it that you as leaders can remove or implement other technology that's making a difference? So we did ask our providers, and not say that, ambient is everything, right? But it's a foundation and there is a lot more hand holding. So my girlfriend, Tracy Breeze from Mercy, she did a talk at, she's done a talk several places, but what is allowed is, maybe it's also to capture what nursing does, because we don't capture it, but we document in flow sheets, but we do so much more. And so in her presentation, she talks about that, there's a lot of spiritual care that nursing does. And because we're not at the computer anymore. With the ambient, she's doing the inpatient ambient for nursing. And so starting with that is that if you take them away from the computer, where is those alerts appearing? You still may need to go, but maybe you've reduced the burden elsewhere. But I think you should research the OPAs, and are they valuable? Are people just skimming through it? You should have routine evaluation to start thinking about wellness and to clean it up. But it really takes a group of people to look at that and make decisions of what they want, what are the opportunities. But then maybe select some technology that brings people back to the bedside, or people back to more human, more of the human touch. So I do hear for providers that the bats are not necessarily away from the patient because they're not typing. Same with nursing in the rooms, that they're, now more engaged. And what do they do with their hands instead of typing? Maybe they're touching, maybe they're holding, maybe they're a little closer to the patient. And so it's that better patient experience. But I think number one is you need to be cognizant, and you're definitely aware of it. But think about action. Go to your group and say, hey, can we look at what OPAs are being just kind of blown through? Do we need to keep those? Or maybe you have a goal and say, can we reduce our OPAs by 2%, by 5%, by 10%? Just think about, or maybe there's a different way to do it, but you got to take action. Anything else? Any other questions?
You should use the mic.
No, you got it. I just don't want to yell. This isn't questions, but I just want to let you know the chat's responses. Incredible. That was from Lucia. Carol said, wow, thank you for sharing. Allison, that was a very moving Thank you so much for sharing. Amazing presentation from Kristen. Jeanette, awesome presentation. Thank you. And Jennifer said, excellent presentation, very inspiring. Thank you. Just wanted to let you know, no questions, but just a lot of great feedback.
Thank you. Thank you. Every time I talk about Keely, she has an impression on my heart.
Hi, is AI, and this was wonderful, by the way, in nursing school, you're talking about like the burnout the first year. Are the young girls and men, sorry, being taught about AI? Because this generation's, grew up with phones in their hands. So there's a lot of disconnect now. They're so quick to get back on their phones and they're going to have more time. And will they go back to the bedside and have more of that human connection? Is that being discussed in nursing schools now in classes?
Yes, there are some nursing schools that are really out front and they're adding it into the curriculum at every level because you have to go at the doctorate level too, because they may have been out of school for a while, but they're doing it at the undergrad, graduate. And I know that there is one nursing school that's really at the forefront, and that's FSU with Dr. Y. But she's leading like a coalition, but it will be also incorporate. There's a competency that there's a group of nurses that's also working on nursing competency as well in this space. But it needs to start at the education school, but it also needs to come to the health system as well. I think it's just to be educated and ask the questions to just make sure that we voice for ourselves as clinicians, but also for our patients and advocate for it. But it is being taught at the curriculum level.
Hi, I really enjoyed the lecture. What are your thoughts about like nursing and providers coming into this AI world and that they're going to lose that, I call it the art of medicine, where you're thinking, you're reviewing everything. AI is going to be doing that all for us now. You lose that. How do you prevent that from losing that and relying on the AI too much?
I think that's a great question. That's a question right now that is being discussed at every health system. And one of the big questions on the listserv is, do you allow residents to do ambient, right? Because you want them to have the structure. That will be the same with nursing. But is it that do you teach nursing the true essential documentation that's needed? And the question I would flip is, have we overburdened to get the kitchen sink in our documentation? Right? And so I would say, who is studying, and somebody is going to be studying, and it's just, what are the essential documentation that's needed, that's being used by our clinicians? It's a really interesting time right now because I sat in AI, it was about AI, but it's about innovation at Stanford Health, probably last spring. And I was in a table, this is it's a good story, not a good story, but I was sitting at a table with nurses, mainly in informatics and application, as well as providers that are in informatics. And we're talking about ambient, and we're talking about in nursing. And one of the nurses around the table said, oh, this would be great because we can do our notes, using the same tool as the providers. And the surgeon provider said, why would I want to see that? Like, I don't want to see that. And fast forward, when you're doing a hospital chart course summarization, or you're doing what we call, just the inpatient stage or a handoff, guess what documentation they're using to do the summarization? It's our notes, it's our flow sheets, it's our documentation. Makes up what has happened in that 24 hours. So, it's really trying to change just the culture and the thought process regarding what we document as nurses. But we got to think about how we ask too much and what are truly the essentials. And I think as people study, we're going to look at what are the true necessities and how do we trend. Maybe in the future, flow sheets or outdated, maybe we see trending in a different way. Right? Maybe the trending is by dashboards and maybe summarization. You know, I'm not sure exactly, but maybe it's going to be visualized differently as we study this new way of technology. But the time will tell, but hopefully you be an influencer to kind of just guide the right decision, whether nurses should use this tool, maybe as a blend, that you should use it 50% of the time. Would you allow that? If something's really doing the well-being of a provider or, you know, and this is clinicians, would you take a tool away? And is there another way to document the essentials that's needed for the art of medicine? It really makes us think. So as us as thought leaders should think about that. Maybe you could write a paper together. I mean, you know, that might be, it's just, what are the thoughts? Maybe you could survey, but get some ideas and be out in front and shaping what is truly the art of medicine, the art of nursing. I'm part of a blueprints group with Martha Curley from CHOP, and they're trying to figure out, you know, about nursing documentation, and we're going to be looking at ambient. We hope to look at ambient because it's not just about flow sheet data. It's really about what's happening in the room with the patient. And then that's kind of phase one, but second phase maybe is the handoff between nurses. Nobody captures that. And that's a lot of critical thinking and critical information that you exchange. And it's not in the flow sheet. But I think that is unknown on what's the right recipe to not lose fundamentals, but maybe it's just a new way of thinking. So we'll see.
So Anna, Sherry Duarte from CHOP, what you just said, I don't know if it's more of a comment. What you just said made me think that if nurses have more time to actually touch because they can speak, it'll be documented for them. Maybe that will help with critical thinking that I think kind of went out the window with the EHR. So if they're not focused on documenting or in the computer in the room, and not even nurses, but even the residents, looking at patients and maybe being able to see changes that they may not have. So it just made me think that maybe this is an opportunity to improve those assessment and critical thinking skills and you know, just go back to our basics.
Yes. The tradition of caring.
So I actually have a question too. Sure. And it kind of ties into that. So we have traditional clinical decision support that's based on straight up programming with algorithms. And we know as nurses that it's clinical decision support. It's not the decision, right? So we use critical thinking, and we also have to incorporate our observations, as Sherry just said, when we're using those tools. But with AI, people tend to rely more upon that. And it's being presented, though, in a similar way to the clinical decision supports that we've traditionally had. So do you think it's even important that nurses know the difference? Because the AI hype is so high, everybody thinks everything is AI. And we're really not using a lot of AI where I am. And we're using Epic, but there's just not a lot of AI incorporated into the pieces of the tools that we're using right now. Do you think it's important that nurses know when AI is being used versus traditional algorithmic tools, and the level of clinical decision support or maybe the level of skepticism they need to approach what's being presented to them with? Because sometimes those AI tools, I know I'm very concerned about hallucinations, and that the information being presented to me might not be correct, and the tools might not have been trained properly, whereas the algorithmic tools, I can pretty much rely on them being more accurate. So I don't know if it's important to know the difference, or if it's too much for our nurses to deal with, because a lot of them don't like technology.
Well, I think it depends on your role and your level. And if you are at an informatics level, yes. And you should participate in the testing and the validation. I will say, with our upgrades, like our testing, it could be optimized. We'd love for a lot more people to participate in testing, because it's like testing a needle in a haystack. Everybody brings a different perspective. And if you can come and do a lot more testing and bang on and just validate, I do think as informatics people, you should know. Ask those questions. That the frontline nurse, no, because they're going to rely on you to have whoever's validating to participate. I think that if they ask, absolutely, they should participate and get educated. But, for a new grad, I think that's, they're focused on taking care of the patient. But you as leaders should definitely know and get engaged, because you should know, because you want to provide the feedback if something's not correct. Right? With the AI, you have some drift, and as you add more data, it could change. Or with the upgrade, or somebody made a change in something you don't realize. You have to be really engaged and to understand. So if you can, just say, if you can provide, hey, maybe you take this type of summarization tools that is generated by AI, and you take this one, and you kind of own that. And so maybe with every upgrade, that's your thing, and you make sure it's working well. But it's a team sport here. And it cannot be just one data scientist. They're in the back end, you're in the front end, and you're working closely. Are you rounding in person? Are you rounding in person rather than rounding remotely, or it to be a video session or people sign up? Are you rounding? Are you navigating? Okay, I know we only have a few minutes, but I'm going to tell you a story real quick. So I went to go visit the high biggest utilizer of ambient listening at a provider's office. So I went there in the morning. We were supposed to meet like at 8:30, maybe at 8:00. Time passed, and it's okay. And she came out, the provider came out, and she said, "I'm so sorry, I'm late." I said, it's okay. This is, I'm here. I'm honored to be here. 2 is the MA didn't show up. The night before, her partner resigned. And she knew that was coming. It's going to be more burden. And then, so that I said, oh my God, I need to know that. Like, that's good for me for being a leader. Like, this is burden. This is chaos for practice. It makes me do my work better. But then I observed her, and she did not use the RFID that we implemented. I said, why are you using the RFID? And she goes, well, I need name tag. And then she went and got it, and she authenticated, and she's okay. She did it. And her window, her PC didn't look right. So I called the technical guys, and I said, hey, she's not having the right image. Now, how did I know that? I just knew from my past life. I said, just, it doesn't seem right. Come to find out, provider had an inpatient image in that practice, not an ambulatory image. So I said, I want a calculation of all the images that have this image that's on the ambulatory side. It's not about the ambient technology, it's the connection with the provider, but just observing and adopting. So if you go in and observe, you just learn so much. And I want to make sure that we get back into that human connection with our providers, because just so many things pop up. And so we had 60 PCs that were imaged incorrectly on the ambulatory space. Now I came to find out, because there is a other feature regarding RF tap and go, is that you can also have roaming features. Well, I learned that you can't have roaming features if you don't have a virtual desktop image. So that was helpful for me. But anyway, is to know your technology, see if it's adapting, and be engaged. So anyway, you just learn things as you along your journey here. Thank you so much for your time.
We're going to get started, and if everyone could have a seat, please. I'm going to do the next speaker introduction. My name is Diane Waltz, by the way. I apologize for not introducing myself twice, but as Constance says, a lot of you know me. I am a GDV ANIA member. I'm currently the treasurer and co-chair of education. And I would like to personally thank all the members of the education group, because they do a lot of work behind the scenes to make this a successful event. So And I would like to thank again the Jefferson College of Nursing. Not only did they allow us to use this beautiful space, but I don't know where, oh, there's Ingrid. Ingrid got us some nice swag for our door prizes. I'd also like to thank Colleen Malazi because she really helped to facilitate all of this. And many of her team is here today. Constance believes technology should support and enhance clinical practice and healthcare operations to assure positive patient outcomes. Achieving this vision depends on a secure foundation that consists of a sound clinical informatics environment and a strong informatics team focusing on clinical workflows and partnering with operations. Constance is a seasoned informatics nurse who has worked in community hospitals and as a nurse executive consultant with a global healthcare IT vendor. Currently, she serves as a health informatics director for Trinity Health. Spanning a successful career of over 30 years, Constance is a registered nurse of 23 years and an ANCC board certified in nursing informatics. Education includes a BSN, ironically, from Thomas Jefferson University, and an MBA focus in information technology from Ashford University. She is a member of the American Nurses Informatics Association, a highly active member with Greater Delaware Valley chapter, and a member of the PA chapter of HIMSS. Constance currently serves on the board of directors for ANIA. Nationally, Constance has contributed to an ANIA toolkit focused on ANIA's online community software in 2023 and the 2025 ANIA chapter leadership toolkit. Locally within the GDV ANIA chapter, her contributions include establishing new committees to increase member engagement, promotion of chapter activities via social media, extended educational events in 2024 to include a professional development webinar series, Nursing Informatics and launched the local podcast aptly named Informatically Speaking. And for me personally, she's been an amazing mentor for GDV ANIA. Constance McLaughlin.
Thanks, Dan. You can hear me on this speaker, okay? Okay. Really happy to be here. As Diane said, I really have done all of those things. And when I hear it, I can't believe that I actually still do some of those things. But I am also the immediate past president. So last year I was president, and this year helping to continue to mentor. So it's exciting. So I love that. Thanks for having me here, and thank you for whoever made this slide and made my face really big. I typically a big picture of myself. But thank you for allowing me to geek out on this topic. It's not something that a lot of people talk about or think about, but Dr. Anna was gracious to talk a little bit about it. So I'm grateful to be following her as she did talk a little bit about governance. So that was a good thing as well. We do the work. We already do this work within governance. You probably don't know it. So let's just talk about a little bit. I want to keep this high level. And I also want to make this interactive. So I am going to ask you some questions and I want you to just blurt things out. Okay. You can use jazz hands if you want to. And also I want to hear from you. I want to hear what your thoughts are as well. So the title, From Decisions to Deployment, IT Governance Powered by Informatics, it really is powered by us. We are a foundation along with PMO and IT as well. I have no disclosures. And learning objectives. I really want to just, again, give you an overview so that you have an understanding of what governance really is, and then also where you fit into the process. In my past, I have worked as a consultant, and when I would walk into different client organizations and I would do an assessment right off, finding out what they're doing with their informatics department, what they're doing in general, how they manage their governance process. A lot of people would just say to me, oh, we have change control meeting every Wednesday. And I would say, okay, I need to start from the beginning here. So that's probably one thing that we'll focus a little bit on. But anyway, so I just want to give you that overview, the definition, talk about responsibilities within the actual process. Process is the word of the day. It is process. And then review the role, your role, and the change champion as well. So if you were to Google healthcare IT governance, this is just a tiny bit of really what you would see. You would see all kinds of graphics. You would see all kinds of theories related to it. In reality, everybody has their own form of governance. So whether it is just change control or if it's a highly agile arm of governance, like Dr. Anna was talking about, they're all the same. They're all governance. But again, want to go on that high level and talk about what it is. But first, want to talk about what it is not. This is an organizational chart. Can it support a governance process? Correct. It can, because it's a business structure. It's a structure. Governance cannot be a structure, although it is kind of a structure because it needs to be structured. It needs to have a communication process, but it's not a business reporting structure. How about change control? Everybody calls it change control. It's makes the hair stand up on my ends because it's a process too. This is a very small part of what governance is. So this is where you come in. No jazz hands. I want to hear from you. Just give me words. What's the first thing that comes to mind when you think of governance?
Shared input.
Shared input, okay. Structure, there is structure to it, yep. Collaboration. Anybody else? Knowledge, sorry? Interdisciplinary, that's a good one. That's a good one. Yes, it is. It is those things. But let's talk about all of the different definitions that surround what this is. So corporate governance, the bigger, broader governance. So today we're talking about IT governance. Just keep that in mind. So corporate governance is more about looking at the objectives of the organization and how they're going to achieve their goals, right? So that's the bigger picture. They're looking at strategic plan. How are we going to meet our goals and how are we going to monitor them? We know what clinical governance is. That's probably the thing that we are most involved with, the things that we have been most involved with over our careers as nurses for the most part. It is more about the quality of patient care. It's the practice of nursing. That's what they're focusing on. IT governance, of course, this is getting closer to what I'm talking about. This from Gartner is actually talking about a process in which they are looking at the effective and efficient use of the technology in the organization and how the technology is helping the organization to achieve their goals. What I'm talking about here today, again, is a process of decision-making and the process by which decisions are made for the implementation of IT or not implementing IT. That's the most basic definition that I could think of, taking into account all these other things. By the way, again, another little tidbit. In my past, when I did work for the vendor, I was there for 11 years. I worked in many different areas and worked in implementation. By the time I moved into the nurse executive role and I was helping clients to figure out what they were doing in this IT space, I helped them with set up their informatics teams and their practice. And then with this research, standing on other people's shoulders, this research was so really invaluable to folks to understand how they're bringing everything together. So it took years and years of me talking about this. And really, that's the reason why I'm talking about it today, because people don't talk about this. But anyway, this whole process is really looking at the investment of IT. The investment of IT. So the UN has 8 characteristics. They say that there are 8 characteristics around governance. I say that's true, absolutely, because successful organizations that I've worked with have employed all of these things. But one thing that they missed was communication. There was no communication mentioned anywhere, so I made sure that it was right in the center of it because that's where it really should be. So why do we need it? We need it for a ton of reasons, right? But it seems this day and age, every day and age, every year we go through what we go through, and the government, our government right now in turmoil, right? Everything is just outrageous. We can't even talk about it, but anyway, so it's it needs to be structured. We need to have the communication, the lines of communication. There's just ever evolving everything, business models, financial reimbursement programs. So we really need to fixate on a few things. Clarity on the alignment across the organization. What are the goals? What are the priorities of the organization? Focusing on achieving those goals. And again, communication, I can't say that word enough. But then also aligning with the vision and the goals of the organization, coordination of the decision-making. So you can communicate all you want, but if you're not communicating the decisions across, you need a little bit of thought about how that's working. The coordination of the portfolio, and then also aligning with the actual planning of the strategy and annual planning as well. So speaking of just a very high level, I'm not going to get into this, but this is the difference between strategic planning and our annual tactical planning, right? So again, the strategic planning is the very high level planning that the organization does. What's their market share? Where are they growing? What are they doing? How are they going to get there? But then you look at the operational planning, and it's all the tactics to meet what's happening on the strategic plan. So typically, your CNO, your CFO, all of your C-suite have all of those strategic plans. They have all the pieces within the strategy, and then they start leading the groups who are going to help them with the operational planning to meet all of those goals. So this is where you come in again. Symptoms of ineffective. What have you seen at your organization? Everybody's smiling. What are the ineffective characteristics? You can just shout them out. Too much.
No plans.
No plan. Silos, that's a good one.
Solutions before understanding what's actually needed.
Solutions before understanding what's needed.
A no attitude.
A no attitude, okay?
The need for consensus.
The need for consensus.
Discussions without informatics.
Oh, discussions without informatics. I love that. This is great. You guys are giving me a lot more than I really thought you would. So over the years, these are the things that I have found. And it's most of the time, it's senior leadership might not even think they need to be involved in the process. They think everybody else is going to make the decisions and hope that things are going to turn out right. Because they can't explain, when they can't explain what their governance process is, that's a red flag. That was always a red flag for me. But then they also see low value from what they've implemented. So that tells me that nobody's looking at the ROI, nobody's paying attention to that. So that needs to be happening in this process too. Projects are often run late, don't have a plan. You get to meetings and you talk about the thing that you talked about last time, right? How many times does that it happens everywhere? Everybody's talking about the same thing. They never come to conclusion. And then the governance process itself changes frequently because it's like, oh, well, this doesn't work, so we're going to change this. Instead of letting it run out for a little while to see how it's going to work and then change it. If it changes frequently, that's an issue too. And I'm assuming that you've all seen these two. All right, so let's talk about the process. The strategic plan, I think I've said it many, many times already. The strategic plan should be visible from top to bottom, from bottom to top. Everybody should know really where they're headed because all of the conversations you're having, even if you're having conversations about a change, all of that stuff ultimately contributes to the strategic plan. So don't think that you are a teeny tiny part of it. You are a big part of it. You are part of the foundation, as you can see. Project management, IT, and informatics. You are the foundation. You are the guiding factors. Most of the time, you are living here because you're in the weeds, you're in the details, you know how things work. But it's not just about the EHR. It's about all the technology that's going on. It's what they're using, it's what they're holding, it's the glucometers, it's the scanners, it's all of the technology, even the infrastructure. All of that stuff comes into play. So if you think that making a change isn't going to impact anybody else, you got to think again, because somebody needs to know what you're changing or what you're thinking about before it actually happens. So thinking about like an agile arm of all of this, and hopefully I'm sparking some thoughts about how your organization does this, because an agile arm to this would go a lot quicker. That's what Dr. Schellenbaum was talking about today. Going through the process, but you have to be very careful about what it is that you're changing and how it's going to affect this entire process. Sorry, I'm geeking out. I can talk about this for the next 6 hours, but I don't want to bore you. So this is primarily where you are because you are talking about the stuff in the weeds. This next part are the decision makers. These are the ones that say, yep, that's okay if it gets changed. They're talking about new stuff coming in. They're talking about the sustainment of what they already have. They're talking about the ROI. They're talking about the impacts of what they put in last year. And if they make changes to it, how this is. So I know a lot of you probably live in the EHR change space, but what about the bigger picture? These are the folks that are making the actual decisions about how things are going to be used and what's coming in and what's going to be sunsetted. So these are the folks that are an interdisciplinary council. Then you have your data and AI council, you have your cyber council, your ambulatory council. So you're having all of these different groups that talk within themselves, talk about their technology, talk about what they're sitting on top of, talking about how far they want to go, knowing what's coming in the future, talking about all of those things. But right now, they're in their own groups. So how do they communicate? They communicate through an integration group. So if you have all of these folks, depending on how big you are, if your organization is a one facility organization, maybe it's not that elaborate. But like I said, all organizations have a type of governance. It might look a little bit different. But this integration committee or council is the group that is the chairs of all of these groups. So that's how they are talking. That's how they say, well, this is what we talked about. This is what we're looking at doing, and this is what we hope to do. And this is how it's satisfying the strategic plan, because everybody should know it. Everybody should see it, or at least have some kind of an idea of what they're working toward, right? So that integration committee is integral because there are other groups that feed into that. So you have, again, your permanent work groups, the groups the service lines that you function with. You're making thoughts and decisions about what's going on in Peri-op and what kind of information they need or what they need to do or where they're going to go. But that information has to come up here to the interdisciplinary group, right? To talk about how is that affecting any decisions that they're making. And then all the chairs of these folks meet together. Med exec goes into there, nursing practice should go into there so that everybody is talking. The CNOs, the CMOs, the CFO, everybody's talking. Communication is going up and down. And then the executive committee. So it's not the board. We're talking about IT stuff still. So this, in some organizations, might fit into your other governance process, but this is not the bigger organizational governance process. This is IT governance, okay? Believe it or not, you need a structure. You need a process for IT governance. You need to talk about all this stuff. All right, I think I beat that to death. So where are we? Everywhere. We should be everywhere. Maybe you specifically are not at all of these levels. Maybe you live in one of the decision committees. If you're not in a decision committee, ask to be. Because you are guiding, you are helping to make decisions, and you are guiding them on the technologies that's out there and what you could be doing in the future, because you're doing the research, you're doing the reading, you understand what is coming. Ask to be there if you're not. Integration committee is usually the more senior leaders coming together, but your senior leader, Colleen, myself, other people who are leading the charge, Dr. Anna, she's on that. She talked about that too. She talked about that decision committee, and she loves being there because she's hearing about all these other things that are coming. So you are informing, you are guiding, you are supporting, you are participating. Okay. So again, this is kind of a little bit of a recap, but this is just a different way of looking at what I just talked about. So the executive leadership sets the vision for the organization. They're the ones that want to know their return on investment on what they just bought or what they bought 5 years ago. And is it still effective in the organization? They handle any escalations, anything that can't be decided upon. They're the ones that make the final decisions on what all of those decision groups are talking about. The decision and integration committee, again, applying the strategic plan, they know what they need to be working toward. They understand policy procedure changes because that needs to be taken into consideration. I think people forget about that. They forget to put the technology into their policies. So that's something that needs to be worked out. Workflow changes, training plans, prioritization of any new projects. And then of course the permanent work groups, which I think they're the ones that do the majority of the work. That's why this is so big. They have visibility to the strategic plan. They understand what they're working toward, but they also understand what they are responsible for and how they're helping to guide the areas that they are supporting. So validation of the workflows, the standard clinical content, review of all of that. So there's a ton of work in all of these. Okay, so this is always fun because this is an example. Please do not take this as real, but this is just an example. So how many times have you been in the department or find out that somebody The manager maybe in the OR said, oh, I have $1,000. I'm gonna buy this shiny thing and expect that IT is gonna just drop it in for them, right? Well, hello, that's really not feasible and they shouldn't be doing it, but they do it. That tells me that there's no process, right? They're not in a group that's actually talking about decisions being made, things like that. So there's a reason why we have all of this. So that's an example just of the departmental side of things. Then the standard and integration committees, of course, they may have some kind of a financial cap that they can make decisions about what they want to move into. And they might not have to go to the executive steering committee to get approval from that. But then the executive steering committee, they're the ones that have all the control, really can say, this is what we're doing, what we're not going to do. All right. I'm talking a lot faster than I thought I would. Additional considerations. Okay. So the governance approval process, this is stuff that you already do. I'm sure of it. These are things that you already do. You probably just haven't thought about it or seen it in this way, but we have to go through that identification. And that is huge for you because PMO should be contacting you early saying, this is coming, I need you to help me think about what this would entail. Because when you know something's happening early, when a new project is coming, you can start thinking about education. You can start thinking about what's the current state. You can start thinking about what might be the future state after this starts to get in motion during the project phases. So make sure that you are there, that PMO knows who you are, and that you should be part of the early process to help them with that. The business case, same thing. The functional areas should be involved. The manager, of course, let's say peri-op or med-surg or whomever it is, but you should be there too, because you need to help them make the business case that this should happen. And remember, if you're in the whole process, you have access to what? The strategic plan, so that you know that it's a good decision and that you're really helping to guide them. Then, of course, approving and funding, then it will go to the committee, one of the committees who is able to approve it and say, yeah, okay, let's move forward. And then, of course, the project delivery where you are. So you are part of the drivers as well. Again, part of the functional, part of the can't speak today, foundation of everything that's happening in governance. Is this making sense? Does this work in your organizations like this? Yeah? Some? It's supposed to? Yeah. In theory, right? In theory, this is great. Okay. So the difference between HIT governance and project governance. HIT governance has no time frame. It goes on forever. It shouldn't start and stop based on what's happening. It needs to keep going regardless of the projects that you have going on in IT, because there's a lot of other things to talk about besides implementation. Project governance has a time frame. And I hope it has a time frame for you, because I saw a lot of nodding heads when I said that things go on forever. Yes, sometimes they do. But you need to have those limits to say, this is when we're going live. Even if you back into the project, I don't know. And PMO does whatever they're going to do. So I'm not going to go down that road. But then again, healthcare IT governance, when you talk about the sustainment process, again, it's regardless of what's actually happening, what's implementing, IT governance just keeps on going. It's the status quo. within project governance, the people are dissolved at the end, right? They should be going back into governance for the sustainment part of it so that they're tracking. The auditing, the monitoring, the use of the technologies, again, in healthcare IT governance, in projects, it is just about that project. It doesn't take into account anything else that it's affecting. They just want to make sure that they're hitting their targets and they're getting their metrics together, and then they move forward. The team disbands. Everybody should be going back into the governance process to make sure they're monitoring. All right. So communication plan. So what? What would be the plan? Why do we need to have one? Because if we're not talking to each other, then we don't know how we're moving forward. This is not about being siloed. So within this whole process, the way that I've implemented healthcare IT governance in organizations is to actually have somebody who's kind of the project manager of it. They go to the bigger decision committee meetings. They're keeping things organized to understand. It's really a quarter-time job once you get it down together. But somebody who is taking care of all of this stuff that's coming through, and then also making sure that there is a plan, that there is communication going up the ranks, and there's also communication coming from the top down. So yeah, the top down has the strategic plan, they put it out there, at least you kind of know, but you still need to know the decisions that have been made, right? So that communication still has to be coming down. We need to make sure that everybody is informed of what's actually happening. So within your process, does the staff know what's happening? Probably not. Yeah.
Also knowing why we are changing certain things, that they really want to know why any change is coming. And if they just tell them why, give them a rationale and an answer. But giving that why in a communication is essential.
Yeah. Everybody should know why certain changes are being made. Yeah, I totally agree. So there needs to be some kind of a mechanism for the staff to understand why things are changing. So when we go through an upgrade, you all are pretty much the ones that are telling everybody that things are changing, right? But how is the leadership involved in telling everybody this is what's actually happening and this is where we're going in the future? Sometimes you don't know, but you should know. Everybody should know.
Well, and I'll just to interject there, something that I think we do well at Virtua where we work is we have nursing congress. We have nursing congress, which is like the shared governance chairs of every single nursing unit that come together, every other month, quarterly. And we have time in front of them as the nurse executives. And so your CNIO should be there because I'm there. And I get time to tell them the stuff that they won't hear.
Yeah.
Because it's not part of an upgrade or a request. It's part of a strategic project that just got approved for nursing and how it's going to benefit them. And it helps them understand the why, but it also lets them know it's coming and it gets them excited because we wouldn't be putting it in if it wasn't going to make things better for nursing.
That's so true because we also have something similar like
We call it cup of joe. So our CMO and senior leadership, they go monthly doing rounding and they have agenda, but not even actually they go without the agenda, but they have some hidden agenda too. But
everything, right?
yes, but they call it like cup of joe and senior leadership, they round on the floor and give them and talk about strategic planning and what's happening around the hospital.
Thank you. Yeah, I appreciate that. And that it's nice to hear that there are organizations in this room that are functioning well. And I realize that, like I said, this is dry and I could talk about this forever because I lived it for a long time, but it's stuff that you really should know. And if you're not getting the information that you should be getting, ask somebody, is there communication that comes from your CNIO or your CNL on decisions that are made about technology? Because you really should know. Yeah.
I'm sorry, I think if you always struggle, what's the best method to communicate, right? Emails, huddles, meetings.
Sorry. Oh, thank you. I think the common topic or the struggle is how to get that message across, right? We know people are not reading emails and you're constantly sending emails. I always joke about it. If there's anything coming from Aisha Gonzalez, maybe delete because she's telling all the changes, optimization all the time. And meeting forums. So there's a constant struggle as to what's the best method to reach out to nursing and other clinicians to give them a timely information about all the changes that are coming. Everybody has any kind of method that really worked for them.
Yeah, if anybody wants to add to that, that would be great. I will tell you in my little corner of the world, we are standing up an informatics council that is local. So in my organization, we're a national organization. So we have different regions. We're working towards standardization. So all the regions are the same. But things like this, it is important that everybody hears the things that we know about. So we're making sure to stand that up so that the expectation is not that informatics is just coming to the table to say, oh, here's all this stuff. It's a collaborative group to talk about what's out there, what are the challenges, talk about workflows, talk about the upgrades that are coming. But the expectation is then to have those members of that council take the information back to their groups, right? So it's not just an email. Sure, it should go out via email, but how many times have you said, wow, I sent an email? Well, yeah, everybody sends an email, right? But how else are you doing that? We are at huddles. We are at different meetings that we can speak up and say, oh, I heard this. But then we also have the bigger pieces that should come from leadership. And in my organization, it comes through marketing and they send out an email. But it's a newsletter, but there's links to it so that you can actually click on and learn more and things like that. So there are a lot of creative ways to get the message out. Yes.
Hi.
Oh, sorry.
No, it's okay.
Yeah.
I was waiting until you finished. I'm an end user, so I'm still at bedside. I'm a nursing informatics liaison within Virtua Health.
Awesome.
And so I can attest and speak to the variety of ways that they do try to get the information out. We have end user groups. We have the liaison program, which is people that are engaged and want to enter the field into informatics. And we go around and we do rounding with the informaticists and have those discussions one-on-one, which we find is, I would say, more beneficial because then that's when we hear a lot of the issues.
Right.
But we also are able to educate and we have rounding topics where, for example, we have patient pass coming from Elsevier. So that's like a big education point coming because that's changing quite soon. So we're always, I say because I'm a part of it, but I'm the end user part of it more so. I bring it back to my community, my unit. The leadership of the nursing staff brings it back as well. So you have these variety of different ways, but getting people involved is really the biggest way to do it, especially end users, getting end users to end users involved, because I've also, inspired, motivated other people who have noticed how much I love it to get involved in it. So then they want to come to the meetings, they want to have input. Because they do come to us. Those end user meetings are so important because if I'm on that meeting, they're listening to me. They actually care what I have to say.
Because you're using it.
Exactly. So it's really great that we have all these different varieties of ways of getting it out. Now, am I saying it's perfect? No, because we have a newsletter, we have emails, they get sent out, but some people still don't read them. But that's why we have so many different ways of communication because someone's going to learn differently at some point.
Exactly. Well, we need you to make the rounds at all of our places, right? So inspire everybody and show up at our meetings as like secret shopper maybe. So that would be awesome. I'm gonna call you.
Okay, I just want to say one thing about email, since we're talking about it so much and we talk about the different ways of communication. My employer has like an enterprise emails and they put everything on that email. And they normally start with fluff. This is the walk that happened over the weekend where for a heart, for all the medical conditions there are, this is how you can volunteer. And one email at the bottom, they put that how much we're gonna pay for our benefits is increasing by 4%. So by the time you got to the bottom, you have read like 30 different things and you're working. So of course you ignore it. Then everybody else in the enterprises was talking to each other. Did you hear that we're gonna pay more? And everybody's like, what email? So I just wanna say, everybody's a different learner. We want to communicate the ways that everybody can get, but some things and whatever you choose, you're going to have to, for some people, they only have a few minutes. So we can get to the nitty gritty in the beginning, the important things, and say, this is the points, and maybe we can have more of a discussion, a long-winded thing that somebody can read later on, the important nuts and bolts. Just try to think about people's time so they don't miss this, or you feel like you're doing emails in vain because nobody reads them. No one has time to read for 5 pages until the important stuff gets done. That's all I want to say.
I hear you. Well, and I'll be shameless in this to promote something that my former VP started. He called it a bottom line up front. I think it's a military thing. And that's what goes out to the provider. So they do a very short blurb in the very beginning, short version, like, hey, this is coming. This will benefit you, blah. And then all the detail, but it's always just a 1-pager. So it's clever. And I think we started using that in other ways now. So it's a really good idea. So thank you for that. I appreciate it.
I would say too,
I
don't care. It's me. The other thing I would say is while, I am not a digital native and there is still a lot to be said for the newsletter on the bathroom stall.
Hey, you know what? That is really the first thing that comes out of my mouth is, do you print this out and you putting it on the back of the door in the bathroom stalls? Because that's where nurses read. Yes. Yes. Sorry. Robert. All right, one more and then we'll.
I was gonna say, we'll take this one more and then we'll let Constance finish her presentation and then we'll take questions.
No, I love this. This is great.
Yeah, it's great.
I'm also an end user. I'm the chair of informatics committee at my hospital, and then part of a member of the system-wide informatics system council. What I created at my hospital was Informatics Council, forms that we can send out because people don't know a lot about informatics. They have questions about like what they can change and what they want to do, but it may not work for the whole system.
Right.
So that way we can help filter and answer their questions before they're submitting IT tickets and things like that. So having two-way communication is very important as well, versus just us sending information out to people.
Oh, absolutely. Absolutely. Well, that's why we have those work groups, right? So you're embedded in your service lines, you're in the ambulatory space, wherever it is that you are, you're sharing that information, but they're also telling you, or when you're there, you're observing out of the corner of your eye, right, Elizabeth? You're out of the corner of your eye, you're seeing things that are happening while you're talking to other people. So you're gathering data as well, even if they're not telling you what's going on. So, okay, let's move on. Not too much longer. We're almost done. So this is what I was talking about, what makes my hair stand up on its end. Change control is the technical check the box. It's been tested. It is there. It is ready to go into production on Monday. That's change control. The change request process is all the work that you put into it. All the time that you spend with your end users talking about, is this right? How about I educate you? I don't think this is a change. What do we do? Oh, it could be 40 hours of you talking with somebody. That's the change request process, right? A small, simple maintenance is a change request. The bigger complex need decisions made goes within the governance process. So of course, change request is where you are. These are the technical people. So if you take nothing else away from this today, please don't call it change control. Those are the technical people. So to recap, and I think I drove this home enough. Project governance lives within the work groups, lives within the decision committees. This is a structure. Everybody has a different structure. Everybody functions in different ways, but the main philosophy remains the same. Everybody needs to be talking. Everybody needs to have a voice. Everybody needs to be communicating back out from this process and into the process. The changes circle in that middle area and the bottom area. That's where all the changes usually occur, the smaller things. But the information still goes up to say, this is what we're changing. And where do you live? Right there. You live within the entire workflow. So I hope that you took at least something away from this today. It's not something that we often talk about or a lot of people know about. And I do have a couple of handouts that will go out with the rest after the presentations today, after this conference. I have a couple of handouts for you you'll have the slide deck as well, but these are just the handouts that I was hoping that you would take away with you. So that's it. Yeah, questions?
You get 5 minutes. Oh, it's so pretty.
Thank you, Constance. That was really great and very informative. At the beginning, you had asked what we thought, our initial thoughts about governance, and someone said too much. And so when you were continuing with your presentation, you talked about ineffective governance having a symptom of slow or contradictory decision-making. So I feel like over-governance can have that symptom.
It can.
What can we do to remedy that or prevent that from happening? Or how do we talk to our leaders to be like, I think we're over-governancing this?
Yeah. Well, I mean, I guess that's where your leaders come in. So to talk with the other leaders about what's happening, but it sounds like things just keep changing to me. If things keep changing like that, it gets chaotic. The recommendation is always you put a process in place, you let it go 6 months, and then talk about it, debrief about it. What is it that's working? What is not working? And when do you want to make the change? Because if you keep changing things, people aren't going to be able to absorb what's actually happening. And that's what it sounds like is happening. Or they're trying to do too much at one time. And then that's kind of a leadership discussion. Where is it that they're going? But then I would ask the question of what's on their strategic plan? Like, why is it that there's so much changing and happening at the same time, and where are they actually going? But yeah, I would say that's more of a leadership discussion. Yes.
I'll use my military voice. So, great talk. I have a question. Yeah. Oh, thank you. So can you hear me? So, great talk. I have a question about, there's a phrase in military called being on the outside looking in. And I feel like in informatics often feel that way. So, speaking, there in an organization, you might have multiple governance structures, but for a lot of them, you're on the outside looking in.
Mm-hmm.
From your experience, what would you suggest when you identify governance weaknesses that you want to help those other structures improve? How do you go about doing that?
So first of all, having a seat at the table, right? And I kind of hate that phrase now because everybody uses it, but it's true. If you're not in those meetings to actually hear what's going on and help to guide them with the technology and moving forward, that's where we're falling short if we're not even there in the first place. If you are on the outside looking in, I suggest, of course, trying to get in, ask the question, are there any informaticists in this meeting, can I just listen in? Because I think the IT part of it, let me listen to see if there's anything I can help guide you. But again, it's the leadership that's trying to set these things up, right? They may be functioning in silos. So depending on what other governance pieces you're talking about, IT governance does kind of function here, but it should be feeding the information into the other processes that are happening. And that should happen at the leadership level. If it's not, have a conversation with somebody that you trust, a leader that you trust, to ask about how to move forward with that. Because that's a hard conversation. That's a crucial conversation, as a matter of fact, if you haven't taken that course yet. But that's a hard topic. But thanks for the question. I'm out of time. I got the big 0. Thank you, everybody. Appreciate it.
Hi, everyone. It is my distinct pleasure to introduce Kenrick Cato with a lot of letters after his name. He's a professor of nursing at the University of Pennsylvania. He's a nurse scientist and a nurse scientist for pediatric data and analytics at the Children's Hospital of Philadelphia.
I got it. Sorry.
Are we good? Okay. Dr. Cato has a varied background. He's worked as a database engineer and a software engineer before serving as an entryman, enlisted, and officer in the United States Army. And thank you for your service. He has also worked as a surgical and medical oncology staff nurse and as an analyst in the information technology department, working on projects to improve patient safety using clinical decision support. Dr. Cato is a clinical informatician whose research program focuses on mining electronic patient data to support decision-making for clinicians, patients, and caregivers. Also, he is involved in several national-level informatics organizations, including as a board member of the American Medical Informatics Association, the chair-elect of the Nursing Informatics Working Group of ANIA, as well as a convening member of the ANIA-sponsored 25x5 initiative to reduce documentation burden. Dr. Cato received his BSN, MS, and PhD in clinical informatics, all at Columbia. Dr. Cato applies rigorous data science methods, state-of-the-art software development, and implementation science to support decision-making for nurse clinicians, patients, and caregivers. His application of advanced data analytics to nursing-generated data has led to successful systems that predict patient deterioration 1 to 2 days before hospital deterioration, and that's what you're going to be hearing about. And I have the great pleasure of being able to work with Kenrick also in my position at CHOP. So, on to you.
Thank you so much, Sherry. Can you guys hear me? Awesome. That was a mouthful. So it's my honor and pleasure to present to you some work that I've been doing for quite a while. I think it's really important to point out that what we're about to talk about looks like we just did it overnight, but it was actually basically like a 14-year-old journey. So when I was a young nurse and also working as a programmer in the New York Presbyterian IT department, so I like to joke that I'm your run-of-the-mill Caribbean New York nurse, which if you understand that joke, it means you have at least 3 jobs. And so when I got out of nursing school, I was already a programmer, and I've always worked nights clinically, both in oncology and emergency department. And I said, hey, since I'm only working 3 days a week at night, I can work during the day in the IT department. And so when I was doing that job, I already started in graduate school. And one of the things that I was interested in is, as an oncology nurse, I would have experiences, especially, on the floor as an oncology nurse, where I'd have a patient and I would see subtle change in the patient state. So I'll give you an example. So there's a certain type of guy that I had, I'll call him John. And John was one of those guys from, what we call the greatest generation, the guys who served in World War II. Unfortunately, as time goes on, there's less and less of those guys. But, he's a proud guy, very stoic, doesn't show his emotions much. They'd always assign John to me because I'm a veteran. People like John. And so I come on the floor at night during shift handover, and the day nurse says to me, John wants to talk to you. It's like, okay. So I go to talk to John, and John looks up at me, starts telling me about his life, starts telling me how proud he is of his kids, his grandkids, his family, what he's done. And of course, I spent some time talking to John. And then usually the first thing I would do is I would leave the room and I would call John's wife, or I call John's daughter or son or whatever, and say, I think maybe you should come in and spend some time with John. And the reason I did that is because I knew from my experience in oncology, when people like John, who usually don't show emotion, start showing emotion, that there's something up with the patient, right? Well, we nurses say, quote unquote, up with the patient. And so, and then often I'd go home, and a couple of days later, I'd hear that John declined, and maybe transferred to the ICU. And so when I started doing modeling of patient data, I was really interested in, when I got into graduate school and started thinking about what I was going to do, that was the thing that I was interested in, is that nursing intuition, how to model that, right? At the same time, around the same time, I was working as a programmer in the IT department, and I was pulling data for a researcher at the Department of Biomedical Informatics at Columbia, a guy named George Wipsek. That's how you pronounce that funny Eastern European last name. And his project was an interesting one. He wanted to understand, when clinicians write clinical notes, who reads them? How's it used after it's written? This was, 2009, 2010, 2011. And we had just, as an enterprise, gone all the way from paper to electronic. So everybody was very excited about mining the electronic patient data. So I pulled the data for that project, for this publication that came out in 2011. And it was really interesting. So I'm curious, when you think about, so what you see here on the screen is when you think about the documentation pattern of a nurse takes care of a patient, and then they put their clinical expertise about what they did and what they think should happen for the patient in their clinical note, right? So percentage-wise, I'm going to just do a little exercise. How many people think that nurses' notes are read by the rest of this interdisciplinary team 50% of the time, after it's written? 60% of the time? I see a lot of head shaking, so I'll go backwards. 40% of the time?
I'd say 5.
You guys are right. So unfortunately, less than 10% of the time, all right? And the reality is, when you look into how they did the analysis, it's actually closer to 3% of the time, because that 10% is if the note was ever read. But if you looked at if the note was read within 30 days, it was closer to like 2.5% of the time, right? So that was really shocking to me. I mean, basically no one reads nursing notes. Not even other nurses read nursing notes after it's written. So the answer to that question is no one really reads nursing notes, right? Yeah, but what percentage is that, right? When you think about it, right? Yeah, unfortunately, if something really bad happens, right, they're going to be reading that note real fast, right? Those notes, and so that started me really thinking really deeply about pulling in that information from for the perspective of how can I share nursing expertise with the rest of the interdisciplinary team, all right? So that's one piece that kind of drove me to what I do. The other thing is, in working with data, and at the time I was working with all the data in the EHR and other systems. One of the things that really became clear to me, and one of the things I'm going to try to convince you guys today, hopefully when you walk out, you'll believe this, is that nurses are great sensors of what's happening in the enterprise. And what I mean by that, from an informatics perspective, when you think of people, process, and technology, I spent a lot of time trying to find signals about different things in data. And when you think of what's happening in the hospital, most of those signals are in the nursing behavior, right? The signals of what the physicians are thinking, social work, respiratory therapists, everyone, you can typically find that information in nursing data. And not only that, as things change from hour to hour, it's the nurses you see the changes reflected most accurately, most validly, and most reliably. So sometime around 2011, 2012, I started using a lot of nursing data in my work as data science work. And everyone told me, Kenrick, you're on crack. It's nursing data, and nursing data is, it's dirty, it's not standardized. Dirty in the sense that, you know, if you ever looked at pain documentation, for example, right, you know that it's inconsistent. And that's just one example. And so they said, you're crazy. And so what I'm going to talk to you about today is a project that myself and a longtime collaborator named Sarah Rossetti, Sarah and I went to graduate school together, and we were interested in the same thing, and we decided to create a program of research around it. It's the Concern Project. And it's basically a clinical decision support project. And I'm going to talk to you about what we've learned from modeling nurses in this. And so Sherry already introduced me, so you know all of the letters that are behind my name. I think it's also important. I'm a big fan, you know, from an informatics perspective, I'm a big fan of context. So I think it's important for you to know who you're talking to, right? So as Sherry mentioned, I'm a veteran. At the ripe age of 25, I joined the Army as an infantryman enlisted. Actually, when I went to basic training, they called me grandpa because I was 25 years old. I was literally the oldest person there. There were 16-year-olds there at the time. So I did it after college. I'd already started my first software startup when I joined the Army. And then eventually I became an infantry officer. The reason I bring that up is because it shaped who I am. If you've ever had the pleasure of being in the military, you know that it shapes who you are. And so I think about things, I think about targeting, I think about exploiting, all of those great military terms I bring into my work as a nurse, and all the other things. I'm also a nurse, worked in oncology, emergency department, both adult and pediatric, and I'm a technologist. Those are two startups that I've had. They still exist. I think that the way you get technology to people is by bringing it in front of people. And then I spend my time, so I'm a clinical informaticist and I'm also a data scientist. So I'm kind of the rare person, kind of incorporate two things. I like to do both. So every day I do a little bit of data science and I do a little clinical informaticist. And then finally, I'm a nurse researcher. I think it's really important. So I take my data science and informatics skills and I apply it to nursing science, so I work at CHOP, and I've had to explain to a lot of my physician colleagues what nurses research and that there is a nurse science still. And I'm always gobsmacked when I have to do that, but that's just the way it is. And then I also I also spend a lot of time these days also just mentoring other nurse scientists as well. So, show of hands, who's ever heard of the DIKW framework? Yes, it's good. That's good. We're in a group of very educated people. So this is basically the theoretical framework that drives what I do. You know, I got a PhD, so we think a lot about theoretical frameworks. It's really helpful when you're doing research. It helps encapsulate and drive what you're doing. And this graphic is from a paper that I wrote with Kathleen McGraw, who's CNO at Microsoft, and Sarah Rossetti. And the reason that we wrote this, it was actually interesting. So Kathleen, I interacted with Kathleen a lot, and she came to me and she said, you know, a lot of nursing leaders are asking me, how do you think about AI, decision support, and strategically? And it's like, oh, that's really interesting. And so I said, let's look at the DIKW framework and let's put a strategic axes on it. So what you see here on the left are, you know, and we were talking about strategy earlier, and I love that slide, by the way, Constance, that slide putting strategy and tactics. Can't tell, Sherry's heard me, I can't tell you how many times I've tried to say to people, what we're talking about is tactics, not strategy. You're talking about, you know, that was, I took a picture of that slide. So, yeah, I'm going to steal it. I'm going to steal it. I'm going to use it. I will. But yeah, so when you think, you know, for folks that aren't familiar with the DIKW framework, and by the way, this is a framework that came from the information sciences, and it was nurses that added wisdom to it, by the way. So kudos to us. But so the idea is that as you go up, every time you go up to a different color, you're doing a transformation and you're hopefully getting something out of it. So you start with data. So on the left is the way you should be thinking about it strategically. On the right, in those white boxes are just kind of descriptions about, you know, what it is, how you can use it. So you're generating a lot of data. And by the way, most of the data in the EHR is entered by nurses. So that's another reason I'd like to work with nursing data. From a data science perspective, there's lots of data there. And if you want to, you know, one of the things you want to do on the right is you want to facilitate data capture. You actually want to, you know, we're talking informatics about people, process, technology. You want all of those things to line up so that you have good data capture. But then as you have the data in, you want to transform it into information to meet the information needs of the users, right? And that's typically your short-term strategy. And you actually want to try to minimize how much data that you're pulling in as well. And then as you go up one other level, you can think of software and interventions to transform that information into knowledge, right? And that knowledge is often guided, you know, when you think about the basic decision support tools, that's what we're talking about. And then finally, the long-term strategy is like, hey, how can we take this knowledge and make it wisdom? Something that really can augment people's clinicians, patients, family members, how they move through the world, how they do their work. And so in that, you have things like predictive analytics, you have things like precision, personalization for the nurse. You have things like taking into consideration patient preferences, which is something we don't do very well, by the way. And then also social and behavioral determinants of health. So this is like, you know, if I was to get a tattoo, I don't have any tattoos. This is what I'd get, right? You think I'm joking? I'm not joking. So this is, you know, this is the framework that guides my work. So so we had this idea that we would build models. So both Sarah and I had a clinical perspective, and we'd actually done a lot of qualitative work with nurses, just asking them, when you're concerned about deterioration, what do you do? How do you think about it? Where do you put the information? All that stuff. And the same themes kept coming up. Nurses say, when I think there's something up with the patient, I pay more attention to the patient, right? And so we said, okay, that's cool. We think we can try to model that attention, that certain increased level of surveillance. And so we did a paper that we published in 2013, where we took a cohort of individuals that had a cardiac event and individuals that didn't. And we looked at just a couple of different, just a handful of behaviors in the EHR. And they were basically just around documenting vital signs in the flow sheet. And what we found was that when a nurse optionally decides to right-click on a flow sheet item and write something in it, there's a strong signal of deterioration. And I'm not talking about, so if you look, and this is, this is a statistical analysis. So, but if you look at it, there was a statistically significant difference for patients who had more than 2 flow sheet comments in a 12-hour, 24-hour period. It was statistically significantly associated with an event happening 3 days later, right? And so we were very happy about that, because what that said to us as data scientists was that there was a signal in the data that we could model out. And so, so what we did was we submitted a large grant to the National Institute of Nursing Research at the NIH to do a project called the CONCERN project. So CONCERN stands for Communicating Narrative Concerns Entered by Registered Nurses. I love the word concern. Sarah was the one who came up with it. I'm not that crafty. But I want to highlight that the word communicating is the first word in there, because what our kind of North Star was sharing the information with the interdisciplinary team. It wasn't actually creating some really cool predictive model. It wasn't about employing AI. It was that we wanted, like I said at the beginning, we wanted to share a nurse's concern about a patient deterioration with the interdisciplinary team. And so the project was a multi-site. This version of it, what we call CONCERN 1.0, was a multi-site project between Columbia University, Presbyterian, Harvard, University of Mass General Brigham. These are our team, first beginning team members. Sarah and I were multiple PIs on it. Patty Dykes was the site PI up in Boston, and we had some really cool advisors. And so one of the things I want to point out about this is the issue of modeling nursing behavior is not an easy one, actually. It's actually a really hard one. And so for us, our team is made up of a real interdisciplinary team. So we have a theoretical physicist on our team. David Albers used to study black holes. We have a theoretical mathematician on our team, Chris Naplin, and a biostatistician, and physicians, programmers. And it really took them to be able to really exploit nursing data and to try to answer this question. And so what we promised, what we promised the NIH we were going to do was this. So in 3 aims, we said, hey, we've already started modeling out nursing data. In the first aim, we're going to create a better predictive model. We're going to use natural language processing to look into the notes to model out deteriorating concepts in the notes. So natural language processing, if you've ever, just think about it as if you've ever spoken into a smart speaker, it's the process of taking something generated by a human that a machine could understand or vice versa. And so we spent a lot of time we spent about 2 years building out technology to look at notes and say the nurse is concerned about deterioration, either in a note or in a comment. We built machine learning models to understand the stuff that's in notes, and then all the other nursing behavior, and then we did predictive analytics. And then also we were building, so again, people process technology, we had to surface this prediction to people, right? And so we built a smart app doing a bunch of user-centered design, which is basically focus groups with nurses and physicians, to just ask things like, what do you want? What do you want it to look like? What do you want to see? What's going to be helpful? Where in your workflow should it be? And we did prototype development and simulation testing. And then finally, the randomized control trial where our primary outcomes were mortality and length of stay. Why mortality and length of stay? Because that's what people care about when they're making decisions, how to spend their money, right? I mean, that's just straight up. Aim 3 for us as nurse researchers was really important because, you know, we clinically knew that there was something important here. I knew from working with the data that I could see a lot of signal, but we needed to put out into the world the science in as highest clinical journal impact factor that we could, that whatever we found was meaningful. So that's why aim 3 is there. It's also there because I mentioned the outcomes. If we were to say, hey, we created this great thing called concern and we want to implement it in your system, then, you know, before I was mentioned ROI, we had to be able to say to somebody, you're going to get some good ROI, right? And mortality and length of stay is good ROI, right? We don't want people to die and we want to reduce the length of stay. So what is concern? Basically, it's an early warning score, early warning system. Back in the, you know, those 2000 days when we started putting everything into the EHR, people were really excited about early warning systems, right? We're going to take all that data and we were going to do early warning. For us, what early warning means is actually predicting deterioration. So that's really important to us. And we're using nursing documentation. So our work is really revolutionary because we're not modeling the patient. We're modeling nursing behavior. So if you've ever worked with like the News, the Muse, the Pews, even the Rothman Index, what they do is they look at, actually Rothman asks some questions of the nurses, but all the other systems, they are saying, hey, what's changing about the patient physiologically? For us, we know and we've seen both from clinical research, just basic physiology, if your vital signs or your labs are getting out of range, it means you've already started deteriorating. So you're no longer predicting deterioration. You know, when you look at something like the News and the Muse, you're basically just monitoring deterioration at that point. So we wanted to create something that was actually going to predict deterioration before it started. Or more importantly, at a time when you could clinically intervene and change the outcome. And so we're basically modeling nurses' expert judgment about what they think is happening with the patient. And more importantly, we are not increasing documentation burden. In 2010, documentation burden wasn't really a phrase that people were talking about. But for us, it was, you know, as clinical nurses, it was important to us. We weren't going to ask the nurse to, for example, at the end of your shift, say if you were concerned about this patient or not, because we didn't want to add burden onto the nurse. And so I'm going to show you something. I don't want you guys to freak out. See, So, and this got messed up, but I think we can figure out the gist of it. So one of the first things we did when we started data mining the data is we took the data and we sliced it up. And what we're looking at here are some different vital sign entry patterns. So on the left are on the x-axis is time. So this is midnight, and then this is like 8 o'clock in the morning. You go to the end of the day. So and on the y-axis is the probability of a vital sign or an event happening. This big orange line is actually discharge. So you can see here, no one gets discharged at 5 o'clock in the morning. And the reason we did this was we wanted to make sure we had like a quality check to compare the data. So, but the rest of the lines are patterns of vital sign for different aspects of vital sign entries throughout the day. And some of it is like, one line is just, like SpO2. One line is SpO2 comments, things like that. But the thing I want you to take away from this, and this is actually, this is the kind of stuff that gets me really excited, is that you can see there's a nice pattern here. It's actually a nice sine wave. And what, in data science, if there's a pattern, it means that AI can do a really good job of modeling it, right? And so we created thousands of these visualizations looking at different items that nurses were documenting. And then we finally got to this through data mining, which is basically just the vital signs. So we had taken 2,500 flow sheet, different types of flow sheet entries, both in Boston and New York, and we did data mining on them. And then we ended up with just vital signs because we wanted to find behavior that we felt was more universal and vital sign that is related to surveillance, and vital signs ended up being that. And so we were very happy because this meant that we could do some machine learning and we'd be able to create really predictive models. And so we did that. We applied a bunch of learning algorithms. We ended up using a gradient boosted machine model. You don't need to know exactly what that is, only that it ended up, and we basically used 24 hours of data, previous data, to predict the next 12 hours. We ended up getting 97% accuracy in the ICU and 97% accuracy in the med-surg or acute care setting. The thing that I think I want you guys to take away from this, our approach, this is average. All of these metrics are average because what we actually ended up doing was we ended up doing what we call an ensemble approach, where we created a bunch of models for different situations. What we realized, and this shouldn't be a surprise to you, but from the computational stuff, is that your length of stay matters, right? And what I mean by that is one of the big problems you have when you're trying to model these types of systems is there's this concept called time variation. So the variables that we're using, like a vital sign, means a different thing at a different time. And that's a hard thing. Computation, there are different ways of handling it. And what I mean by that is if you are a nurse and you are waking somebody up at 2 a.m., 3 hours post-op, it means something different than if you're waking them up 4 days post-op at 2 a.m., right? So that's the time varying part of it. It's the same variable, blood pressure or heart rate, but it means something different at different times. And the way we ended up capturing that, and there's lots of fancy ways to do it, but the way we ended up capturing that was creating best performing models for each hour of your stay. So that, and then we had to do it one set of variables for the ICU because behavior is very different in the ICU and deterioration is very different in the ICU. And then we had to do a different set of variables in the med-surg setting. But then there was other wrinkles that we found that was interesting. Nursing behavior actually ends up being very different on the weekend than on a weekday, which makes sense. But it's different at night than during the day. It's different in the summer than in the winter. So that's how we end up getting to about 1,300 models, right? And so what our system does, actually every hour we make a prediction. It knows how long the patient's been in that setting. It knows what day it is. It knows what season it is. And it picks the right model that we've developed that performs well for that situation. And we run the data through that. So that's how, so I just want you to know that this is an averaging of the performance of all those models. And that's, you know, that's a very important thing because when you talk to data scientists, they don't tell you some of those kind of details. So this is our model. Our model, we ended up, we actually had, we have like 4 models. This is version 3. And our model ends up really looking at just counts, frequencies. So how many times did a nurse enter these vital signs in the last 24 hours? How many comments are there? We found a really strong signals in medication administration. Not only frequencies, but if a nurse decided to hold a scheduled medication, there's strong signal. And also, and PRNs given, things like that. And then I mentioned, you know, the temporal data and then demographics. And I'll talk about demographics in a second. But one of the things I want to point out, this is actually version 4 of the model. Version 3, we had, I told you, we did natural language processing where we were actually looking at the percentage of deteriorating concepts and notes. We actually ended up taking that out because we created a better performing model without looking into the note, just looking at the pattern of note writing. And the reason we took it out actually is a silly reason, which is intellectual property. The folks at most of the NLP work was done at Harvard. Harvard thought they were going to make a lot of money off of it, and they wanted to, you know, started fighting over money, and the rest is history. And so, but yeah, so, you know, the take home message there is really just the nursing behavior. The content of the note is actually not that important. It's actually, when you think about it, and I give these examples, but I want to point out that the AI is learning much more complicated relationships than the examples I'm giving. But, you know, if the practice of a unit in a hospital is that on average, nurses typically write like 1 progress note a shift, and then you see nurses writing 3 or 4 notes that shift, you know that there's something going on. I like to say nurses will typically triple and quadruple document in the sense of they will take a vital sign out of range. They will contact a prescriber. They'll write a note that says they contacted that. They'll write a comment in the flow sheet that says that the vital sign was out of range and they contacted the prescriber. And then they might write an additional note saying that they contacted the prescriber and the prescriber hasn't responded, or, you know, so you end up having 4 signals in the data about that one concern of the nurse. And so it works out for us. So, so one of the things that I learned personally, and I like to share this with the world, we learned through doing validation and quality checks. So what you see here is it's a thing that we always do when we say, hey, let's look at the data and let's compare what's predicted and what's expected. You know, so and one of the things we found was there was a difference based on concerned deterioration based on demographic factors. So We generated a concern score, but we ended up going with the stoplight metaphor, green, yellow, red, right? And so as patients deteriorated, when we built our first models, when we didn't have demographics in the model, by the way, we found that for Black patients, we under predicted. For Asian patients, it was pretty much flat, and for white patients, we over predicted as patients got sicker. Just modeling nursing surveillance and behavior. So we looked into the data to see if something's going on in the data, if our analysis was wrong. And then we went to the nurses and we talked to nurses. And basically what we realized was that nurses were paying more attention to white patients as they deteriorate than Black patients. And when we looked at other demographic factors, this was true also for patients where English was not their native language. So we under predicted for them. And so we said we needed to correct for this in our modeling, or else we'd have a biased model. And so I mentioned the interdisciplinary nature of our team. So myself, a data scientist, theoretical physicist, mathematician, biostatistician, we all got in the room and we argued for about 3 months about the best way to predict to de-bias or fix this. All of the methods we tried ended up adding our own bias. So the method itself added its own bias into the results. And so we ended up, what ended up happening was that gradient boosted learning that I mentioned, when we added the patient's demographics into it, it learned how to adjust. So it learned if you were a Black patient that you need to adjust by a certain amount. And so that's what we ended up doing. So really quickly, we did a study where we wanted to see if our adjustment worked. We did a bunch of things, but this is just one where we actually compared concern to the news and the news to see if there was a statistically significant difference between our prediction of yellow patients by race. And we already knew that there was a bias in the news and the muse. And so graphically, what would happen is if the prediction was the same this is a probability distribution. If it was the same for both races, the two colors would overlap perfectly. And they don't, and they never do. But you can see, when you compare that they don't overlap, they overlap much worse than concern. But when you take the average and actually do a statistical analysis to see if the average is statistically significantly different, we found the concern it wasn't, but for the news and the muse it was. And so that was one of the final analyses that we did to just make sure that we were doing what we could. So what can we do about this bias? So we know as clinicians that no one shows up to work and says, I'm going to treat a patient in a biased way. Like I personally never met a clinician like that. And I've met thousands and thousands of clinicians. So do no harm is something that we all care about. But I also think, as nurses, we have the 5 rights, right? And so one of the things that we really need to, I think, a way to think about it is the 5 rights. Think about this AI. Does it work the same for all of the patients? And the thing is, it doesn't have to, because in a lot of cases, you're not going to generate an AI that does that. But the more important thing is for the clinician to know that it does it. For that AI to tell the clinician, like, hey, I have an Asian woman. Our modeling has shown that it actually, doesn't work as well for Asian women. And for the clinician, especially the nurse who is where the rubber meets the road, might make a decision about whether that should happen, right? Is it an appropriate intervention for the patient? Is the timing right? Is it the right amount of intervention? So the 5 rights is a way to think about it. And then finally, is it an appropriate intervention? So There's some other things that, from our work, we found that we think is important, which is we as nurses, so both Sarah and I are nurses, and we've led this project. And neither of us are practicing nurses anymore clinically. We always make sure that they're practicing clinicians, nurses and physicians at every stage of the project, right? And so one of the things that we found when we were putting in clinicians is they really don't understand how AI works. And so it's really important for nurses to be knowledgeable, to be able to advocate about bias, to understand how AI works. And then finally, for nurses and clinicians to be involved in every stage of the process. So clinical trial time. Thank you. So what we did was we built a system that in the back end is doing this stuff. It's pulling in the variables, it's doing scaling, it's creating features, and then it's generating a score from 1 to 10. And we're assigning red, yellow, green. And this is what it looks like in the system. So we ended up putting the concern column. So we write the concern score as a flow sheet item back into the system. So that allows us to configure it however the EHR configure stuff. So that's how we configure it. Also, we put this asterisk here that tells you that the concern score has changed since the last time we calculated. Right now, we're calculating every hour. So clinician could and we picked the patient list because we knew that both nurses and physicians use it for the clinical trial. And so if you want to learn more, you look at this and you already learned most of what you need to know, but you want to learn more, you could double click and it would launch this app. It's what's called a Smart on Fire app. It's basically a web app that is built so it's interoperable. You can snap it into all the top 3 EHRs that are fire compatible. And what it's doing, it's pulling out additional information for the user. So it's the patient, so you have the header at the top. The most important thing is what we call the factors pane in the middle. This actually tells you, these gray bars, if you can see them, it tells you what bucket of variables is driving this concern score at this time. So it gives explainability to the model. The physicians wanted this. It actually tells you where in the distribution of patients. So if it's in the ICU, it compares this patient to all other ICU patients. And the same thing for MedSurg. Where they are, the percentile wise, and then you can toggle the trend over time. So this is just additional detail that you can look at. Also, you can see here, we have medication administration as an example. Clinicians wanted, they thought they had a hard time finding the MARS. So we actually tell you what the medications that were administered for the patient in reverse chronological order. Up in Boston, they actually added this. This wasn't part of the trial, but the rapid response team wanted to see. So this is a dashboard they had before. They wanted to see what the concern scores were for patients on every unit. So you could pick a unit and it would show you the concern scores at any given time. So this was a trial. We randomized on the unit level. 2 hospitals in New York Presbyterian, 2 in Mass General Brigham, 1 large academic medical center. Newton Wellesley was this like a small community hospital. Brigham was a large one. Milstein at Columbia, the Allen, and we randomized on the unit level. So if you were in an intervention unit, clinicians could see the concern score. If you weren't, it would be gray. Crafty nurses figured out how to configure in the control units how to put concern in, but they only saw gray circles. So very quickly, we were able to get some really cool results. We found a decreased risk of mortality by 36%, decreased risk of length of stay by a day, decreased risk of sepsis, and increased risk of transfer to the ICU. So one of the things I like to talk about is the transfer to the ICU. So one of the things, when you think about concern, at first we're just like, whoa, increased risk of transfer to the ICU. That's not good. Then we realized that it's actually good because what we're trying to do is get the person to the right level of intervention. And we did a sub-analysis and we actually found that when people were transferred early, meaning closer to the change in concern score, they had much better outcomes. They died less and they had shorter length of stay. So just really quickly, I want to wrap up. This is what we're up to now in Concern 2.0. We actually have a 3.0 now too. We're spreading it to different sites and doing implementation science. So we're implementing a pediatric concern and also an emergency department concern. Those are actually very different models. So we're building the models and then doing that. And then we're looking at ways to detect bias and improve understandability. So in conclusion, I hope that you believe that nurses are great sensors, that we can model expertise, and that clinicians should be included in the process. And finally, the bias needs to be accounted for. So thank you so much. Couple of minutes for questions. So thank you.
Thank you. I think that was a fantastic presentation.
Thank you.
We have data scientist team that work with our clinical informatics team every other week we meet. And man, if any of them were also nurses, now that I've listened to you, it would be like utopia for me at work. So I do have a question, just out of my own curiosity. Did you get any insights when you were looking at the data as to if there was a difference between a new to practice nurse, a novice nurse, or an expert nurse?
Great question. So I had a graduate student named Jessica Schwartz look into that. And what she found, she was looking at documentation patterns. And what she found was that there is a difference. The interesting thing is, so experienced nurses document very differently than novice nurses. But what she found was interesting is we actually looked at what was happening at the floor. So the interaction effect. So when the units got busier, both groups of nurses tend to revert to the mean and document in a similar way. And so we then looked at just, our bed, like the bed occupancy and things like that. And it turned out that in our trial and in both of the settings that most of the time, 95% of the time, people were very busy. So that difference in documentation patterns really didn't matter because nurses were always busy. Yeah. Yes.
So I have a question specifically for oncology patients.
Yes.
Because I saw on your one slide you
We exclude, so my chagrin, we exclude oncology because just so if you've ever worked in oncology, and we also exclude inpatient psych because deterioration means something very different in the psychiatric setting. And in oncology, we expect a certain kind of deterioration. The deterioration looks different and nursing behavior is different. So when you're on a course of chemo, sometimes there's a deterioration that's expected and you're not going to transfer someone to the ICU. And you're not necessarily going to pay more attention to the patient because you know that deterioration, that, like a lot of oncology meds affect organs. You see basically like organs shutting down, things like that. And so we're going to circle back to oncology, but it just wasn't generalizable enough to compare it to the other places.
And then also you said you excluded DNR or DNI patients,
and hospice.
Did you separate DNR and then DNR DNI?
No. So what we did was basically what we would do. So there was two different strategies for hospice and DNR DNI because people go on and off DNR DNI all the time. What we did was so once a person was on DNR DNI, we stopped calculating the scores, and then once they got off, we would wait a whole shift to start calculating again, because one of the things we learned from qualitative was that it took about a shift for everybody in the team to realize that the person was off DNR DNI. So we waited a whole shift to then start calculating their concern score again.
We're just gonna take one more question.
Sure.
And then Travis will-
Yeah. And I'll be around for the break, so if you have questions.
Awesome.
What's,
It's great presentation there.
Thank you.
I love data. So mathematically speaking, we know there's always a threshold of when a change is guaranteed
Yes.
to occur there. So I was wondering how far out, hours, days, or whatever, is your predictive model able to actually predict that change is going to occur?
42 hours. 42 hours, our model. And then I have to point out, so there's two pieces to this. There's a model that produces a probability of deterioration, and then there's a risk stratification to generate the score. So we did all of the data science stuff to do the modeling and then validated that with the outcomes that happened in the future. Then we did simulations with clinicians to understand what the thresholds should be for green, yellow, red. And one of the things we did with the thresholds was clinicians actually told us, we know the green patients and we know the red patients. What we need you to do is help us understand the yellow patients. So our thresholds in the risk scoring are optimized for those yellow patients. And one last thing I also want to say, and this might be a little weird, sometimes I don't say this, but I trust you guys, is that the modeling part actually doesn't matter in this intervention. What actually matters, and Patty Dykes did some work for a conference submission just at MGB, is that people are using a tool that they trust and the information is being shared, and then around deterioration, and then clinicians are actually intervening early. Like that's what actually matters. So whether the tool, as long as the tool is better than chance, really at the end of the day, because clinicians have the clinical training to intervene once they've identified somebody that is deteriorating. And we have, if you're old enough to know $6 Million Man, we have the technology to reduce, to have positive effects on some of these outcomes. So it actually doesn't, for us, I'm a geeky guy. I really was very excited to create a highly predictive tool. But, those numbers really don't matter. It's just that as long as there was a connection between, clinicians are using it and saying, oh yeah, concern says this patient's deteriorating, and this patient is a patient who's deteriorating, and both the physician and the nurse are seeing this. So I just want to point that out. And finally, once we got out of the trial, we added concern to the brain for nurses, because that's where nurses do most of their work. And then at Columbia, we did something where they went all in secure chat messaging. So the concern score is actually on every message that's sent between clinicians, the concern score is there. So thank you so much.
So now I'm going to announce our next speaker. Her name is Dr. Sherry Duarte. And she is not only on the committee that put this great event together, but she is also a nursing informatics senior project manager at Children's Hospital of Philadelphia, or CHOP, where she leads the development of the Nursing and Clinical Care Services platform. This innovative system integrates near real-time workforce and unit-level data to support nursing leadership, inform clinical practice, and advance patient outcomes. She earned her BSN from the University of Pennsylvania, an MS in Healthcare Informatics from Grand Canyon University, and a DNP from the University of Arizona. Her background spans emergency and pre-op PACU nursing, cardiothoracic and post-lung transplant care, and air-ground transportation before transitioning to healthcare IT leadership roles. She's an ANCC certified informatics nurse with CPHIMS and BRMP certifications, and expertise in optimizing workflows, driving technology adoption, and using data insights to strengthen nursing practice. Dr. Duarte is active in professional organizations, including HIMSS, ANIA, and Sigma Theta Tau, and GDV hymns, GDV ANIA and GDV hymns. So the main groups and the subgroups, and serves on the Penn Nursing Alumni Board. Outside of work, she enjoys traveling, reading, good food, and life with her husband and 3 dogs. Please welcome Dr. Sherry Duarte.
Can you all hear me? Is that okay? Okay. And we now have 4 dogs. My husband just adopted another little pug. So, yeah. Hold on, let me get myself together. So BRMP, for those of you that probably aren't familiar, it's Business Relationship Management Professional. I got that a few years ago in one of my last roles when I was in Arizona. And it's one that is, I use across the board just in general. Let me make sure I'm going in the right direction. Okay. So I'm here to talk about my job at CHOP, essentially. That's all about me. No disclosures to report. So basically what you're gonna get out of this is the theoretical influence that we have used behind our platform, the multiple data sources and how they intersect to help support our nursing and clinical operations. I can't wear these, sorry. Explaining the importance of standardizing and simplifying data visualization, so how data is visualized matters. And so hopefully you'll be able to get an understanding of why. Strategies to help users become more proficient in using data, and then usability and why it's important. So CHOP. CHOP is the oldest pediatric hospital in the nation, which I think is really cool. It's been around since 1855. It is a not-for-profit hospital that does generate a lot of revenue, both operationally and in research. We employ over 5,600 RNs, and I know the exact number, and you will see that later, out of our nearly 20,000 employees. So very large chunk of our employees. We are a large health system with 2 campuses. We have our main campus in Center City, and then we also have our Parsha campus, in addition to multiple primary specialty and outpatient surgical and urgent care centers. One of the things that still impresses me every time I pull this data is the number of outpatient visits in CHOP. I mean, over 1.6 million. That just boggles my mind, and it just keeps going up every year. So, I mean, that's just particularly impressive. Really cool place. I will tell you too, I'll get there in a second, but lots of awards, lots of recognitions. And that data I just showed you is from fiscal year 24. We are one of the premier children's hospitals. We have been top ranked. Just recently in 2025, we were ranked number 3 among pediatric hospitals and world specialty hospitals, but we have all this great stuff. We just last year got our 5th magnet designation, so I think that's really cool. So it's a great place to work. Really happy to be here. All right, so I'm an informaticist. My job now is data dashboards, which is something that I had not done before until I came to CHOP. So this was learning new skills, learning new set. So I tried to put me in one page using pictures. I don't recommend from a cognitive burden standpoint that you put so much information together like this. And this is one thing that we have had to fix since I came. But they say a picture's worth 1,000 or more words. And so this is just me in a nutshell. I went to Penn, Grand Canyon, University of Arizona. I mean, this is just my professional journey. As you can see, I've worked at a lot of places. This nursing experience, these are all the places I've worked. The ones in the top row, those are my full-time jobs. So I don't think there's been many years, if any, where I haven't had a side job. I still have a side job. My side job, this is my full-time job. This is my other side job. So I also work weekends caring for elderly participants at Trinity Health PACE. So it's, I'm so sorry. Oh, okay.
One on Zoom is, we think it might be.
I can do you want to switch it? You can put the lock if you want. Are we still?
what? I think it's.
What are they hearing on?
We're hearing that. Clear, the sound is muffled, it's difficult. Okay, so let's switch it.
I tuned it off.
I wanted to make sure that one was off, but I've been trying to figure out this. Let's try this. That's okay. Hold on 1 second.
Are they invites?
Yeah. Oh, that one's gonna be, I have a big voice, and that's gonna go back and forth and back and forth. Let's try this. The other one off, right? Yeah, I turned it off. Is
this any better? Do I still sound muffled? Okay.
I know, it sounded fine to me, but they were saying it sounded very muffled, so hopefully.
Okay, so just let me know. Thank you.
Sorry.
Oh, it's okay. So anyway, as I was saying, I still do have my clinical practice. Working there has been something I hadn't done before. And it just keeps me clinically in the game and something I really enjoy doing. But as you see, I like to be busy. I decided in the pandemic it would be fun to start a DNP program, and then in the end of my first semester, moved from Arizona to Georgia. And at the end of when I was graduating, moved from Georgia to here. So I just like things a little crazy, but you know, I've done a lot of things, and I think that also helps with what we do as nurses. We really bring into our work as informaticists, because we do have that understanding of nursing. All right, so I'm here to talk to you about our NCCS form. NCCS is an acronym for Nursing and Clinical Care Services. That is what our nursing department at CHOP is called. And this is really the main focus of my job. So I am the project manager, an informaticist, and I manage the development of this platform. So we're going to start with theory. I don't know if you're anything like me. Theory was not my favorite. And that's why I kind of went the DNP route, because I also don't have the patience for the PhD route. But it's important, though, to understand this theoretical model, because it is the model behind our platform, the work of it and its design. So this synergy model is the nursing framework for NCCS, and it's what guides what we do on the platform. Dr. Martha Curley led the conceptual development of the model by the American Association of Critical Care Nurses to link certified nursing practice to patient outcomes. The basic tenet of this model, according to her, is that patients' characteristics drive nurses' competencies. And she states that when patients' characteristics and nurses' competencies match and synergize, outcomes for the patient are optimal. So just keep this in mind as I'm talking, and hopefully you'll see how it kind of comes together. The principles of the synergy model are that patients' characteristics are of concern to nurses. Nurses' competencies are important to the patients. And patients' outcomes result from mutually enhanced patient characteristics and nursing competencies. I'm very privileged to work with Dr. Curley. She is actually the driving force behind this platform and is, I guess, almost directly responsible for my job there at CHOP. I am an adult nurse too. I am an adult nurse in a pediatric hospital. So I've learned a lot going back about, peds. And she is she's a living legend in nursing and a very well-known pediatric critical care nurse researcher. So I am so incredibly honored and privileged to be able to work with her. And she and our CNO, Paula Augusto, are the executive sponsors of the whole platform and the work I do. And Dr. Curley is still very involved and very integral to the work in the platform, especially as we move towards incorporating the outcomes that she's looking to incorporate, that Anna was talking about in her blueprint work. So nursing characteristics. So along those lines, regarding nursing characteristics, Bach discussed the relationship between education level, specialty certification, and nursing experience and patient outcomes and satisfaction. And she also evaluated the impact of nurses' emotional characteristics of self-awareness and emotional intelligence on the outcomes of quality care. So I asked ChatGPT to create a rendering of a pediatric nurse with these characteristics. And let's see, and that's what it gave me. This isn't what we have at CHOP. But, you know, I just thought it would be kind of fun to see what it would give me. And then also talking about the qualities of a great nurse. So Bach also highlighted Kathleen Pfeiffer's ideas of the top 8 qualities of a nurse, as was posted in the 2017 blog. So Kathleen was the area director of clinical operations for Bayada Home Healthcare Skilled Nursing Unit when the blog was created. So we had these qualities, but then for what I'm doing on my project is we're trying to pull in those qualities that have been identified in the literature that make an engaged nurse and contribute to better patient outcomes. So things like professional development, advanced degrees, professional associations, teaching, and professional committee and governance involvement. I think that aligns a lot with what has been identified as that Bach was talking about based on what Kathleen Pfeiffer just declared was hers. I think that's in alignment. So again, I asked ChatGPT to create a rendering of the characteristics of a great nurse, and this is what it gave me. Didn't fit everything in at the bottom, however. Teamwork and leadership also includes mentors others and demonstrates accountability. And lifelong learning also includes seeking out continuing education and reflects on personal growth. And I think that that's something that we as nurses, especially informaticists, are we still having problems? Okay, we still good? And I think that, you know, as informaticists and nurses, we're all lifelong learners. And, you know, when we look at outcomes, and this is, I'm focusing on this because it's a big part of what we're focusing on in our platform. It's, you know, looking at those nursing characteristics and the patient characteristics, as you'll see here shortly. So that's the background. So let me describe the platform for you. It's comprised of two, so we call it a platform, but it really is comprised of 2 separate dashboards. So we have the unit profiles and the nursing dashboard. They provide, like was mentioned in my introduction, that near real-time aggregated data for certain metrics, and help the, the goal is to help nursing leaders manage their operations and clinical, but eventually we want it to be able to take those together and do, look at outcomes and how do the characteristics of one impact the other and how together do they impact outcomes. We're not there yet, but that's what our ultimate goal is, because I will probably forget to tell you that later. So while it's in my head, I'm telling you right now. Our data and analytics platform is ClickSense. So we use the term platform very intentionally because we have 2 dashboards, but we want to remind our users that they are connected, even though they're not really connected, but they are theoretically connected because they will inform the outcomes later on. ClickSense doesn't support the idea of a platform at this time. And the dashboards aren't even in the same place. ClickSense is organized into streams, and the dashboards exist on different streams for now. And a lot of that has to do with also who has access to the dashboards. So while it's not a true data platform, we intentionally call it that. And when I talk to our nurse leaders and I talk to any of our nurses, I always mention the platform and then spell out the 2 dashboards because that's what they recognize. So our unit profiles dashboard has unit-specific patient, clinical, demographic, safety observation, use, and harm event data. It's currently only limited to our inpatient departments. We are planning to expand that out to include our ambulatory care areas and some of our other specialty areas, but that's going to require thinking things a little differently with how we're doing the data. So we're hoping to be able to do that next year. The unit profiles is available to all of our nurses and providers. So we recently just moved it into a stream that's accessible to more users so that people could be able to go in and look at it and get a better idea of what's going on in the inpatient world. It's also based on discharge patient data, so that's important to also understand. Our nursing dashboard, which is where I spend most of my time since I got here in building out and validating, is our nursing demographic and workforce data. It's got patient experience data related to the nursing questions. We do have some HR protected data in there that is only available to our CNO, the associate CNOs, our project team, and anyone else who might have a business purpose to be in there. It's only available, so that one was limited. When I came to CHOP about 3 years ago, it was only limited to our senior nursing leaders. We have since expanded access to nurse managers, clinical supervisors, our clinical nurse specialists, safety quality specialists, so we're expanding as we go. Eventually, we want all nurses and everyone to have access, but all nurses aren't going to get access to it like our bedside nurses yet because there's nothing really useful in it for them. So we feel very strongly that if we want to give it to users, it has to have some use to them. So right now, really the nursing leaders and those that do support our nurses, we have, I think, more in there for them. So we continue to expand, and then as we continue to iterate, eventually it's, the whole idea is transparency and having anyone be able to have access. Of course, not maybe to everything that'll be in there, but to most of it. So this graphic is basically our I like something fell, sorry. How it shows how our platform's dashboards can support outcomes by looking at patient and nurse characteristics and their impact on the patient, nurse, and system outcomes. So you can also think of it as kind of a synergy model incorporated into our platform model. So just keeping that in mind, we're looking at all of that together. So we have goals. And we strive to meet these goals by providing data and analytics to support nursing work and analyze how the different and changing patient or clinical characteristics and nursing characteristics impact outcomes. So you're going to probably hear me say that a lot, but that's what our whole thing is about, is showing how those change and make the outcomes. We are still building the foundation, and it's slow. But you need that good foundation to be able to put those outcomes together and put that data together. And Dr. Cato is my colleague, and his wonderful expertise and knowledge is helping us get to that point of being able to put all that together with the outcomes and prediction and things like that. So I'm also extremely honored and privileged to work with him as well. So how we are also trying to get to this is by building a robust data and analytics infrastructure that automates integrating data from many disparate sources, creating that single source of trusted data for nursing analytics. I don't think we're going to quite get to a single trusted data source because we have a lot of different dashboards, but if we can at least consolidate, that's kind of, I've really gone from single trusted, although Dr. Curley really wants a single trusted, but I think if we can consolidate down, that's really becoming the goal. Having those key performance indicators with standard documented and approved data definitions, and that is something that we are continuing to work on. We are now, my data analysts and I are going through a metrics definitions review process because it's important to go back and look at them. Do they still make sense? When I first came, the definitions, it's important to say, when I first came, there was no nurse that was, they were high level. There was no nurse directly involved in the project. It was being run by a project manager from HR. So the data definitions were created by our data analysts. So one of the first things I did was say, I don't know what half of this stuff means, and our nurses aren't either. So I went through and with the team, we redid all the definitions from a more clinician focused point of view. Although some, there was back and forth with my data analysts because they thought it was important to include some data specific things. So we just kind of wordsmithed around it.
And then we used actually Dr. Curley's research assistant to help, who was not a nurse, to say, does this make sense to you? So he was our measure of understandability. So that's also important. We're also trying to provide self-service applications within the dashboard as much as possible to help provide insight into the clinical, financial, and operational performance. We will hopefully eventually, when we can get off ClickSense and with Dr. Cato's help, provide those basic predictive analytics tools to help support proactive decision making. So that is our ultimate future state. And then we have developed a curriculum and training program to help augment data literacy among nurses on the best use of basically ClickSense in our dashboard. So one of my data analyst that does our visuals, he and I put together a data literacy program focused on our dashboards, geared towards our nursing leaders, like our nurse managers and our clinical supervisors, and any of the others that want to come to make them get them more comfortable and proficient in using ClickSense, because it is not a very intuitive platform. So as you can see, this started in 2018. I said I've only been here 3 years. So this was conceptualized and started long before I showed up at CHOP. So a lot of work went into this in the beginning. I came in phase 2 and took over towards the end of that phase. We finished phase 3 last year. We are in phase 4. I don't have it in here. We started phase 4 in May of 24. And then right after that, they decided that data modernization needed to happen and we needed to move everything to the cloud. So that was a more than 6-month process. So most of our resource time ended up going into that. And that's fine. It was very important. It needed to be done. Things are definitely much quicker to load. So I would have hoped to have been in phase 5 by now, but things happen. And I only have really 2 dedicated resources. I have 4 that work on it, but 2 that are truly dedicated to this project. One is an amazing data analyst. So she's the one that has pulled all the data. She's basically created the foundation and the tables for the whole thing. And then and that's Maria, and I have Tim, who does the visualizations. And so I'm also limited by how much they can do. And there's a lot that we're asking them to do. So I think for what I have, we have done amazing work, and they just have produced wonderful things. But so we have been in phase 4 for a while. That work is focused on expanding our workforce data because initially it was just showing HPPD, so the inpatient data for volume staffing and things like that. We expanded that to include the non-inpatient areas, and that just went live earlier this summer. So that was huge. And that was a lot of data validation and working with, we are very blessed that we have a finance business manager who meets with us weekly for nearly 3 years. And she validates all that data with us. One of the things I was told when I came here was that the dashboard needed to replace her dashboard that she uses for business operations meetings, which is a huge, amazing Excel spreadsheet. So this she knows, but it's a completely manual process. And she's worked with us. We are getting so close to the point where she no longer has to use that anymore. But one of the things I did was take that to heart, and I said, let's make this sheet look like what they're used to seeing, which is what we did. And that has helped. But having her buy-in has been very important because the data doesn't always match what they are seeing. And I'll go into that in a little bit. But anyway, the other things we're looking to do is update our magnet, our RN excellence data. So it is a bit stale. It's from 2022. We didn't do RN excellence in 23, and we just haven't had the resources to work on the 24 data. That's next. We are doing RN turnover. So making sure that we're doing it to align so we can benchmark, align with HR. And then the first part is true turnover, which is the coming to CHOP, leaving CHOP. But what our managers really want to see is what are transfers?
I have a lot of transfers. That accounts for a lot. So that's our next step. And I've been pulling in some of our managers to help validate our data and give us feedback on what they're seeing. So I think that's also really important. So we've been doing all that kind of stuff. So still have a couple things. So turnovers about halfway there, and then we'll focus on the RN excellence, and then also pulling in nurse engagement data outside of RN excellence. So we don't have that. And the beauty of what they can see in our platform, or what they can currently see for the older RN excellence, is that they can compare to the other units. Whereas when they go into Press Ganey, they only see theirs. So that's the beauty of the platform, is that they can see other units and compare to like units if they want. So we're still, I don't know, we're still at the beginning of the timeline, I hope. I'm hoping that I have job security for quite a long time to come, because like I said, we're still really at the beginning. So there have been challenges. So it's difficult to come into a place like CHOP without working there clinically, because I didn't have the knowledge of the organization gained from being there for any length of time. I didn't know the departments. I didn't know the key players, didn't know the language. CHOP's been around for a very long time. It's Chopified. We call it Chopified. So there's a lot that's Chopified. That's fine. So it just takes time to learn all those things. And we also found that the platform was not being used as much as we expected initially. Still like to see a higher usage, but there's reasons for that. And as we add groups, our usage does tend to go up. Some of the reasons are that people just aren't as familiar with ClickSense. It is not intuitive. Also, we have a lot of dashboards. So especially our leaders that have been around for a long time, they have their workflows ingrained on where they go for their data. And I had managers say, when would I go to this? And I would say, go here first, because it was all aggregate data. Get your picture, and then you can go to where you normally go to drill in. We're still working there. I have found success in getting to new leaders who haven't developed those workflows yet. There's a guy that was an interim nurse manager. I met with him, introduced it to him, and he's like, I haven't been able to get the tools I need. I said, I will give you access to this. He is our biggest nursing user of that. So because I gave him what he needed, and then so he goes there. So that's super cool. But I think it's culture, it's workflows, and ingrained in where they're going. And we have to be better about consolidating. And I think what we're looking to do, as we think about it more, is maybe we're producing KPIs and then linking to what already exists there. So we're constantly, thinking about what does this look like, while also trying to stay true to what Dr. Curley also wants, because sometimes her ideas are a little different than what operations wants. So we're, trying to stay true to those things. I've also found that sometimes the users think they know how to use ClickSense, but they really don't. We have many different ways to slice and dice the data. We've got different filter buttons. You can create bookmarks, but it's again, not intuitive to do, which is why we developed this class, so we can show them, here's how you can do this. Here's how you can go look at things. So they don't really know how to tell their story in the right way, or they're not filtering things correctly. So that leads to some challenges. ClickSense, I'm not saying it's a bad platform. It's not. It's a great platform for simple data analytics and visualization. But what we're doing is, I think, more complex than anyone else in CHOP is doing. And so we make it work for what we need. But when I first came, it looked like my dashboard about me. It was like kind of everything was all on a page, and you just scroll down, and it was kind of the same data in different ways. So we ended up hiring a graphic designer for a short period of time a couple of years ago to help us with visualization, standardization, making it easier for people to come and look at the dashboard and understand what they're looking at without that cognitive burden. We would get, getting feedback on from our users, refining our metrics definitions, and that was, ended up being a really great thing. And guess what? She got hired by CHOP to do the same thing across our data and analytics department. So another thing we had heard too is that our user, the dashboards were all done differently. So there was cognitive burden going from one dashboard to another because they were all looking so different. So standardizing across the board also helps. And I think we kind of helped start that, and it's made a big difference. So we have many years and iterations to go. We're just starting with little bites from that elephant. So I don't ever want to eat the whole thing, but it's just kind of how I think of it. So we do have limitations, when we're working with our dashboards and our data. Like I said, much of my early work was spent learning the top language, learning the different roles. We have mic dropped. I'm done now. Mic dropped. So learning the different roles. Maria, my data analyst, did an amazing job of pulling all of our job codes together and creating categories. So what we've mostly focused on, because this is a NCCS or nursing department platform, is focusing on how do we categorize nurses. So we've got our bedside nurses. We call them, and initially they're in acute care, they're acute care RN, so those are inpatient bedside nurses or ambulatory RN nurses. And then our acute care RNs the RNs are then further characterized as staff nurses. So those are our bedside nurses. And those are comprised of clinical nurses, clinical nurse experts, and our nurse residents. And then we have our APRNs. And we had to work with our APRN leadership group to say, how should we make sure we were defining them right? So those are our nurse practitioners, our nurse midwives, APR, the CRNAs, and the CNSs. We also categorized a large group of system support nurses. I am one of them, as are my colleagues. Our nursing professional development specialists, our system support nurses, our safety quality specialists. Those are the nurses that aren't providing direct patient care, but they support our direct patient care nurses. So it's, making sure we're categorizing people and job groups in a way that the leaders know who's in them, and making sure that they have the definitions to know who's in them. So it's learning all these things that I don't think we ever had an SQS where I worked in Arizona. So, there's things are different out west versus out east too. So it's an iterative process. We are now going through the job groups again. And there's many that are general because Maria is not clinical. We've done pretty much all the nursing ones, and I think we've done a nice job with that. But there's other groups that are involved in providing nursing and working with nursing who are showing up in the workforce, and they're not well defined. So we are trying to define those so that the leaders going in know exactly who's, what overtime hours are being attributed to which job group. So that's a large job. And lucky I had some help. I've got some grad students helping me with that. Another thing is we've been missing some key elements like nursing education data. For Magnet, you need to know, you need a certain percentage that are BSN. We also like to know who's in school, who's got an advanced degree, how long have they been on unit. So we pull that data from Workday. We pull data from like Red Cat, we pull data from Workday, we pull data from Epic, we pull data from Kronos. So all sorts of different places. Most of the data that we have on our nursing dashboard sheet regarding our nurses comes from Workday. Gotta update their stuff. So we've had, that was a problem. At one point, we were missing like 30% of our entry-level education data for nurses. And that's whatever degree it took for them to be able to take their NCLEX. So 40%, 35%, it was a lot. So we went through a process with our, and once we gave the dashboard to our nurse managers, that really helped us a lot because they really wanted to know how many BSMs do I have? Well, go talk to your people and tell them to update their career profiles. But another thing that we found was that we were missing some key data elements, like our new hires. I'm like, why are we missing new hire data? It should be in there. You know, it's Workday. They just put this stuff in. We know it's there. It's missing a key data element of did they receive their degree? If it's not marked yes, it shows as missing. And that wasn't even in the HR piece of it. So we have an HR data analyst that found this, and she validated everything, and she went back and she backfilled it. And between those efforts, we are now missing, I think we're at like 99%, which is incredible. Now we need to work on them telling us that they're in school and that they've received an advanced degree and putting their certifications. So those are just some of the challenges that we have. And going back to why is this important? Because we're looking at the characteristics of a nurse. Literature shows that when you have engaged nurses, when you have experienced nurses, when they have certifications, when they have advanced degrees, outcomes are better. We want to know what our nurses look like, and we want to have an accurate picture of what our nurses look like. That's why it's important. Workday's not the best. You can put that information in Workday, but it's, again, not intuitive. So we've talked about the idea of creating a nurse dossier where they can pull in that stuff. Like, are you a faculty at a school of nursing? Do you write exam questions? Are you involved in professional organization? You know, that kind of stuff. But again, we haven't gone anywhere with that yet. But again, that requires them putting their information in somewhere. So that's, you know, still something that we are still having to figure out. Oh, I gotta go fast. Sorry. So here's what it looks like. So what I want to tell you before I even go there, this is CHOP's intellectual property. So please, I ask that you don't take any pictures. It's important that you see what it looks like, because for me, I'm very visual. I need to see what things look like. So I will very quickly go through all of these things. But this is our unit, one of our unit profiles. So our dashboards are created, we have sheets. So it's a dashboard and then basically little dashboards within. So we have different sheets. So our unit profiles, this is our DRG. So you can essentially go on here and see what DRGs have been attributed within, from the discharge patient data. This has no filters. This one is filtered to a particular unit, and you can filter the, according to frequency of the DRG. So this one has top frequency, sickle cell anemia crisis is its most frequent DRG. You can also, we have severity of illness in there. So that's just one way that they can do this. And you can slice this and dice this by looking at what's the payload group for this DRG. You can filter strictly to that one, look at, and also look at like readmission rates and things like that. This is one of my favorite ones. So this is unit comparison. So users can look at different unit groups. We have 5 NICUs in Maine and 1 NICU in KOP. So you can look at a department group of NICU and compare like length of stay. We had 7, 14, 30-day readmission rates and whatever other metrics are in the rest of the dashboard on this one sheet. The table is my favorite one. And you can select directly from the table. So you can just pick a couple of different units if you want and just compare those. So lots of great ways to slice and dice it. And I like the data on here. And they can use the unit profiles for unit bios. So they can tell applicants or anyone wanting to come in the unit, here's the type of patients that we see on the unit. They can use it for targeted education. So if they are noticing that there are diagnoses on particular units that aren't used to seeing them, then our NPDSs can target education towards them as well. This is going now to our nursing dashboard. So this is our NCCS snapshot. And we have a little snapshot icon. This was a request of our CNO to have something at a high level view of what the NCCS department looks like. And these were the items that she specifically requested. And our data analyst, Tim, did an amazing job. So we pull this from different dashboards. We have links to dashboards. So the data we pulled from dashboards not in the nursing dashboard, we have links so that they can go drill down. The ones that do come from the nursing dashboard, they can click on and it will take them to that sheet so they can do a little bit more looking. She didn't ask for trend lines, but he put them on there, which I think is great. So you can kind of see where things are going. And then we have other different sheets in there. We added the nurse resident percent because for a while we had a high rate of new to practice nurses. And so we're now down, we're even less than that now. So what's great is we're all recovering from the pandemic and we are seeing more retention. And and because of that, we're seeing more experienced nurses. We also gave them some quick buttons at the top so they can filter to look at what does Philadelphia campus look like, what does KOP campus look like, and all of the metrics will change except for this one because this is enterprise level data. So we can just get a high level view of just those. I love this one, our own dashboard. So this is old. We now actually have 5,681 RNs. And we have median, so we use medians. So that's the middle point in the whole list of data points because it avoids skewing based on averages. So the median years has gone up a few years since I first came, so I think it's really great. So this gives us a high level view of what do our nurses at CHOP look like. And it does not look like that picture that ChatGPT gave me. I know, right? So this is our enterprise. We added a little NCCS department button so that our NCCS people can just click on that and see what NCCS looks like. And as of 2 days ago, NCCS had 4,722 RNs with a median age of 33 and median years at CHOP of 4.3. And that's, I think, doubled. The median years at CHOP, I think, has doubled since I came here. So I think that's wonderful. And then you can filter. So I took this, I just clicked here to look at acute care RN, and we've got 3,300, I think. It's hard to see that number, but so you can slice and dice to look at your different groups. So that was overall. Now I just filtered through department. So this is what that department's nurses look like. So they can, get a look at that. We add ratios. I've wrote them out, but they can see how many clinical nurse specialists to bedside nurses that there are. The ratio is probably 1 to whatever my number is, and things like that. We also included PEAK, which is our professional development, clinical ladder type thing. So we gave them the ability to drill down to nurse level data for that. So they can see who in particular has PEAK. ClickSense does not let you hover to discover definitions. So originally when I came, definitions were all down the side in little print and it just scrolled. With the help of our graphic designer too, we created a definitions and explanations page. The metrics definitions are organized by the sheet they are on and then in alphabetical order. And then we made it easy for them to go back to the sheet they came from using a return to sheet button. Oh, I'm getting fast, sorry. I get really excited about this stuff. I could talk, it's my job. So I talked about what it looked like. We had all this data and it just kept going and going. And yeah, we still have a lot of data on our new look and feel, but it's organized. So this is what the financial manager's dashboard look like. We've got those metrics up at the top. And then it's categorized into containers that have similar data. The first page is typically a summary, and then you can go do more detailed after that. And then you go into your a different set of data that's all categorized the same. We've also given them the ability to do some self-serve where they can choose 1 to 4 metrics, and they can look at them and look at trending. All right, quickly. A couple years ago, we did a user experience survey with mostly our senior leaders. We had a fairly, 20 out of 70, 29% response rate. But one of the things that we found, and we used the adapted health IT, health information technology usability evaluation scale, 5-point Likert scale. And basically what it showed us is that, most of the respondents were managers who'd been here for over 11 years. So they were experienced nurses who'd been here for a while. And they actually agreed that they were comfortable using the dashboard and that it was fairly useful. So that was really great to hear. We just did a repeat of that survey. It closed on Tuesday. We targeted to 133 users. because I have the ability to see who's been using the dashboard and how many users. So we targeted to those that had used it twice in the last 6 months. And we got 51 responses this time. So that's about a 38% response rate. I haven't had a chance to look at that yet, so be really interested to see what they think. I think I've already talked a lot about our future next steps and talked about our data issues. So we added the ability for our managers. They can see nurse level education data. They can see nurse level certification data. We're going to allow them to see nurse level turnover data. So that's why not everyone's going to be able to see everything in the dashboard. Right now, all users can see anything because this isn't like sensitive or protected data, but they really like this. And it's very helpful, especially when they want to see who's missing education data, or also, who they think has a certification, but their name's not there. So let's go back and have them please do their career profiles. Our usage, this is last year. So we had managers in, we've had some dips. We're seeing a little bit more. Oh, that's the wrong one. Anyway, I had another one where it shows that we're up here and more steady. I also did some where we were looking at eligible users by quarter, and we have, definitely you can see, again, it's a steady, slow but steady uptick. These are, Dr. Curry, Paulo Augusto, these are the leadership team. Dr. Cato is involved in that. And then my lovely project team. So couldn't do it without him. So amazed that, again, we're not where we want to be yet. We're still putting that foundation in. But especially when we get off of ClickSense, the things and the places we can go, and with Dr. Cato's help, is just going to be incredible. And can you tell I like what I do? It's exciting. And just some references. The dashboards have been written by Dr. Curley and my boss and other members of the team before I came. And that's it. Questions? Sorry, I seriously thought I'd be done sooner, but I got excited.
Any questions?
How do nursing leaders use the dashboard to match the correct or best nurse experience to the patient?
They can look and see what they have, but we're not quite there yet. So eventually what we want to be able to do is have their shift data. I mean, we're still, like I said, we're still just putting in that foundation. That is one of our goals, though, is to be able to look and see, who do I have? What's the experience level? What are the patients I have? So again, that's that synergy. So I wish they could do it right now. I really do. But again, and being on ClickSense isn't going to help us. So it's still going to be about a year or two before we're off of that platform. But we're, as long as we can keep putting in the foundation for that, we'll be able to get there better.
It would be a huge win for the entire nursing community at large if you would meet with your EHR vendor, who happens to be my EHR vendor's development team, because their roadmap includes in the future having their own staff scheduling system and not needing a third party. And if you think about, this was years of work that each organization would have to take on, right? So they're already developing it. So I need to get you with their developers so you can teach them what we need. So integrate with the assignment wizard, which is already matching the nurses, right? Because this is nursing operations basic needs on Maslow's hierarchy. Yes, this is it. And to think that we're this far along and don't have it without all this work. Right. So yes, they're developing it.
And we have, so we're switching to UKG. We do have scheduling tables. But right now we don't, number one, resources and a place to put them right now. Wow.
I know. I was just going to add for Sherry. My name is Ari Johnson. I work with Sherry at CHOP. So we are actually going to be exploring the precision staffing model this year and implementing. So I have a lot of high hopes that we'll be able to, hopefully marry the two. And I will say, just to add to, I think a lot of what Sherry's team has really given our nurse managers is that and I came from a nurse manager position prior to my current position, but I think you often know what your staff are and you know your patients, but this really validates and gives hardcore data to what you're feeling. And you can really match what your experience is, how you're rolling things out. I think change management, when you're really looking at your demographic of who your nurses are and the patients that they're serving, I think has just given nurse managers a lot more engagement to how we are engaging with change management processes.
Yeah, or fight for resources.
Yeah.
Like from a CNO level, this is your data you need that to show the organization that you have a lot of novice nurses.
Yeah.
You need
Yes.
more CNSs.
And that showed a lot. And actually one of the nurse managers or directors reached out to me yesterday because she couldn't get what she needed in the dashboard because we don't have that built, but I was able to get her the specific data she needed. And we actually need to meet with her to talk about how we have categorized her staff, because I don't think it's right. And it was really funny because I just talked about it the day before. So we're working, that we'll be working on too.
All right, everybody. I'll introduce myself very quickly. I'm Angela Joy. I'm part of the education committee, and my committee members felt it was appropriate for me, Angela Joy, to introduce our next speaker, Dr. Joy Iota, who serves as the Associate Chief Health Informatics Officer within the Office of the Chief Health Information Office at Penn Medicine. Her primary focus is on governance and clinical decision support across all healthcare settings, with a specialty in cross-clinical workflows. In addition to her role in health informatics, she is a DNP prepared registered nurse and holds an EPIC ASAT certification. Outside of work, Joy enjoys spending time with her family and pursuing further education, as well as engaging in swimming, biking, and running. So without further ado, Dr. Joy Iota.
Good afternoon. Can you guys hear me okay? Can they hear me okay?
Yeah, because I'm
All right, I'm going to attempt to navigate two things here. So welcome. Thanks so much for having me here today at the ANIA Greater Drive Value Fall Symposium. It's so exciting. It's, I was thinking about this before that I was like, it's so nice to see everybody in person. I appreciate it. So over the next, 35, 45 minutes, I'm going to walk you through clinical decision support, also known as CDS, across the continuum of care. And my focus particularly is on how nurse informaticists can make CDS practical, powerful, and relevant to the workflows that matter most to us. See if I could. All right, let's take a moment to ground ourselves in what we're going to cover today. By the end of this session, you're going to be able to define clinical decision support, not just what it is, but what makes it actually work in real world settings. Then we're going to explore the 5 rights of CDS, simple but powerful framework for designing support, clinical decision support that actually helps rather than hinders. We're also going to look across the full spectrum of care, settings where inpatient to outpatient, home care, maybe we won't have home care today, but I do have home care examples, and everything in between. So you can see how your CDS can scale and flex to adapt. And then finally, we're going to look through some nursing specific opportunities because, at the end of the day, right, we're building CDS for nurses, and sometimes we build them for providers to make the jobs easier for the nurse, right? So whether you're in ambulatory, acute care, peri-op, leadership, there's something in it for you. So let's dive in. All right, a little bit about Penn Medicine. We support care delivery that spans 7 hospitals, hundreds of outpatient practices, home health, hospice, and everything in between. That means our CDS design can't be one size fits all. It has to work for the ICU nurse at HUP, the primary care medical assistant in Lancaster, and a hospice nurse on an iPad in somebody's living room. This kind of scale pushes us to think beyond just what works in the EHR. It demands that we build systems that are adaptive, targeted, and respectful of context. And nurses are on the front lines across every single one of these settings. So when we talk about CDS across the continuum, we're really talking about CDS
that meets nurses where they are. I'm so excited that all the other presenters put their journeys on. So my continuum of care looks like this. I started as a baby nurse after graduating from Villanova in 2002. First of all, I didn't realize that I could just talk about myself for a little bit. Like, this is really exciting. I usually presenting stuff for other people. I'm like, oh, I get to talk about what I do. So medical oncology nurse is where I started as a nurse extern. And then I stayed on, worked there for a couple of years, ended up accidentally really in the emergency department, where, I was like finding myself needing more complex patients, really found myself in the rooms where the patients were the sickest. And I was like, I need to go to the ER. And I didn't have that much.
You want to take a from me. So I did I die? You did. Like, well, I don't know what to do. Let's do the effort off the battery. Right, I'm so it's gonna be. Does the other one fix this one? Yeah, he went.
This one?
Does it work for you too? Once you put it.
How about now? All right.
Maybe it was just me.
No, I think it died. Sorry, I talk too much anyway. So moving on, spent a good 10 years in the ER. I loved what I was doing. I could have stayed there forever. Had the best boss. And just remember a really big email that came in. It was like, hey, we need a nurse who really understands the workflows, has an understanding of technology, to come on for a 1 year trip to become and that's all it really said, like a 1 year technology venture. And I was like, I know what it is. It's epic. And went to my interview with Holly Malazzi back in the day, and I was like, you don't have a choice. Like, I need to do this, right? Like, even though I loved my job, I was like, I'll step away for a year. That was like 10 years ago. So did that, stayed on IS, loved what I did there. And then once again, a very cool opportunity presented itself to me to join informatics at the system level. So my world, I have seen the continuum of care. I work with nurses, I work with providers, I work with therapists, I work with all the entities. I love cross-functional workflows. So this is a really cool job for me. I also did some disaster management in there just because anybody else doesn't have enough to do. And then I didn't even have the opportunity. Very engaged in Delaware Valley Hymns, the treasurer and president-elect. So come to our conference. But what I want everybody to do here, taking away, is build your own slide. Show what you've done, because what you've done will influence what other nurses to know, especially, we're academic, we're in nursing school right now. Let them know that your bedside experience influences what you do in informatics. All right, we're going to move on now into some academic stuff. All right, so what is clinical decision support? This is the framework, comes from the American Medical Informatics Association. I returned to it. It's the book by Dr. Jerry Ossoff is Bible. Read this if you have the opportunity. It reminds us that good decision support starts with a well-understood clinical problem, not with the tool. So you'll hear me talk more about this. Whoever wants to. Can I have an alert? Can I have an alert? No. But CDS is not just a pop-up. It's not just an alert committee. It's a process. It's an evidence-based process. And to do it well, we need to take the time to understand what's really needed at the point of care. Especially in nursing workflows, interruptions come fast and time is short. So you can't afford to design blindly. All right, the first foundational concept of CDS is defining the problem. You have to define it clearly. If the problem is framed wrong, the solution won't work, no matter how good your CDS tool is. So I'm going to tell you a story. So Roy Rosen, he was our former Chief Innovation Officer. He gives a story about Hertz rental cars that really stuck with me. Customers were frustrated about long lines getting off to the airport. So Hertz said, get everybody together, we're going to put a group together, we're going to figure this out, and we're going to solve this problem. Well, they defined the problem as the lines are too long. Easy enough, right? So what did they do? They hired more staff, they sped up the paperwork process, nothing changed. Well, then somebody else reframed it. The problem wasn't the line, it was, it takes too long to get to my car. Now that insight, totally different, led to the Hertz Gold program. Totally different solution. No line at all. You just walk to your car and drive away. In informatics, we fall into the same trap. Request comes in, we need an alert, right? Raise your hand if somebody has asked you for an alert, or you have asked somebody else for an alert, right? It's not the problem. You got to ask more questions. What are we trying to prevent? What's not happening that should be? All right. The second foundational concept is this. You must understand the real workflow before jumping into CDS design. It's tempting to assume that we know how things work, but assumptions are dangerous. A request might sound straightforward, just add a vaccine alert. But when you trace the actual workflow, it's anything but simple. I have a nice example right here. The process of getting a patient vaccine involves multiple roles. You have the patient, you have the nurse, you have the provider, the scheduler, the documentation system. Everything has a part to play, and each step depends on the step before it. If any piece is missing or mistimed, you're not going to get your vaccine. So the swim lane diagram and taking that time to map it out, that will guide you to your intervention if you need one. And we all know what actually happens at the bedside in the documentation and during shift change. Even when they get the concept right, they might get the timing wrong. So you got to map it out, figure it out. All right. This is not the first time that you've seen this today, right? 5 rights, everybody's familiar with 5 rights. We have the 5 rights medication administration, we have the 5 rights of clinical decision support design. Think of them as a checklist, a way to make sure that you're designing your CDS that's not only technically correct, but is useful in practice. So you have your right information, right person, right time, right channel, right format. Let me go into a couple of these in a little bit more detail. Oh, by the way, you're all expected to go back to your institutions with a different lens. Let's start with the first and arguably the most critical, the right information. Ask yourself, are we providing the right information in our CDS tools? That means information that's evidence-based, relevant, most importantly, actionable. If the clinician can't act on it in the moment, it becomes clutter. Even if it's correct, not tied to a decision or an action, it risks being ignored, or worse, resented.
Think about it from a nursing perspective. If if a CDS reminder pops up about a fall risk that doesn't tell you what to do differently, it's not helpful, right? But if it flags a patient as a high risk, links to a tailored intervention, that is the right information. The right person. CDS must reach the right person who can act. Right, okay. Alerting a nurse that a chemotherapy dose is wrong isn't effective. Got it. The nurse can't change the dose. The alert belongs with the ordering provider. The right time. This is probably one of the most underestimated factors in CDS design, probably the most frustrating when it's wrong. CDS has to show up at the right moment, not a chart open, not 5 steps too late, but right when that decision needs to get made. Call it the Goldilocks zone. Not too early, not too late, just right. Walking through a scenario. You open a chart for a patient you've never seen before. Immediately, a pop-up alert appears. You need to order a set of labs. You haven't even looked at the patient, right? You're just like signing yourself up. You haven't reviewed their notes. You don't even know why they're here. That's not just poor timing, it's disruptive. It creates alert fatigue, not support. Now imagine instead that same alert pops up only when you begin placing those orders. It's contextual, it's aligned to your workflow. That's the difference. The timing respects clinical judgment. It meets you in the moment when the recommendation is relevant, not intrusive. All right, moving on to the right channel. The channel that you choose for your CDS delivery can make or break its effectiveness. This is important, not every CDS intervention belongs in the EHR. Let me give you an example. Critical lab result, like a dangerously low or dangerously low hemoglobin, maybe a high potassium. It shouldn't just sit in like an in-basket message, right? Or even a text message, secure chat, unless you have a very good process redefined like Chester County has. But if they don't answer immediately, what do? You pick up and you call them because you need them to act on that. So maybe the EHR isn't where you need to go. Basically the channel matters, and you have lots of channels, right? So you have in the EHR, you have, the patient portal, right? So if I want to fill out a specific nutrition screening, why do I have to wait for the patient to come to me? I can just push it to the patient so it gets filled out before they show up, and then you can act on those answers. So when you're designing your own clinical decision support, I want you to ask yourself, what's the urgency? Who's the audience? And what will make this information the most actionable at the right time? All right, the last one of the 5 rights, probably the trickiest, is the format. Are you using the right format for your CDS intervention? Not just what's available in the EHR, but the tool that actually fits the job, right? So we have a whole toolbox of tools. You got order sets, banners, checklists, pathways. I'm going to go into a couple of these in a couple minutes. And sometimes the best format, sign tape to the bedside. Fall risk, right? Like that not everybody's in the EHR all the time. So what is the smallest, clearest format that gets the job done without overwhelming the clinician? All right. I spent most of the time on the 5 rights, but I do want to briefly acknowledge another well-known framework. This is Dr. David Bates' 10 Commandments of Clinical Decision Support. You have probably the slides that will be distributed or available, so I'm not going to read them to you. But if I were to call out two of them, I would call out anticipate the clinician's needs. So design your CDS to be proactive, not reactive. The most successful interventions feel like they're one step ahead of the user. They show up before the question is asked, not after the work is already done. The second one that's most important is keep it simple. Sometimes it's the smallest change, a smart default, a reordered list, or a pre-checked box. A lot of times they feel invisible or elegant so that the person who's receiving that decision support, they don't even know it. All right. Let's go a little bit more about anticipating needs and delivering. Principle all about thinking ahead, bringing the right information to the right person at the right time before they even ask for it. I have a good example. When a clinician orders, making sure I'm like, have all these animation that I wasn't able to do on 2 slides here. Clinician orders Coumadin, and they need to monitor the patient's INR. Well, if you have an order set, don't have the provider also click it for them. You know, my institution tries to limit pre-checked items in order sets, but if it's 100% of the time for 100% of the patients, you're going to run the risk of patient harm if the clinician just zips by it. You default it. You put it in there, you make it easy. So that's what I mean by anticipating needs. And also for nursing, we're the ones that are going to see the gaps when the orders don't line up. We're the ones that are going to get called when things fall through the cracks, right? Nobody reads the nursing documentation except for the auditors. So if we can build that CDS that anticipates, we can be more efficient and safe and less frustrating. Here is another one that I'll just skip through real quick. So this is just a simple but powerful change that we used to reduce oxycodone prescriptions, right? Because we have a big initiative to control the opioid pandemic however we can. So the default was 28 pills. So providers were prescribing they're just clicking through, right? All right. Oh, you've been walking, you haven't taken any painkillers after your surgery, whatever, 28. We changed it to 15. We didn't prevent them from changing it, but let me tell you, it was a simple, quick win. Didn't have any crazy alerts, just worked. So we went the path of least resistance. All right. How am I doing on time? Okay. Yeah, I'm doing good. Okay. All right. So back to when the next time somebody comes to you and says, I need an alert. Can you build me an alert? Because you know they're going to come. I want you to take this back and tell them to take a deep breath and pause and do what we do best. Let's do an SBAR, right? Everybody knows what an SBAR is. We use it every day in clinical care. That's how we communicate with providers. It's clear, makes sense. So let's break it down. And we do this basically as part of our governance process. We do not just say, I need a,
we have the requesters go through a process, right? We want them to describe who's impacted. Is it patients? Is it clinicians? Is it a challenge, or is it is there a risk? What inefficiency? You know, we want the background. You know, is there evidence for the problem that they're seeing? Did it happen to one patient at one time, or is it a pattern? And this is really important because if you don't have an understanding of what the problem is, how are you going to know if it's fixed, right? So like if you're going to put anything that you put into that EHR, you want to be able to measure its impact. What's the current state when you go into the assessment? Current state, is it one department? Is it across the whole enterprise? Is it multiple hospitals? So what can you do to get a clear picture of that problem? And I say this, right, like do this for everyone before thinking of a recommendation, because it might not be something that you thought of, especially if you have a team or a brain trust that you can bounce ideas off of. So I want everybody to say, let's talk through your problem first, and then see what the best tool is to support your workflow. Jazz hands. Thanks. All right. We had our own problem that we tackled on. It was one of our most challenging, highly regulated workflows that we faced. So restraints. The issue came to light following a survey in our ED where a violent restraint order was missing. So missing from the medical record. I mean, they're probably busy, right? They're holding the patient down or doing something. But on digging in and getting that data, we actually found that it was, you know, we found much more. It was very eye-opening. So across care settings, there were inconsistent practices and across applications, right? So we have like different modules, our EHR, which many of you know what it is, different applications had different tickets placed to solve the same issue, but they all had different solutions. So Rebecca's over here on the side. We took all those and we said, let's think about this, right? Because the other problem that has, like, nobody wanted to own this, right? It's, you know, everyone sees it, nobody wants to own it. So we took it on as a system initiative to see how we can do to improve it. But you have to be careful, restraints, very risky, right? You have very specific regulations around restraint use. At least 5 of those were related to orders and documentation. So what we found was that there were gaps in restraint orders. We had varied face-to-face documentation, which is impossible to track. We had requests for both nursing and provider alerts, but different groups were asking for different things. It was really painful. So let's see what we did to attempt to fix it. So this slide says it simply. We tried an interruptive alert and it backfired miraculously, right? So I'll give you the full story. Before this initiative, we tried to fix the restraint workflow. We thought a pop-up alert would work to help catch order errors in real time. So we built one and it fired when someone selected the wrong restraint order, and it fired and it fired and it fired, right? But in practice, it made things worse. Nurses were frustrated, providers were frustrated, it slowed the workflow down, didn't actually solve the problem. It interrupted at the wrong moment, didn't guide users to the right path. Worse, right? Worse, we broke one of our own golden rules. We created an alert that told the nurse to call the provider. How would we know?
So that's the exact kind of thing we tell people to not do. So alerts shouldn't just be used to pass the baton. This kind of alert adds friction, and it's the wrong format. So we went a little better. All right, so let's pivot to how we tackled some of the problems. Providers were choosing the wrong restraint order. In this case, the issue was picking the wrong age group, mistake that could lead to compliance issues, patient safety concerns. We have New Jersey, we have Pennsylvania. They have to be reordered at different times. We would like to just tell them to coordinate, wouldn't that be nice? We asked, what if we make it a little easier from the start? So we did some initiative to focus on improving the actual order set itself, making it clearer, smarter, more user-friendly. You can see here, so we had on the left many different restraint orders, combined them into a single order set. So providers only have one way to access it. This is in the ED, in inpatient. We reduced the verbiage to declutter, so less noise. We added some tall man lettering, which you can see there, because people were like, "Oh, is it, are we doing violent or non-violent?" And we had to do extra education, like the restraint isn't, the order isn't related to the type of restraint, it is related to the type of behavior that the patient is experiencing. So along with this went a lot of education. So you can see some of the changes that we have here. Another CDS tool that we use are banners. So this is situational awareness directly in the chart. So we use these sparingly. We try to make them interactive, actionable, and give you the information that you need when you need it. So we built out a tiered system. So orange ones are expiring soon, and this is regardless if it's a violent restraint order or non-violent. We just figured out like what is, hour minus, 1 hour prior to the expiration. If they're in the EHR, they'll see the banner. If they're a nurse, they'll be able to discontinue it if the patient is not in restraints. If they're a provider, they'll be able to click on it, pulls up the order, actually pulls up all the extra defaults that they had previously, so they can look through, be able to click through, and get to it to reorder, especially if it's a patient that really needs it. So everything is very clearly labeled. You can see just looking at the summary report. It also collapses if you want to declutter the screen, so it's not always there if you need it. So, and what else do we do here? So we did, the completing the restraint orders directly. So that's something we did. And we also had patient list columns, trackboard columns that really kind of meant exactly what was happening. That interruptive alert that I showed you a few slides ago, we turned it off. Now, wrong way, again. Now, right, we already talked about this. Clinicians aren't sitting in front of the computer 24 hours a day, right? So they're actually like taking care of patients, talking to them, doing something, rounding, maybe seeing another patient. So we went beyond the desktop and into the mobile space, where a lot of the care delivery and task management actually happens. We have entire hospitals that don't even have like scanners anymore. They just use mobile for everything. So we built out mobile that mimic the banner. So one fires an hour before, and then the other one fires when it expires. Triggered to nursing, triggered to providers. We have like different ways to, they're like different, why can't they build similar? I don't know, but you can see expiring restraints, and then providers eventually will get that just right to be able to accurately order it from it. But so you can see here
We built a clear understanding of the restraint order cycle. Oh, next one. So clear understanding of the full restraint order cycle, how they're placed, tracked, and if they expire. So this is an example of a 4-hour restraint of when the timing happens with the mobile notifications in the banner and the icon. So they all kind of they bounce off each other depending on if you're looking at a track board or a patient list, or if you're in the chart. So we found that mapping out the life cycle like this give us a little bit more clarity. We know what we're trying to do. All right. I gave you a couple examples of CDS tools, how they work within the system, but there are many tools in your toolbox. So don't feel like you have to just use one thing, but also think about the strategy so that, you know, if you're adding in more banners or more things in storyboard, or that they're keeping track of how many alerts too, and can you optimize some of them? Some alerts you probably don't need anymore, but because we have new technology or the process has been changed and we just haven't updated. So go back to and reduce the ones that you have and make sure that they're being prioritized. So the point of this, you know, every workflow challenge doesn't need an alert. Understand the clinician's environment and then pick the tool that naturally blends into solving their problem. And don't think that you have to know all of these tools all by yourself. Connect with your analyst teams that do have this, and not one analyst team might know it, because all the different analyst teams blend together, right? Especially if you have pharmacy and orders and clinical documentation, they all have like a little bit they can contribute. So definitely go for an interdisciplinary work group. All right, I just want to make a note: pitfalls, don't let this happen to you. Some challenges that you may encounter, hopefully you avoid it. Workflow misalignment. If the CDS doesn't match how people actually work, it will be ignored, right? That first interruptive alert, some of the other ones we've had in the past. We broke our own rule. Classic case of friction, not function. The second one, lack of stakeholder engagement. I can't emphasize enough how important this is. CDS isn't something that's done to clinicians, right? Especially if inpatient wants to do something to the ED, or the ED wants to do something to inpatient, or infection prevention has this thing that they need the provider. Like it should be engagement from the beginning, especially when you're doing cross-functional workflows. Because if you do not have clinician engagement from the start, they're going to fight you. They're going to complain, even if it is a good idea and they should be doing it. So want to make sure that buy-in, especially interdisciplinary, multidisciplinary buy-in. Did my mic go again? All right. No, it's what's funny is it's not Apple. My battery. Oh, no, it did. All right. All right, here we go. Mic number 3. Good. I'm almost done anyway. All right, third one, right? Alert fatigue is real. More alerts do not equal better care. In fact, like it leads to desensitization, risk, right? Like if everything is important, nothing is important. That's why we want you to focus on clarity, timing, and only surfacing what's essential.
Ultimately, good decision support is more than delivering the right info. It's about doing it at the right moment, in the right way, and with the right people. That's what earns trust, and that's what makes it stick. Oh, here we go. There you go. There's the slide I was reading. And, all right.
Anybody have any AA batteries? Gonna text them.
Let's bring it home.
Send a message.
That makes sense.
Oh, no, you have a question. No, you got the batteries. I got that.
I'm
Yes.
messaging the tech guy, give me a minute.
Yeah. All right, I'm gonna finish this up here.
Does
So,
anyone have any questions?
wait,
Okay.
hold on, almost done. I just want to make sure, did I meet the objectives that I said I was gonna do today? All right, does everybody feel a little bit more confident when somebody says, I need an alert? Do you know who to call? All right, remember your S bar. All right, happy to take any questions. I think I got us, I think I kept us on time.
Really quick, did?
How do you, I think this works. How do you continuously review, like we have an OPA review process, which is not perfect, but how do you do an ongoing review of all your CDS tools to make sure they're not getting to a point where there's fatigue? Yeah, so your EHR may give you feedback, user feedback on alerts. Follow that feedback. Follow it for patterns too. We did some really good EHR wellness, EHR hygiene, where we looked at the alerts that had just lots of thumbs down, right? So you look at their the negative comments, you look at how often it's firing, and then you see if how actionable it is. And then you look at the ones at the top, you move them down, and then you just kind of keep moving. And then you try to make it so that it becomes more simple. It's an ongoing thing. It also takes a human being to look at them and say, okay, this is important. We have to do this now. Like nurses are going to like climb through the screen and they're going to start calling me. Yeah, so yeah, we have a couple of different tools. So we use tools within our EHR, and then we also use a third-party tool, which has a thing called Cranky Comments too. And those are the ones that were mentioned earlier, like free text comments, right? It wasn't just a typical thumbs up, thumbs down, but if it was like, please stop. And then like our extra reporting system will be like, this is literally a cranky comment. And we're like, okay, so then, we look and we say like, is that a one-time thing, right? Or is that just a cranky provider, or is that a really like a bad workflow? And then we try to reach out and figure it out if we can. Dr. Kendrick, he left, but like, I didn't get to mention that, like, I never thought that I was going to be, like, I thought an oncology nurse turned ER nurse, turned nurse informaticist was like a single person thing, that I was like the only one. And he left, and I was like, I saw him at lunch. I was like, oh,
No, me too.
I was like, it's amazing.
Same
It's
path.
amazing. Oh my God.
So there's actually a lot of oncology nurses that are informatics nurses. It's
It's so cool.
interesting.
So cool. And any other questions?
Good afternoon. We're ready to start our final presentation, and you are in for a great surprise. Mary Ann is currently the IT Assistant Vice President and Chief Nursing Informatics Officer, overseeing IT clinical applications, clinical informatics, and instructional design and training at Virtua Health. Mary Ann's 29-year career spans key leadership roles, including Corporate Director of Nursing Outcomes, Magnet Program Director,
advanced nurse clinician, nurse performance improvement coordinator, nursing director, and 13 years in the specialty of nursing informatics. Nurse Mary Ann's clinical background is in intensive care, medical surgical acute care, ambulatory medical specialty, and school nursing. Mary Ann was the IT clinical readiness co-leader for our One Virtua and One Virtua 2.0 system-wide Epic implementations. She led the mobile device strategy and implementation, which resulted in Virtua Health being a leading organization in nursing mobile adoption among all Epic organizations. Mary Ann also discovered non-provider use cases for voice-activated macros in Dragon and led the system as the Magnet Program Director for Virtua Health's first Magnet System accreditation. Mary Ann has led her teams in collaboration with operational stakeholders to develop and implement several innovative virtual care delivery models, including inpatient virtual nursing, hospital at home, care after discharge, and clinical decision units. Mary Ann's certifications in education include ANCC, Nursing Executive Advanced Board Certification, Doctorate in Nursing Practice and at the turn of page, and Executive Leadership from Baylor University, Master's degree in Nursing Science from the University of Phoenix, and Bachelor's of Nursing Science from Drexel University, Healthcare Informatics Certification from Drexel University, Epic Clinical Documentation Analyst Certification, and Six Sigma Yellow Belt. Mary Ann is the recipient of the Baylor University Outstanding DNP Project Award for Inpatient Virtual Nursing, Francis Black Humanitarian Award in Healthcare for her work contributing to patient fall and restraint use reduction, and Virtua Health CNO Superstar Award, 2 Virtua Health Nursing Excellence Awards, and a Virtua Health Superstar Award for ANC of the system. Mary Ann has presented on numerous topics locally and nationally. Mary Ann is an elected member of the Epic Nursing Wellbeing Steering Committee and a member of the New Jersey Organization of Nurse Leaders Advocacy Committee. Thank you. Welcome, Mary Ann. Let's go home. There's no time. No time to say anything. So, thank you so much for having me here today. I'm really excited to talk to you about this. I think we need to switch the deck. Okay. I could have been doing that during that whole thing, right? That's okay.
You're on the way. Sorry.
We got excited with raffles.
Free stuff.
That's right. If it's free, it's for me. It's that one, right? Yeah. Okay. Thank you so much. Okay. That's okay. Don't worry about it. This is why we're nurses, because we flex and flow, right? I have nothing to disclose, and here are the objectives that I'm not going to read through, and hopefully you'll learn something and you'll meet the requirement for the CNAs, right? I'm going to zip through some stuff faster than I intended because I don't like to listen to things more than once, and some of this is kind of repetitive, but it does show you that as leaders that are speaking to you today, we're all aligned on where we're going and where the future is. So just want to remind you of the IOM Future of Nursing report that came out. Obviously, we're having shifts in care models. I think we've heard a lot about that today. Where the care is going to be delivered, how it's going to impact nurses and how they're going to interface with this new world that we're going into. Definitely many organizations are experimenting with various forms of digital technology. I think we've heard a lot about that today, and I'm going to try to focus mostly on the virtual care models more in depth. I'll get into the weeds maybe a little more than I was planning to, because I know a lot of you are working in virtual care, and I think we'll have some time to do that now that some of the other things I was going to say have kind of been covered already. The healthcare system is being transformed by an increased focus on community-based coordination and population health, of course. And there's definitely essential skills for nurses that need to use these new technology tools and learn how the future of nursing is going to look. And the thing I love the most about the IOM report is they really do call out nursing informatics specialists and the key role that they're going to play in our future. Yes, no problem. So just some of the catalysts I know we talked about this at the very beginning of the day, so I'm just gonna call out a few. Good thing she's mine. Right? I wouldn't feel anybody else. All right. Hey, everyone else. So are you good? They can hear me online? It's not too loud? No. Okay.
In addition to that, like.
I love the little antenna now. I feel very techy, right? Anyway, so some of the catalysts for change, we're gonna say the C word, right? The C word was a huge catalyst for change, right? COVID. We had telehealth before COVID. I think most of our organizations, our telehealth numbers went through the roof during COVID. Even I learned how to do things that I didn't know how to do during COVID very quickly. And I think our patients and our consumers showed us loud and clear that they are willing to learn and did, and we're very receptive. One of the things I wanted to go into a little bit more, at the very beginning of the day, this was kind of mentioned, but it really plays a factor into virtual care, especially inpatient virtual nursing. It's really a very questionable time right now with reimbursement for our hospitals. A lot of hospitals are struggling financially. They are not finishing the year in a good place. And they're unsure what the future is going to hold. And so some of the virtual nursing programs that have been piloted in the last couple of years started out really focused on exactly what the nurses needed. And then in order to get executive sponsorship of the finances that are involved, we kind of have to pivot a little bit. I'm seeing some organizations are pivoting to focusing more on how can the virtual nurses support excess day reductions? How can they focus more on length of stay reductions? And so what you're seeing are some hospitals trying two different pilots. Some hospitals started out with one model and then moved to a different model where they're just focusing on discharging to prevent readmissions and medication reconciliation. So we'll get into some of that a little later, but even while we're rolling this out, sometimes as nursing leaders, you have to say, like, what's the long-term gain, and how do I have to pivot to be able to show the ROI I need to show in the places that matter to the organization at the moment, so they can give me the resources I need to expand the program so that eventually I can get it where I want it to be, right? So we'll get a little bit more into that. And then obviously increased complexity of hospitalized patients is a catalyst for virtual programs, access to care. And then I put in some of the statistics here that I used in my doctorate project. So I know Duana said it, but my doctorate project was inpatient virtual nursing, and it was building the business case for it and getting adoption and approval, like to implement it. That was what my project was, not actually rolling it out and doing a research study on it. But as an executive leader, what does it take to get an organization to invest millions of dollars into something like this? And so the statistics that I used at the time, if you don't know Jeffrey Adams' influence model, he's an informaticist and he has an amazing model called the Jeffrey Adams influence model. And that's what my doctorate program was based on. And it literally teaches you strategies and tactics that you need to use to try to get buy-in and influence people to get you what you need, right? And so timing is one of the influence factors. So the fact that, I know it sounds awful and we all lived through COVID. I was out vaccinating in mega centers just like everybody else on my team, but never let a good crisis kind of go to waste. We got Rover in my organization because I used COVID as a reason that we might need mobile devices. And, we used the nursing shortage. At the time, we had 250 vacant positions in nurses. And, you couldn't find them, right? We had agency costs at the wazoo. So I basically used the statistics about the workforce shortage to show that if you could reduce 1 year turnover on your units by having a virtual inpatient nurse, the inpatient virtual nurse project paid for itself. So I just added that there because the workforce shortage is getting better, but it's still not gone and it's still a problem. So you can't take your eye off of it. All right, so some of the research, okay. So when I was doing my doctorate project, it was 2002 is when I started it. And there really was no research on inpatient virtual nursing. There was tons of research on telehealth. There was a lot of research and evidence on EICU, the different models for EICU. But at the time, there is more research on inpatient virtual nurse now, which is great, definitely not enough. But at the time, there was basically just some white papers and one or two organizations that were kind of really early adopters that were using like agencies, to do inpatient virtual nursing. So that's still a gap. We still need more research. Standardization is a gap. Everyone is kind of implementing it differently. And, we just kind of did what we needed to do. And it's different based on every organization. You look at what your individual needs are. But that is one of the things about nursing that we all wish we could do is form coalitions, do things together. Because there's power in the numbers of us. And if we would all kind of have a little more standardization, it would help each other. Especially in that gap where there's no evidence to support you or back you up, right? Licensure too, like I'm kind of fortunate, my health systems are in the same state, but I know that's not true for many people in this room. So when you're thinking of nurse practitioner licensure, right, when you're doing telehealth services and things like that, what are the things we have to think about geographic boundaries with that? And now you're bringing that down into like an inpatient virtual nurse care delivery model. And now you're talking about like a med-surg nurse that might be taking care of a patient that's in a different state than where she's physically housed. Obviously, technology integration, staff perceptions is something that still needs to be studied. And then we need good frameworks for evaluating the outcomes of specifically virtual nursing. So this is just something that came out of the ANA. I'm going to talk a little bit to you about the ANA guidelines that just came out 3 months ago. I don't know if you're familiar with them, but they were just published 3 months ago. ANA guidelines specific to virtual nursing. So that will help us. This kind of came out of that work of the committee that got together. And it's basically saying like the integration of virtual nursing into mainstream healthcare necessitates thoughtful policy development. So when we started our first virtual nursing program, really was hospital at home, and we didn't have any policies, right? We had no practice committee, we had none of that. So we had to develop all of that and really put that down in writing, and so we need to continue to move forward with things like that. The ANA emphasizes that virtual nursing should be reimbursed on par with in-person care to ensure its sustainability. Policymakers should address ethical and regulatory challenges posed by emerging technologies, particularly AI. So the reason my presentation talks about virtual nursing, it also talks a little bit about AI and smart rooms of the future, is because they all go hand in hand. So when you're developing a strategy, like how we talked about earlier, in your organization that goes through governance and IT governance, it's difficult to look at these things in piecemeal. You really need to develop a strategy that's forward thinking, that thinks of all these things together: smart rooms, AI, and virtual care. So while AI holds promise for enhancing care delivery, its current limitations require careful oversight. I think we talked a lot about AI today. The ANA advocates for regulations that encourage innovation while safeguarding the human elements of care, and nursing input is crucial in shaping these policies, as their expertise provides valuable insights into balancing technology with patient-centered care. All right. So I just want to really quick go over, I'm just going to mention 3 frameworks, and I love this picture. It kind of goes hand in hand with some of the things that we've heard a little earlier today. But why do we need a framework, right? So it's a little blurry, but basically this first one is saying, like, if you don't have a framework, then this is what was proposed by the project sponsor, right? They wanted a swing with, this is what the proposal was, right? This is what the vision was specified in the project request. This is what was designed by the senior analyst. This is what was produced by the programmer.
And this is how it was installed at the user site. I love that one because the trunk is gone, right? The tree is just right. But this is really what the user wanted, a tire swing, right? So if you don't have a good framework in place that you're using, it just causes rework, it causes frustration, it fails out of the gate because the user's expectations weren't met, right? And we've all been there. We probably all have 12,000 examples of this. So a couple frameworks that I know people have used for virtual nursing implementation. I mean, everybody has heard of the IHI rapid cycle change, right? This PDSA cycle. It's supposed to be, right, a small test of change, one intervention at a time. You try it, you fail first. If that doesn't work, you try a different intervention. And in our organization, when we were rolling out some of our virtual care models, it was really coming from our digital transformation office in our organization, and that is their model that they use, rapid cycle change. But that does not always work for some of the nursing virtual care models. Especially in our organization, we have 2 collective bargaining units. We're a 5 hospital health system, right? 3 of our hospitals are part of a collective bargaining unit. We have 2 different ones that we have to go through. So depending on your culture of your organization and the culture of your unit, you may have a hospital or a unit that is really innovative and they don't mind failing fast and they have a lot of tolerance for developing, in a space where nobody really knows where you're going. But in our organization, we do some of that, but when it comes to inpatient virtual nursing, EICU, we don't want to fail with these concepts. We want the nurses to be heard. We want their voices heard. We want the design to be something that's going to succeed. So we have done this and it's an option, but I just wanted to mention that one. The second one is called EPIS. It's exploration, preparation, implementation, and sustainment. And that one really lends itself to virtual care delivery models. And then the third one that I wanted to just mention, I don't know if you guys have heard of Dr. Bonnie Clipper. Dr. Bonnie Clipper is really kind of world-renowned expert in the field of virtual care. She's all over everything. If you go on LinkedIn or anything, she was one of my professors in college. She's like really well known. And she created an Activate. It's called Activate. It's an acronym. And it's in an effort to try to bring order to the vast differences among the creation and deployment of virtual nursing care models. So she's out there globally talking to all kinds of organizations that are going down the road of virtual nursing, and she's seeing that we're kind of doing things differently all over the place. So this was a model that she created to try to help us with a nursing framework to give us structure and strategic approach when we're implementing virtual nursing care delivery models. So that might be one that you want to check out. All right, so just some background, we're going to talk about the guidelines that came out 3 months ago. So in 2023, I actually thought about applying to be on this, but I was in the height of my doctorate program, so I couldn't do it. But in 2023, the ANA asked for members to submit an application if they wanted to be on a committee. I think it was about 30 organizations around the nation, so the United States, to come together and talk about creating guidelines for virtual nursing, so that as we're all working on virtual nursing programs, we're all given some guidance to help us, and we're not just kind of testing and guessing and all of that. So the objectives included creating a formal definition, addressing implications related to quality, safety, ethics, policy, and education, and developing guiding principles. And so the initiative builds upon previous ANA efforts, including the 2019 core principles of connected health and the 1998 core principles of telehealth. And the earlier frameworks are now being retired in favor of these core principles of virtual nursing. So I do think it's important as nursing informaticists moving into a virtual world that we're all familiar with the guidelines, and hopefully then it will give us some leverage and power when we are implementing or expanding our programs or optimizing them, when we need to advocate and honestly protect
the nurses that are involved in these programs. When different conversations happen. So basically what their definition, and this is all they've created a wordle of all the words that they think that the committee thought should be in the definition. So that's what you're seeing there. And so basically virtual nursing is defined by the ANA as the use of remote technology and tools to deliver safe and high quality patient care. This care is grounded in the nursing process and emphasizes communication, compassion, and collaboration throughout the continuum of care. Virtual nursing is not a novel concept. It's been a standard in certain specialties such as ambulatory and critical care, mentioned that earlier. However, its adoption has significantly increased since COVID, the pandemic, leading to innovations in how care is delivered. The model addresses several pressing challenges in healthcare, including staffing shortages, rising patient acuity, and the need for expanded accessibility. It also bridges the knowledge and experience gap among nursing professionals and enhances the overall patient experience. So I just wanted to take a quick poll. So I was going to put it in the chat for the people that are online.
Because I'm not a host, but
Or they could just put it in. They could just put the answer in. So do you think that the committee said that virtual nursing is a specialty or a modality? I hear specialty. Does anybody else want to weigh in? Everybody thinks it's a specialty? Okay. So actually, the committee said it's a modality. And I find this very interesting when I was reading through this. So they're saying a key discussion among the working was whether virtual nursing should be classified as a modality or a specialty. Given its application across multiple specialties such as med-surg, maternal and infant care, and various settings, including hospitals, homes, and ambulatory environments, the group concluded that virtual nursing functions as a modality. This classification avoids confusion and unintended consequences that might arise from labeling it as a specialty. While some nurses are pursuing certifications in virtual nursing, the practice is still considered emerging and evolving. As a modality, virtual nursing supports and enhances care delivery rather than replacing traditional roles. It allows for flexibility and integration into existing care frameworks, providing support to in-person staff and improving overall care coordination. This perspective underscores the importance of viewing virtual nursing as a complementary approach that enhances the capabilities of healthcare teams without redefining the foundational structure of nursing specialties. So when we first rolled out, when we were developing the care delivery model for inpatient virtual nurse, I had to go with my doctorate project in front of our IT board. And there is a nurse from our community that sits on our IT board, which I love. And when I told them about the concept, which was very new back then, it's not like it is now. What do you think the very first question that they asked me was?
Taking away job like less nursing, other virtual nurse will take over the and something like that.
Yeah, that's one, right? But and so she was saying that they would be worried that the virtual nurse would take over the job of the bedside nurses. So when I went in front of the board asked, "Oh, okay, so you can increase the ratio at the bedside." That's what the board asked me. And I said, "No, actually, you can't, because this is a supportive role. This is not to replace the nurse at the bedside," right? And so thankfully there's a nurse on my board. And so she chimed in and supported me in that conversation. But you have to remember, going back to, I'm trying to build a business case of why we need this. Like, there are a lot of people that we interact with as informaticists that think like business people, and that's their job, and they're supposed to do that. And that's good, because we need people to think that way, because, you know, no money, no mission, right? However, it underscores the importance of why the people who are developing virtual nursing models should be nursing informaticists, partnered with CNOs, nursing leaders, and nurses that do the job every day. So it's a soapbox for me. I'll probably say 8,000 times today. So it's a modality. The other thing that when we were developing our inpatient virtual nurse model is we were also at the same time developing tele-ICU. And so there was this perception by the leaders of the strategy that, well, we could just combine them. And, if we're short, then the inpatient virtual nurse can just cover the tele-ICU. So that was another kind of like, sorry, no, you can't, right? So I do think, because I have to be honest, when I first started looking into this with my doctorate project, I'm like, yeah, it's a specialty. And then I'm like, no, I agree with them. And because now that we've lived it and we've heard some of the things that maybe could have happened if we didn't have the right advocates in the room, I do think that's true. So I thought that was interesting. So I wanted to share that with you guys. So how does this relate to quality and safety? So this committee used the framework, the Institute of Medicine, IOM's 6 domains of healthcare quality as the framework. So, and it's basically, if you're not familiar with this, so safe is the first one. So avoiding harm to patients resulting from the care that is intended to help them. So we obviously want to be timely. So we want to reduce waits and potential harm delays for both those who receive and those who give care. We want to be effective. We want to be efficient. We want to be based on science and evidence, and we want to be equitable. And of course, the patient is at the center. And so these are the domains that guided the work of the committee to come up with their principles. So this slide, I've kind of grouped the principles into buckets. So there's professional standards, ethics and patient-centered care, scope and legal compliance, access and coordination, trust and communications, privacy and documentation, evidence and policy advancement. So, basically what they're saying is nurses are accountable for providing virtual care consistent with the standards of professional practice with clear role delineation within the care team. The very first thing we did when I finally got approval and we were allowed to start one hospital, my informaticist, Jen Redner, who's on the phone, who is the informaticist for all things virtual, even though I didn't get another FTE, in case you're wondering. So we did what we always do at Virtua. We pulled in all of the nurses at the bedside, the nurses that were going to be in the role as the inpatient virtual nurse, quality leaders, nursing leaders, and we got all our stickies out, right? All the stickies, we did all the yellow belty stuff, coach tools that we always do. And we said, this is med-surg. We started med-surg. I'm a med-surg and ICU nurse, so I love when med-surg gets things because they never do. And we basically said, okay, you're going to just use Epic like you do today, because we don't want disjointed workflows. We want everybody seeing the same thing. You're on the same team, you're taking care of the same patients. And we literally went through every part of their documentation and their workflow and had clear role delineation, right? Is it okay for the virtual nurse to do a skin assessment? Is it okay for the virtual nurse, right? And we literally one by one made sure it was crystal clear. What is my role and what am I responsible for? And what is your role and what are you responsible for? And we can see everything each other's doing. We use secure chat a lot, right? Back and forth, because that's important to make sure everybody knows what your job is, right? And how you can work together. So that they accounted for that in their principles. So virtual nursing care must be grounded in the ANA Code of Ethics to ensure that all patients are treated with dignity, respect, and cultural humility. Nurses engaged in virtual care should validate the patient's and families' understanding of virtual care and advise them of their rights and responsibilities. Nurses engaged in virtual care are responsible for working within their scope of practice and knowledge while maintaining competence and recognizing variations in nursing practice standards across facilities, states, territories, and countries. So I don't know if any of you have, I think some of you have virtual nursing programs going on, but one of the things we had to help our virtual nurses with is, how do you get a hold of a hospitalist at this hospital versus that hospital if it's not the same process? who do you escalate the issue to? Like if your concerns aren't being heard, right? If you're telling the bedside nurse there's something going on with this patient and they're not addressing it timely or they're not listening, and then you escalate it to the provider and they're not, then what do? Right? And we don't want our virtual nurses to have to go to 10,000 people, right? And learn like process for 5 different hospitals, and you guys have some of you have like 32 hospitals. That would be impossible, right? So we had to put leadership in place in our command center that was going to be able to be that person for them that would they can just hand that off to, and then they go take care of that and address it. So that is apparently was talked about here. So nurses engaging in virtual care are subject to broad oversight and applicable geography-based healthcare, commerce, fraud, and abuse laws comparable to in-person care. So we got to think about that too, right? All of the differences there. They should improve access to quality care, be appropriate to patient needs, location, and care setting, ensure ease of use for patients and care team members. Nurses should that deliver virtual care should make sure it's safe, high quality, and person-centered, coordinated with patients, families, and care team, and informed by evolving evidence. So, you know, one of the great things within patient virtual nursing and the technology is you can have people join from wherever. Like if I'm a daughter and I live in Florida, I can send you a link and now you're in the conversation with your loved one and me. And so you have to figure out all those workflows and how you're going to do that, right? So they go through. So you need evidence-based research. You have to have policies supporting the advancement of virtual nursing, that you should ensure safe transmission of health information and communication, and be compliant with standards of privacy and security, and make sure that you're engaging in virtual care in a way that builds trust and enhances patient outcomes. So that's basically in a nutshell, 13 principles, guiding principles that the committee came up with. And to be honest, I wish I had them when we first started, because it would have made a lot of the growing pains much harder. And I think what would be really great is, you know, and this would be something even you could do in your professional organization here, is, you know, we should all be getting together and publishing a playbook on how we all did it. It's great we have standards now, but we should be getting together and doing like, here's our lessons learned, and helping each other out that way too. So it's a modality, it's not a specialty, but clearly we need to be doing more for people that are virtual nurses and for the bedside nurses who are interacting with the virtual nurses. And so really there's a lot of discussion that lives in the competency space, right? More so than calling it a specialty, because everyone needs the competencies, not just the nurses that are doing the virtual care. So I wanted to just open it up to you all before I show my slide to say, what do you think some of the competencies are that we need now when it comes to virtual care delivery models? Anyone? It goes faster if you participate. Team approach for sure, interprofessional collaboration, communication, assessment skills. We tend to have the nurses with more experience be the virtual nurses, right? Just by nature of that role, right? And the mentorship that sometimes goes along with that.
Computer literacy.
Computer literacy is right. Actually, I'm going to say we actually have some nurses that were going to retire who are virtual nurses, and they are challenged, but we were able to work with them and get them comfortable with the specific technology that they needed to use. So they don't have to be too literate, but it's helpful. It works better if they are.
Well, and if you design your system in a way that doesn't change a lot of what they were doing on the floor, there's less of that they need to do, right? So I just put some things up here just for us to think through about competencies. So clinical expertise, right? They have to have a strong foundational nursing knowledge and clinical judgment. So we talked about earlier, somebody asked a question, How do you make sure that the newer to practice nurses, or any nurse for that matter, with all of the things that are coming down the pike with AI, stops using clinical judgment, right? And I think we all worry about that today. And I think the virtual nurse is a key to that, because literally their jobs, our EICU nurses and our virtual nurses, is to watch over the patients to make sure there's not something going on. And when they pick it up and the bedside nurse didn't, like, give the bedside nurse time to do the right thing, right? But if they're not picking it up or identifying it, that's that mentor moment, right? That, do it in real time. You can go right into the room in real time. Hey, I never put in a NG tube before. Can you come in the room? I like review it with me ahead of time, and then come in the room with me, because then that's going to give me confidence, right? So I think it is important that the virtual nurses, if you ask me, what do they need more? Clinical experience or technology savvy? I would say clinical experience, because the way we did it at our organization is we wouldn't do rapid implementation of this. I advocated out the wazoo probably 55 million times. I said, no, you cannot put a camera on a pole and wheel it into the room, because the virtual nurse will be bothering the bedside nurse to fix that camera more than that will ever be successful. And so it took longer to have it go live, but it was worth it, and it was the right thing to do. So anyway, technology proficiency, of course, and it's more than just the EMR. It's the telehealth platforms you're using. It's data analytics, because they're the ones that are watching the deterioration index. They're now going to be watching our, what was it called? What was it called that we just saw? Yes, concern. Thank you. They're now going to be watching that, right? They're the ones that are going to like see probably the VPAs before anybody, right? So it's all of that. And then there's all these remote monitoring tools, right, that they have to learn. And then for communication, I love they coined it webside manner. Have you heard that yet? Like bedside manner, webside manner, right? So you can do all kinds. They now have newscasters teaching nurses and doctors how to have a good video presence, right? I saw a video and I was like prepping for this. It was kind of cute, but I was like, we're not gonna have time to watch it, but it's kind of cute. And they're basically saying, you know, what does eye contact mean? It's totally different now. I mean, you think about it, when you're on a Teams meeting, how awkward it is that you're looking at the camera and you want to be looking at the people, but and everybody is, so everybody's looking down, and you can't eat in meetings anymore because everybody's like really big in your face, like watching the food just down your face, right? So it's totally different. It's totally different. And we have to think about all those things. And I'm sure if you're doing virtual nursing, you've thought about them too. But how do you knock on the door, right? There's a doorbell. But then guess what? For EICU, the patients hated the doorbell because they're sleeping at night. So then you have to go in under night mode. Like they actually have like a night mode that doesn't have the doorbell go off because it's nighttime, right? Stealth mode. So all of these things we have to think about as we're designing the system and implementing them. So, and then of course, time management and organization. That was a big thing when we first rolled out inpatient virtual nursing. And I'll talk a little more about that, but our motto, we had them doing a lot. And so we had to go back and say, well, what's the priority? Is the priority that I'm in the interdisciplinary round so I can do all the follow-ups? Or is the priority that I'm doing the admissions and discharges? Like, which one do I do first? You know, all of that kind of stuff. So you really have to help them. And then obviously cultural competence is everything we do, problem solving, adaptability, mentorship and support, and then obviously ethical and regulatory awareness. And I have to say, I'm pretty proud of our nurses that were part of our early virtual nurse staff, because they thought of everything. Like they were even thinking about, can we get like a green screen behind us? Because originally we didn't have this huge elaborate space for them, and like people were walking by and like they're like, that it's not bothering the patients, but it's bothering us that the patients can see somebody walking behind us. So all of those kinds of things sound huge. Can the patient hear them? Can they hear the patient? What do they do if they can't? They have to call their phone in the room. All of those things you have to think about. All right, so I'm just going to talk briefly about some of the virtual care programs. We have about 10 minutes left. So some of the virtual care programs that we've done. So we always had Telesitter. We were using Abashore. We still are for now, for a couple more weeks, where you have to wheel it in the room and put it at the end of the bed. And so we're moving now, we centralized our telesitters into a huge command center. We're calling it the 6th hospital now, and I'm sure some of you have this too. And our 6th hospital is located in Pennsauken, and there's a whole entire floor that we built out that has our central staffing office, all of our EMS transport, our capacity management, our bed planners, for lack of a better word. And then on the other side, we have all of our EIC nurses sitting right next to our virtual inpatient nurses. And then we have our care after discharge nurses and our longitudinal monitoring nurses. And they're all in the same space, which is nice because then they can have somebody they can bounce something off of. And so our telesitters are going to be using the cameras in the room. So my project basically was perfectly aligned with EICU, and the EICU strategy included a 2-year rollout strategy of putting cameras in all of the rooms. So we did the whole RFP process, we brought all the vendors in, the organization made a selection, and we just finished putting cameras in all of the rooms of all 5 of our hospitals. So that kind of like laid the foundational work that needed to happen in order to bring all these programs to life. So our tele-ICU is night shift, and our inpatient virtual nurse is day shift. And that's because of where the support was needed. So if you think of our inpatient virtual nurse model started out with the nurses having, gradually going up to a 1-to-20 ratio. It was med-surg. They work 8A to 8P. And they started out doing admissions, discharges, education, critical tests, notification, and we wanted them to go into codes. That didn't work because they couldn't hear. Like we wanted them to be the code documenters, but there's so many people in the room that they couldn't hear. So we quickly kind of like said, okay, we're not going to do that. And basically doing all of those things. And the bedside nurses loved it because think about how long it takes a med-surg nurse to do an admission. Think about how that helps with throughput because now you don't care if the admission comes to you because you have help. Right. And then, so we piloted all that, we put them in Pennsauken, we rolled it out to the whole hospital. And then we had to pivot because now we need more FTEs. And so what they're doing to prove the ROI is they're focusing on the discharge process. And they've shown, and Christiana Care made this pivot. I saw an article when I was doing this. I know Ashna made this pivot because I meet with Ashna all the time. And they're reducing readmissions because they have the time to do the discharge instructions the right way, make sure the med rec is right, make sure they have all their follow-up appointments by 35%. So now we have the buy-in to roll it out across the system, which we'll be finishing doing. And then as nursing leaders, our plan is to say, great, we have the FTEs. How can we put some of the stuff back that the nurses loved that we had to then pivot? And it's the admission that they're missing the most. They want help with admissions. So that's kind of where we are with virtual nursing. And EICU, we did, we're using Epic Monitor. We built out all kinds of rules and logic. So they're really doing like surveillance of patients. They're doing rounding on patients. They're supporting the ICU nurses at the bedside. And then we do have physicians that are part of that program that do not live in the state of New Jersey. They live all over the place. And so we had to tackle all of that. Like, how do you get them onto the system, reliably and all of those things. So telesitter will be, and this is all through the cameras in the rooms. It's one camera. We talked about that earlier today. We don't want 10 million cameras. We don't want 10 million monitors. So the telesitters use the same camera, and all the virtual care team uses the same camera. The physicians, by the way, they have a workforce shortage too. So we expanded it to the physicians. They're doing virtual hospitalist consults now, so we can have virtual hospitalists. We've always had teleneuro consult. That's been a long, like we've all had that forever, right? It's not new. Teleneuro consults and things like that. We also opened a clinical decision unit in each of our 5 hospitals over the last year. And so that's all built with the ED module of our EMR. So they're ED nurses, and there's certain diagnoses that will go to our clinical decision unit. And they do use the virtual cameras for that too, if they need to have a physician come in from another campus and see them. So at a very high level, those are a lot of the inpatient models. And then for remote monitoring in the ambulatory space, we started hospital at home. How many of you do hospital at home? A couple of people in the room. All right, so I'll show you a quick video of, I don't hear.
But it's just now being launched in New Jersey. Hospitals at home, safe, high quality hospital level care to patients in the comfort of familiar surroundings, their homes. Advocates for older adults have long pushed the idea, and as Joanna Gagas reports, it could be a game changer for the future of geriatric care.
I like to be home. You know where everything is.
Sitting here in her comfortable chair, Betty Coyle is actually a patient at Virtual Hospital, where her care is provided right here in her house through a new program launched last year called Hospital at Home.
It was the perfect answer when we really needed an answer.
Karen Smith is Betty Coyle's daughter. When her mom developed a urinary tract infection along with COVID earlier this year, she had to be admitted to the hospital. But Coyle's dementia made just one night's stay extremely stressful and even dangerous.
She became more disoriented. She was requiring oxygen. She was trying to get out of bed. She pulled out 2 IVs. That was just one night. So the next day, the doctor offered this and we jumped on it.
The care at home meant Coyle could be monitored 24/7 using a band on her arm that sends her vitals right to the healthcare team at Virtua, along with twice daily visits from a nurse and regular telehealth appointments with her doctor, Diego Ortega.
They are much more comfortable in the home setting, and we've seen just incredible responses in terms of how quickly they're recovering compared to some of the more traditional brick and mortar building treatments. They are able to sleep much better at home, get that rest they need to improve quickly. Mobility is tremendous compared to being in a brick and mortar hospital where you're kind of afraid to get out of bed because an alarm might go off, and all you really want to do is just get to the restroom.
And they can be close to family for support. Dr. Raul Berrio helped to launch the home care program that started when the U.S. Department of Health allowed hospitals to offer at-home care to certain Medicare patients as a result of the COVID pandemic, an effort to keep more vulnerable patients out of the hospital. They've now learned that approach is improving outcomes in a multitude of ways.
We're able to eliminate hospital-acquired infections. With older patients, we're able to see that there's decrease in hospital-acquired delirium. Patients are in their own environment. They don't get confused. Patients with dementia, usually that happens when they're in the hospital. We're able to eliminate that.
Smith believes being home and around loved ones gave her mom a sense of control over her own healing when she had to be readmitted recently due to a leg wound.
But you could just see every day she was moving better. She was sleeping in her own bed. She knew everyone was coming in and out and visiting her. She just didn't feel sick. She felt like she had control over it to a degree.
But as promising as the results have been, right now insurance coverage for this program is only available to Medicare patients.
Yeah, that's not true anymore, just so you know. There's lots of payers now that are letting us do it. So let me just get back where I was. All right, so that's hospital at home, and you already heard all of the outcomes. I have 10 minutes, so I'm going to talk very fast now. So everybody, like, whatever you got to do, stay awake. Okay, so then we launched a care after discharge program. So if you don't, so really what we're trying to do, and I think we're not alone, I think a lot of organizations are doing this, is we're trying to stop looking at like episodes of care and try to connect care, right? So first, we want to prevent you from coming into the hospital in the first place if you are certain DRGs, right? So we have what we call a longitudinal remote monitoring program, right? And that's really like nurses that kind of look at data that patients send in through their MyChart, right? To flag that there could be something going on with the patient and then connect them to their primary care provider, right? Or a specialist or a pulmonologist or things like that. So prevent them from coming in the first place. If they do come in, even through our EDs, then we evaluate them. It's all built into our EMR. It's a big, huge project, right? We evaluate them to say, like, do you really need to be admitted? Or can you go to the CDU? Or can you go home on the care after discharge program, right? So you're discharged from the ED, but the care after discharge program, you actually get a kit and we're gonna like monitor you more. We're gonna monitor your blood pressure and those kind of things, right? So we really move towards these transitions of care and handing off from one place to another and like getting rid of that divide between if you're inpatient criteria, you need to be in the hospital, you might not be. You could go to hospital at home and then we can free up capacity in the acute care setting, right? And it's successful and the outcomes are good and the quality is good and the patients love it. Like these net promoter scores, I don't know if you geek out with patients out like I do, or have to, but I should say have to, but these net promoter scores are great. Patients love it. But think about the workflows that we had to develop. What happens? Like that cuff that the hospital at home patient had, the first time we were talking about it, they didn't have a way to continuously monitor ECG. Who do you think pushed that? Informatics, right? Hard, we had to push it hard, right? How are you gonna listen to their lung sounds? So you're relying on a med-surg nurse that's going out to the house. You're totally relying on her assessment. Is that okay? Maybe, I don't know, maybe not. So what's the digital stethoscope plan, right? Anyway, these are outcome measures and process measures that lots of organizations have used many or all of these. We've used a lot of these to try to prove the ROI and track the outcomes of these types of projects. All right, the only thing, we're not going to talk about all the AI stuff. I think we've had lots of great conversation today about AI, but I do want to mention two things. So one is the cameras in the rooms have LiDAR technology. That's what this is in this picture. So now we're starting to roll out use cases of, you can't see the patient's face, right? But it outlines everything in the room and the AI learns the behavior over time and then can alert our remote nurses or someone else if it's not something a nurse needs to do at their level of practice, right? I'm a big proponent of that. Just because they're virtual doesn't mean they have to tell you if the bed's low and locked. You don't need a nurse for that. We need virtual nurses to be doing what nurses need to do, right? Monitoring for deterioration, right? Those kind of things. But the different models that are being developed now, like you can tell if it's a movement that's going to be a fall or just a movement like I'm just turning in the bed, right? A lot of people are looking at this technology to say, can it tell us if it's time to turn a patient, right? Also staff duress, it can do a lot of that too. The other thing I just want to talk about with ambient and AI real quick is we are an early adopter of voice. Huge proponent. We published a study in 2020. You can read it. We've been working on it since 2018 with the vendors. The vendors are your friends. You need to talk to them. They need us to help develop stuff. We are the only ones that can. When we met with our voice vendor 8 years ago, they didn't even think about using it for nursing. Didn't even have a thought in their brain about doing it. So really important to make sure that we're involved in all of that. All right, so I just want to show you real quick, smart room of the future. Go ahead, Joanna.
Because I use Amazon AI. I'm going to show you a
The new Houston Methodist campus in Cypress opens on Monday, March 17th, and merges technology and medicine in a way that has never been seen before. Health reporter Haley Hernandez is joining us now to explain the AI hospital. Haley.
Isn't that so interesting?
Yes.
So this is really the first completely high-tech hospital featuring ambient listening technology and artificial intelligence. And I was one of the first ones to get a look inside.
Why don't y'all come on in? The brand new Houston Methodist Hospital in Cypress is AI powered. Here you have self check-in, remote monitoring of patients, service robots, and smart rooms.
There are no curtains in this place. There's a quick show of us.
We've got these big spacious hallways all designed with the idea of robots and AI technology coming in the future.
You'll also notice in this room, there are no telephones, because we have doubled down on voice to drive everything.
Hey Alexa, turn off the music.
The rooms are really designed for patients to have a more interactive experience, and you can ask the room to deliver complicated things like a summary of your chart for a family member who comes to visit, or something as simple as, hey, Alexa, turn off all lights.
Okay. If you need water, hey, my IV is beeping, I might want to use a device versus using my voice. So you can do either or.
The rooms are also equipped with buttons to immediately get doctors on a televisit, eliminating the wait time to meet with a specialist just because one isn't available at the hospital at that moment.
Voila, our virtual command center, which lives in our central hub downtown, allows us to kind of port right into the room, to see patients, to see it and move and directly zoom into where you need to be, how you need to be, et cetera. This has been years in the making.
People from Houston Methodist have been telling me about this hospital before I could comprehend what AI meant.
The technology enables them to better care for patients and helps us improve in overall quality, safety, and the experience that they're having when they come to Houston Methodist.
I think that's what people want to hear because they're afraid of AI taking away jobs. Did you guys have to address that a lot?
You know, here and there, people have questions, right? But the key is creating more efficiencies and taking the computer out from between you and I. So now I can walk into the room, say I'm a clinician, and just have a natural conversation. And then we have AI that'll pick up on the speakers and help document. So a lot of times clinicians are spending a lot of time documenting after visits. This creates efficiency. So documentation is happening as I'm just having a natural conversation with you.
The hospital says patient information will be confined within the room and is therefore kept safe and private.
Now, again, that hospital opens on Monday. They're opening with 100 beds and they have the ability.
Very excited for them. That'll be very fun. So just real quick. So Smart Room of the Future, I look at the things that are coming in Smart Room of the Future, and I really just want to take the picture we saw this morning of that innovation curve and how everybody is so excited. I want to say shoving down, right? All of the things that's coming. And I want to put underneath that curve a picture of the people who are taking care of our patients. And I want to put a protective bubble over it and just put clinical informatics. Because I honestly think that if there's anything that is needed right now in the world of healthcare, is for people to protect, literally protect the people that are taking care of our patients from having to drink from a fire hose. It's so much that we're putting on them. They have to be prepared. They have to have a voice. They have to have a seat at the table. And so this is the same thing that we saw before, right? It's the integration, identification, management, communication, right? Data, information, knowledge, wisdom. Without evidence in this space, the only thing we have to rely on is our wisdom, our knowledge, and the people that have it in the clinical world to be driving and leading these innovations. So, so many things have come our way that we've had to fight and advocate for, and we're going to have to continue to do that. Any questions?
I just wanted to say thank you to everyone, to our wonderful speakers for joining us today. And I think I introduced myself earlier, but I'm Lori, I'm the president-elect, just so you know. So I will be taking the reins from Robert next year, but it's still his show today. And please, if you see the QR codes throughout, I know we have them out on tables, but we need to hear about your activities for the Gold Distinguished Chapter, but we also need you guys to get involved. So many of you showed up today and we're so excited to see you all and to see the people online. And we'd really love to have your involvement. So please, even if you don't see the QR code out there, if you want to email us anytime, respond to any of the emails we've sent, you are welcome to do that. Reach out to us on social media and we will get back to you, and we would love to have your input. There's small jobs to do, there's big jobs to do. Whatever you have the capacity to handle, we have a job for you. So, and I have to say that it was so exciting to hear you talk about the virtual nurse because I worked on that work group. So with the ANA, so it was very cool to hear somebody present on it because I was just thinking back to all the conversations we had and yeah, the debate about methodology versus specialty, and it was very exciting. And we really did base it on the previous work about connected health. That's the principles came right from that. So, yeah, but thank you. So, that's it. Yeah, thank you so much.